Bismillahirrahmanirrahim. Sabah al-khair. Good morning, everyone. Before we start, I have a request, because this room is probably the most filled room with radiation oncologists, with two proper medical oncologists, Dr. 𝗷𝗀 𝗕𝗲𝗀𝗳 from 𝗕𝗲 Cancer Center, which is always part of us, and Dr. 𝗷𝗂𝗙 𝗕𝗲𝗀𝗧, who is the chair of medical oncology and the oncology at 𝗕𝗲 Medical City in Abu Dhabi. So please, let's do a quick picture and then we will start the conference. So let's just come here, we take a quick picture. This is the request of the medical oncologist. So please, because they were like, we've never seen so much radiation oncologists in one room. So. This is for you, Aida. So, okay, so Bismillah ar-Rahman ar-Rahim. On behalf of the Emirates Oncology Society and the Radiation Oncology Work Group, we'd like to welcome everyone. So, unfortunately, Professor Hamid is not here. He just arrived from Istanbul late evening, but he will be joining us, inshallah, in the opening ceremony. So just a quick reminder for everyone, this is Best of Astro. We'll talk more about it later during the opening ceremony. We really want to encourage you all to attend the whole meeting. There's a lot of nice abstracts. We want all speakers to please stick to time. A lot of our speakers are traveling tonight because they have work tomorrow. So please, each talk will be 10 minutes. 8 minutes will be talking about the slides and maybe 2 minutes QA. So I highly, and I appreciate if the audience, I know there are some dying questions sometimes you want to ask, but we can always ask them during break time. So without further ado, we'll start with the inviting the moderators for the first session. It's really a pleasure to have the 4 moderators early on morning. I have Dr. 𝗷𝗂𝗙 𝗕𝗲𝗀𝗧. She's the chairman of the oncology group, breast cancer oncology group in the Emirates Oncology Society, and the scientific chair of the Emirates Oncology Society. Very active, dear friend, MD Anderson graduate, breast medical oncologist. She has it all. We have our pleasure to have Dr. Noura Al-Hammadi with us. Dr. Noura has a lot of titles. All I know from them, she's the deputy CMO of more than 15 hospitals in Qatar, and she's the chair of the radiation oncology services and always advocates for her team. Dr. Maryam Aslani, she's a very dear friend, very smart and bright radiation oncologist, practicing in Mediclinic in Dubai, and she, her input is always great. And last but not least, we have Dr. Hikmat Abdul-Razik, who is the deputy chair, the CMO and the deputy of the King Hussein Cancer Institute, which is, for all of us who know and don't know, the largest and the most advanced cancer care, with all due respect to all our colleagues in the region. So thank you so much. We'll start with the first, maybe you want to introduce Dr. Tamer. So.
Good morning, everyone. Thank you so much, Dr. Ibrahim, and congratulations to you and the whole scientific team for this well-put-in amazing conference. So again, I'm a medical oncologist. I felt as an outsider when I first came, but I feel more comfortable now with my amazing radiation oncology colleagues. So without any further ado, I'm excited to chair this session with my amazing colleagues. And we'll start with our first talk. Usually, the amazing thing about radiation oncologists is that they're always on time with their presentation, and we've known that for a while now. So the first talk will be covering breast cancer. Dr. 🗲𗗀 I think he doesn't need any introduction. He is a professor of radiation oncology in Loyola, University of Chicago, and a prominent member of SARO Society. So please welcome Dr. 🗲🗀.
Sorry, I forgot my glass. Okay. Good morning, everyone, and thank you very much for joining us today. My name is 🗲🗀. I'm a radiation oncologist at Loyola University in Chicago. I treat primarily breast and GI malignancies. Today, I'm going to present. The screen stopped working here. Can we make it work? So today we're going to present a RAD-COMP study. It is a phase 3 randomized clinical trial of protons versus photons therapy for patients with non-metastatic breast cancer receiving comprehensive nodal radiation. This is the funding acknowledgement, and it was primarily supported by PCORI, through PCORI award. So as you may all know, radiation therapy plays a major curative role in the management of breast cancer. We know that radiation therapy definitely improve local control and in many occasions prolong survival in breast cancer. Seeing this proton therapy by reducing the volume of heart and other tissues exposed to radiation, primarily heart and lung, in the treatment of breast cancer has the potential to decrease the morbidity of radiation therapy compared to photon therapy. And that was the rationale for this study. It was based on the physics of a proton therapy beam, and at least on paper, dosimetrically, it looks like it should provide more sparing of the heart and lung. Prior studies have been small, non-randomized, with short follow-up. Our colleagues who treat GU malignancies, they started using proton therapy in 1979. The first patient who was treated with breast cancer proton therapy was in 2010. So you can see the difference. The rationale was that only a large prospective pragmatic randomized clinical trial in patients requiring comprehensive nodal radiation may answer if what we think the physics of proton therapy would help in any way patients with breast cancer. The primary objective of this study was to assess the effectiveness of proton versus photon therapy in reducing major cardiovascular events. Primary hypothesis is that for patients with locally advanced breast cancer, proton therapy will reduce the 10-year major cardiovascular event rate from 6.3% to 3.8%. This would require 1,238 patients. Our secondary objective is to assess the non-inferiority of proton versus photon therapy in reducing ipsilateral breast cancer recurrence or any recurrence. Also to assess the effectiveness of proton versus photon therapy in improving patient-reported body image and function, fatigue, and other measures of health-related quality of life and adverse event. And this is what we are going to present today. So remember, the study is still ongoing. It's close to accrual, but we are still do not have any data except for this one secondary endpoint that we're going to present today. The expectation that we're going to present the primary endpoint, which is cardiac toxicity and likely local control in 3 to 5 years from today. The other secondary objective is to develop predictive model to examine the association of radiation therapy dose distribution to heart and major cardiovascular event and health-related quality of life outcomes. This is the structure of the studies, and interestingly, the study required that the patient's insurance approve proton therapy before enrolling in the study. The study stratified patients based on their age, cardiovascular risk, surgery, mastectomy versus lumpectomy, and treatment laterality right versus left, which you would expect may benefit more. Patients were randomized 1-in-1 to proton therapy or photon therapy. The debate when they designed the study was to go with conventional fractionation or hypofractionation. The majority back then was using conventional fractionation, and they wanted a homogeneous cohort of patients. And that was the reason that we stuck with 45 to 50.4, which still kind of the standard of care in the US. I see this is changing very soon to hypofractionation based on the CHARM study and other studies. The study required in both arms that internal memory nodes be treated. The other thing that the study developed was the Picori Atlas, if you're familiar with this atlas. In this atlas, they actually included posterior triangle lymph nodes. So for those of you who treat breast cancer, not many people will use APPA field or lateral oblique field for the supraclav to cover the posterior triangle of the lymph nodes. Many of us would just have direct anterior field and they ignore this area. We never contoured it in our practice. Part of the reason they included this was to make it difficult for photon and make the proton a winner, which is nonsense. What was the eligibility criteria? Invasive mammary carcinoma of the breast in non-metastatic setting. Mastectomy or lumpectomy were acceptable, left or right side. Proceeding with comprehensive nodal radiation with the inclusion of internal mammary lymph nodes, which back then was not standard of care. Right now, based on the ARTC data and the RTOG data, we actually include internal mammary in pretty much every patient. Exclusion is the typical exclusion for breast cancer, prior radiotherapy to the ipsilateral breast or chest wall, scleroderma, and patient with contralateral, actually radiation was eligible. Okay, what are the methods? That's the tough part for me because I'm not very much into questionnaires and quality of life, but the primary health-related quality of life endpoints were fatigue, satisfaction with breast cosmetic outcomes, breast Q adverse events of radiotherapy, and FACT-B questionnaire. Secondary endpoints include FACET, which is, and those will going to be important when present the result, effectiveness of treatment, treatment was right to me, willingness to recommend treatment, willingness to choose treatment again, satisfaction with the effects, side effects were as expected. And remember, most of the patients enrolled in these studies really wanted proton therapy, thinking it's better, right? This was the only way for them to get protons, to enroll in this study, and their insurance may cover it. So if you design this questionnaire asking these patients who really wanted proton, If you do this again, if that was the right thing for you, you expect the answers and you know the answers before you even start the study. Just something to think about. And common toxicity criteria: adverse events, severity, interference, frequency of chest pain, and shortness of breath. It was collected for the short term. It was collected at baseline, 1 month, and 6 months post radiation therapy. The measure was previously validated in 𝗓𝗏 pilot study before we start the study. Repeated measures for linear and generalized linear mixed models were used to compare the impact of treatment on continuous and ordinal binary health-related quality of life scores. Sufficient power to detect a clinically meaningful difference was more than 0.33 in mixed effect models, assuming a correlation of 0.4 or higher. And as you might imagine, that's all written by a biostatistician, so I might not understand most of it. Okay, the study included 1,239 patients, randomized to proton 624, photon 615. The median age was 50, included women between 21 and 92-year-old. The majority of patients had mastectomy, almost 70%, 0 to 2 cardiovascular risk factors, 80%, left or bilateral breast cancer, 60%. Health-related quality of life completion rate at 6 months was 86%. Okay, this is the outcomes. And without even me needing to go through the curve, I know those are very small curves, but as you can see here, it's pretty much identical. So there is no difference in photons versus proton in most of these endpoints. There was no clinically meaningful differences by treatment arm in fatigue total score, satisfaction with breast cosmetic outcomes, which honestly kind of surprised me, because when I see the women who received proton therapy, I would feel, at least in my own experience, that their skin toxicity is higher. So it comes equal. Is actually interesting. Breast Q total score, trial outcome index, everything the same. However, interestingly, they found when they look at the common toxicity criteria that the shortness of breath, when they categorized 0 versus any shortness of breath, it favored proton. They ran a multivariate analysis. It did not validate these outcomes. So no, it doesn't make anything. There is no difference in that. However, the one thing that was statistically significant is the questionnaire, the facet questionnaire, which is like, do you think that was the right thing for you? Do you think proton is a miracle on earth? And yeah, sure it is, right? So willingness to recommend treatment, choose treatment again, and every other endpoint from the patients who underwent proton, they were happy with their decisions. So in conclusion, in the first randomized study comparing proton to photon radiation for breast cancer, health-related quality of life was excellent and similar between both arms, which is what we see in our daily practice. Differences favoring proton were noted in the facet items, but again, remember, we cannot unblind this study, right? We cannot make it a blind study. We cannot tell the patient you are getting photon and she's on proton, right? They know. So it comes with all the bias of those are patients who signed up for proton, who come especially for this, who signed for the study, hoping they will be randomized to proton. So I don't know how much data or conclusions we can get out of this. Local regional control and major cardiac events will be reported according to the study statistical plan in the future, which is planned 3 to 5 years. Thank you very much.
Thank you. Thank you so much, Dr. Tamer. We have for 2 minutes question. If there is any question from the audience, please.
Thank you, Dr. Tamer. The question is about the methodology of this randomization. Non-inferiority trial, basically, I will say it will be a positive trial because the design of it is simple. All of us know that proton therapy is non-inferior to photon therapy. So I don't think that from the principle, there's need to make this trial because it is obvious before doing this trial.
So let me say it this way. For non-inferiority, we always teach our residents that when you design a non-inferiority study, that means you don't need to come first. You can come second and we'll consider you first, right? But that's the secondary endpoint. And I don't expect, to be honest, it will be inferior. I think they are both effective. Um, Personally, I think the acute toxicity is much higher in proton than photons. Cardiac toxicity, I do not see in my practice 6% in photons having cardiac toxicity. So I am not sure if that's something we'll see in this study. The hypothesis 6% going down to 3%. We may see some better cardiac outcomes in left heart, left breast cancer. But again, whoever designed these studies, he did everything possible to make proton winner. So yeah, just to make it on.
Dr. Tamer, can I have a question here? Uh, since in this part of the world, we see breast cancer in a much younger age group. So the median age here is really 50 and compared to 60 plus in the West. So comorbidities when it comes to cardiovascular risks is are lower. As you just stated, we don't see that much of the cardiac event, the post-radiation therapy. So the question is, would it be possible to lower the number of randomized patients to select a higher risk patient, for example, rather than any newcomers for breast cancer, i.e., patient at higher risk for cardiovascular event will be randomized to proton versus photon in order to minimize the number of patients that you need to randomize and to make the difference meaningful, and the rationale behind doing the study is meaningful, but not to enter each and every newcomer for the study part of the study. Especially so, the cost is the difference is tremendous.
Correct. Cost, weight, list, many things. I'm sure that whenever they designed the study, they looked into this. But remember, there were many challenges to enroll in these studies, including insurance approval and the number of patients who are willing to drive to, like in Chicago, there is only one proton center serving the Midwest. Now we have two more, but back then it was only one, right? So they knew before they start this study that the cohort is actually limited. So if they add more limitation by like higher risk, like what I do in my current practice, if I'm treating bilateral chest wall and the anatomy is not favorable, and I think this patient will benefit from bilateral internal memory nodes, I send them for proton. And those are the ones that I see significant skin toxicity. But the majority of my patients, I'm very comfortable delivering photons, maybe using IMRT or VMAT. IMRT usually give me less scatter, and they are doing great. But yes, very valid point. I agree.
Maybe one last question from Dr. Rana.
Thank you very much for an excellent presentation. Just a very quick question. As you rightly pointed out at the start, that most people were doing conventional fractionation at that time. But in your experience, do you think that right now most people are using 5 fractions, possibly maybe 2 fractions in future? Do you think there will be a value of protons if it moves to 5 or even 2 fractions, or is it like dead?
So it's hard to say because we do not have any evidence. I would say the 5 fractions so far, at least, the evidence, except from one study from China, is only for breast treatment. All these patients received comprehensive nodal. So we do not use 5 fractions for those. We use at minimum 16 fraction. But even with 16 fractions, that's a higher dose. And in younger women, it makes sense. However, we might spare them some cardiac toxicity, but we don't know about the secondary malignancy with the higher dose of proton and PED. So it's like a double-edged sword. Okay.
Thank you, Dr. Tamer. Like,
they're clapping for you.
Like in your opinion, any category of cases that you would recommend to refer them for a proton?
Yeah, so as I mentioned, bilateral chest wall and treating the internal memory, or even like left chest wall, if it's a breast, usually it's much easier. But if you're treating chest wall and the anatomy is not favorable with breast hold and line RT or vision RT or whatever, I give myself an exit. I sometimes tell the patient, let me try. I feel very strong about your internal memory nodes, very large tumor, upper middle, and I'm not able to safely deliver radiation. I send them to proton, but those are really very few. Those are the exceptions, not the rule. Yeah.
Well, next would be Dr. Ibrahim Abu Ghida. Ibrahim, I know him very personally for quite some time. He was supposed to join us a long time ago, but you guys managed to get him here. Ibrahim is a well-trained radiation oncologist, both at AUB, Cleveland Clinic Foundation, and MD Anderson. And his talk will be about the standard of care systemic treatment with or without the stereotactic body radiation therapy, SBRT, and the management of patients with a newly diagnosed intracranial oligometastatic breast cancer. This is the prospective randomized trial. I was testing in my eyes also here with this.
You passed.
Uh,
So
Ibrahim?
you passed well. Thank you so much, Dr. Hikmat, for this kind introduction. So first of all, I really wanted to take this chance just to see the audience. So it's really great to see a almost full room early morning. And thank you for Tamer for giving this nice talk. I remember it was very difficult to accrue. I think Karen Hoffman, Chad, was the PI at MD Anderson for this trial. So it was very difficult. So the reason I'm presenting this trial is actually because this trial is coming from Egypt. And it's really give us great pleasure to see a trial coming from the Arab world presented at Astro as an oral presentation. And this is a very nice trial that was presented by Dr. Boutros. And the background is very similar in oligometastatic breast cancer patients with up to 5 metastases. We have very solid guidelines in defining what is oligometastasis, published by the Green Journal by Wendy Woodward as a senior author. And multiple trials have shown potential improvement progression-free survival with ablative radiotherapy for all sites, different cancers. But we do have some controversy when it comes to breast cancer, as we all know. So the objective, and I'm sorry, I'm going fast trying to make up for some time. The objective is to look at response rates, progression-free survival in breast cancer with oligometastatic disease, treated with a standard of care with or without SBRT. Secondary outcome is to compare the quality of life measure between those patients who were treated with SBRT. So this is for the sample size calculation and the power, calculation. But in methodology, this this study included women between ages of 18 and 70 with pathologically proven breast cancer, with PET scan staging done for all, with up to 5 extracranial metastatic lesion with a good performance status, and no pre-existing condition to prevent radiotherapy. It was 70-70, 1-to-1 ratio between the standard of care treatment versus standard of care and SBRT, with a follow-up PET scans and the quality of life assessment at 6 months. So the patients, as I mentioned, they were randomized into these two, and this is the dose and the dose fractionation they use for different sites. Moving on to the results, you can see that both arms are slightly well balanced between the standard of care and the SBRT arm across all groups. And the response, when you look at the response rate between complete and partial, interestingly also was quite similar. So the response assessment was not very much difference between the SBRT and the standard of care. When you look at the primary endpoint, the progression-free survival, unfortunately, this trial was negative. It did not show any difference between the standard of care and the SBRT. And the patterns for failure, you can see that those who had an SBRT, their failure at the index site was much less, but most of the failures happened at distant sites rather than at the radiated site, as we can expect. When we know that bone metastasis only might have slightly different than visceral and bone metastasis, you can see that the response rates with the SBRT compared with the non-SBRT arm, complete response, actually no difference, partial response, no difference, stable disease, no difference, and progressive disease, no difference. So there is no difference between the standard of care and SBRT, even in bone-only disease. Also, these are the curves showing no difference between the SBRT arm and the standard of care. Interestingly, when they did the quality of life questionnaire, patients who received SBRT had better quality of life outcome than those patients who did not, which don't ask me this, I'm still struggling to understand how, and I'm happy to get any conclusion, but we're waiting for the full paper. So in conclusion, again, this trial showed that SBRT, in addition to systemic therapy, did not show improvement response rate in progression-free survival in patients with de novo extracranial oligometastatic breast cancer. We know from the AVATAR trial there is some positive data on oligoprogressive disease in ERPR positive, on CDK4/6 inhibitors, and the MDT using SBRT was associated with better quality of life measured at 6 months from treatment. With that, I'm going to stop here. Maybe we have some time for question, and then we'll move to the next session. So thank you so much.
Can I start with the
Please.
first question? Thank you so much. Actually, I'm a big fan of oligometastatic disease and the management, and we are working on the paper also together. So what do you think, like the weakness of this? Because you would expect at least to see maybe PFS benefit. I know that data has been debatable. I mean, conflicting results across different studies. So what do you think the weakness of this trial?
Yeah, so first of all, yeah, again, the strength is coming from Egypt, so that's the nice thing about it. The weaknesses, of course, is the number of patients, the follow-up duration is short, and the we know from the NRG trial, which is very bigger trial, phase 2, they didn't move to the phase 3, that these patients did not show improvement. So we know the results of this. Yet, I think we are still, and we know from Dr. Tang's trial, from the extent trial, from MD Anderson, also it was negative for breast. It was positive for other sides, negative for breast. Now the question is, why are we seeing this? We have always assumed that breast behaves like prostate. We see a positive results in lung, we see positive results in prostate, and unfortunately we're only able to prove that local therapy might be beneficial in patients with an oligoprogressive disease in ERPR positive only. I think also the heterogeneity of patients. We know breast cancer, I mean, triple negative or HER2 enriched is completely, it's a different cancer than ERPR positive HER2 negative breast cancer. And we know that breast cancer in the premenopausal is different biology than in postmenopausal. So there's a lot of details. So I think if you want to get a clean trial, the best thing is to do what they did in the AVATAR trial, is to select those patients with only certain biology and study those. But lumping all breast cancer patients, and this is one of the weakness, in my opinion, in NRG, because they lumped them all in one bunch. And we know breast cancer is a very heterogeneous disease. Even in metastatic, when I was in Houston, we used to biopsy the metastatic site because you see different biology as well between the primary site and the metastasis site. So that's another thing. And finally, and this is what I was having a chat with Dr. Tang yesterday at the evening, is that I think the definition of oligometastatic is old now. I think we should start looking more at circulating tumor cell DNA, looking at the blood markers rather than imaging, because I can interpret a PET scan as positive. Someone else might tell me this could be inflammation. Someone, we're not sure. And we came up with a definition of 5 sites. We know that patients maybe with one side with high ctDNA, at least in other primaries, behave much worse than patients with 5 sites and low ctDNA. So we should probably start being more smarter in defining oligometastasis, and that's what they.
Thank you.
Yeah. Questions? Yeah, Dr. Issa. Pain.
Should be local control.
Yeah.
Rather than in the targeted lesion, rather than event-free survival.
I totally agree. And I think sometimes pain, pain control, if it's bone metastasis, if there's pain.
Pain control for spinal and bone, and the skeletal related events.
Yeah, I agree.
I think if they choose bony metastasis and they just looked at local control and the skeletal related events and pain control, it would be a successful trial.
Agreed.
The second thing, I don't think any one of us would order PET CT scan to evaluate the response after stereotactic. We know from our practice that even in highly controlled lesion for many years after SBRT, we still see some uptakes in PET CT scan. So I think PET CT scan is misleading and don't give us the correct information about local control following stereotactic.
Agreed. Agreed. Okay, Dr. Ibrahim.
So probably another point, I think some patients will benefit. We will have progression-free survival if we take the patients, the good responders, and use local SBRT as consolidative rather than curative. What do you think of that?
Yeah, I mean, this is, the best evidence we have is from the AVATAR trial, and this is after we consume systemic therapy in the setting of oligoprogressive disease or oligopersistent disease. We still get these young patients, as Dr. Hikmat mentioned, who, we feel like we want to offer them everything, including, local control with surgery, radiation, SBRT. I tend to rather have them, if we have a trial open, to put them on a trial which is specifically for that. We know that we counsel them in the clinic. We tell them, the NRG is negative, but the NRG, as I mentioned, had a big group of patients. I think after 5 years, we'll be redefining oligometastasis based on tumor cells, we'll be selecting. 5 is not a magic number. You can have 7 with a low ctDNA, I would still treat you. But you can have 2 with a very elevated ctDNA that is still elevated after SBRT, then we probably have not done a lot. But the nice thing about SBRT is it's not toxic anymore. I mean, we're able to treat it with very high precision, low toxicity. We rarely see major complication if we follow the guidelines. And our medical physicists and the engineers are doing a good job in allowing us to do so. But it's unfortunately the data is not to our favor as of now.
Rahim, can I ask another question? I know it's an abstractory format and you probably will know details about the study, but do you know what was the standard of care? Because standard of care can be very variable, especially so that only 140 patients were randomized. And the question is, how long did it take them to randomize those patients? If it's over a couple of years versus 10 years, because the standard of care is very variable. And that can explain. One last thing I was telling Aida, I was expecting you guys to invite the authors to the meeting to discuss this. This is very interesting. And this is probably one reason to hold a regional kind of a clinical trial rather than just a collaborative effort that would really make a difference with a lot more patients to be enrolled.
Inshallah, we're working on this. Dr. Hekmat, Dr. Isa is very aware of this. And yeah, I mean, Dr. Boutros has moved to the US and would love to have him here, but inshallah we'll have it. Yes. He's in Bahrain, actually. Yes, you're right. So we have Dr. Zainab. She can represent him, but we'll ask him next year. Thank you so much, everyone. Thank you.
So much. I think we'll move on to the next session. The moderators, Dr. 𝗿𝗂𝗓 and Dr. Ibrahim 𝗓𝗂𝗓.
Thank you so much for this great organization. We'll start with the first talk with Dr. Majid Al-Ghamdi, who's a very dear colleague and friend. Dr. Majid is a consultant radiation oncologist at National Guard Hospital in Jeddah. He's also the president of Saudi Association for Radiation Oncology.
Thank you very much, Dr. Ibrahim, Dr. Saif. Thank you very much for Dr. Ibrahim 𝗿𝗂𝗪 for organizing this, and Prof. Hamid, Dr. Tamer, and my colleagues from SARO. So finally, after 2 negative studies, now we will come to finally a positive radiotherapy trial. And I think it's very important and practice changing, so that you better pay attention to this, I guess. So how can I move it? So this is a trial out of Dana-Farber in the US. And the primary investigator, Dr. Ayel Azir, and her colleagues. So they're out of Dana-Farber Brigham and Women Hospital, and this research was funded by the industry. So that's the trial. So the background of this trial is that we knew a few years back that whole brain for brain metastasis is very detrimental when it comes to the cognition. So whole brain has a very important impact on the cognition of those patients in the short term at 6 months. And this is very significant and consistently was shown in multiple trials. And then the local control was not that much better than stereotactic radiation. And these sample of the trials that included WBRT, and again, it does not increase survival, but rather it actually results in consistent decline in the neurocognition, and also in some trials the quality of life. So then we came up with the hippocampal avoidance technique. So now we improved our standard whole brain because we know it does cause cognition problem. And then we came up with a hippocampal avoidance technique, which you are all aware of this. This is the NRG trial that established hippocampal avoidance for those candidates for whole brain as a standard of care, except those who have leptomeningeal disease and involvement of the hippocampus, etc. And the neurocognition was much better when you do the hippocampal technique. And of course, in the NRG trial, you have to add memantine because it was independently important in preserving neurocognition, independent of the hippocampal avoidance. So when you combine both, you kind of improve the neurocognition much better. So this trial was, okay, now we know that we adopted the stereotactic radiosurgery for those patients with brain metastasis to avoid whole brain, because we know it's bad. Now, actually, and all the studies that established SRS as a standard of care use the rationale of bad reputation of the WBRT in terms of neurocognition. So when they came up with the hippocampal avoidance, the same question came back to us. Okay, so what if we do whole brain, but now with hippocampal avoidance? So what is the benefit of a stereotactic? So again, at least three well randomized and well done trials, modern trials that established SRS as a standard of care for up to 4 lesions compared to WBRT, and their primary endpoint was neurocognition, all of them. So this is the trial came to answer this question. If we can protect the neurocognition with the whole brain, so what is the benefit of a stereotactic? Let's do whole brain hippocampal avoidance for all of our patients, more than 4 lesions. So the randomized patients with 5 to 20 brain metastases, because nowadays it's very hard to treat anybody with whole brain if he has less than 5 lesions. So they kind of came with that reality that we cannot recruit patients to give whole brain, even though with hippocampal, if they have less than 5. So they started from 5 to 20 brain metastases, randomized into SRS or SRT. If the lesion was a little bit bigger, then they would go with the fractionated SRS. And the standard arm here, it is the hippocampal avoidance whole brain, and the investigational arm is SRS SRT. So they included all solid primary cancers except small cell lung cancer, 5 to 20 brain metastases, adult with good KPS. I mean, those who were ineligible included those who had brain radiation for any reason before, or leptomeningeal disease, renal disease, etc. And then the radiation, basically it was central credentialing. They used VMAT for the SRS arm, 1 to 3 isocenters. Most of the stereotactic was performed on LINAC. The dose is 16 to 20 for the single fraction. And then the SRT was 30 and 5, except those who had resection of the cavity, and then they received 25 and 5. Hippocampal avoidance, they followed the NRG CC001 protocol, which established how we do nowadays the hippocampal avoidance whole brain. They use the same dose constraint, etc., and they added memantine as well. So it was investigator-initiated study supported by various medical systems. They started in 2017, and basically, so that's all from here. Yeah, the quality of life using MD Anderson brain tumor questionnaire was the primary endpoint in this study, and they have a bunch of secondary endpoint, intention to treat. So these are the secondary outcomes, performance status in terms of the functional ADLs, neurocognitive function, etc., using other tools. Survival based, they used overall survival as a secondary outcome, etc. So again, this is the chart. These are the patient characteristics, pretty much balanced. Most of the patients were breast, melanoma, and non-small cell. In terms of the baseline characteristics, symptom-wise and extracranial metastases were well balanced. Same thing for the dexamethasone. So, this is the primary endpoint that they reported on or they presented on. So the MD Anderson brain tumor symptom severity and symptom interference. And these two tools are probably the most widely accepted as the current modern tools for brain metastasis, for brain tumors in general, including brain metastasis, in terms of the local effect of the tumors on the quality of life. It's pretty long questionnaires that has from general quality of life to specific symptoms that they ask for related to the brain tumors themselves. So if you look at the baseline here, there was no difference between the two arms on the symptom severity. And then when you look at the post-baseline minus baseline, so the change, in fact, comparing each arm to itself, and then they calculated the difference in each arm from the baseline after treatment minus baseline for each arm, and then they compared the two arms to each other, the difference, they compared it to each other, and then they came up with these numbers. So there was a significant difference between the change from the baseline comparing the two lines, the two arms in favor of a stereotactic radiosurgery for these patients. Same thing exactly happened with the symptom interference with the ADLs and everything. So this is the primary outcome. It is met, and that's where we're at now. Again, this is just to show the primary outcome here based on patient characteristics. So the secondary outcomes, performance status was better with the stereotactic radiosurgery. Ability to complete ADLs was also better. Neurocognition function measured through the Hopkins Verbal Learning Test. It was also generally better with SRS. These are the curves. Overall survival, there's no difference between the two arms, as well as the neurological death. Intracranial control there was difference, but this difference between the intracranial control when you compare the whole brain versus stereotactic, because we know that the cumulative recurrences in the brain is more with the stereotactic, but those are salvageable. You can go back and do a stereotactic. Local recurrence as well local recurrence was more in the lesion, in the treated lesion was more with whole brain. So you're better with SRS for local recurrence, but for regional recurrence in the brain, whole brain is better. Leptomeningeal disease was pretty much similar between the two arms. Salvage therapy, time is up, so I'll go through this quickly. The necrosis also, it was not statistically it was not very high. It was deemed acceptable in the arm of stereotactic, although there was a good difference between them in terms of the radiographic necrosis. Same thing with the symptomatic necrosis, but it was still less than 10% of those who had 20 lesions treated with a stereotactic that they developed symptomatic necrosis. So the key takeaways: a patient with 5 to 20 brain metastases experienced less symptom burden and interference with daily function with SRS-SRT compared to the hippocampal avoidance whole brain without compromise of survival. Hippocampal avoidance whole brain minimizes the likelihood of development of new metastases, but achieves poorer local control than SRS. And salvage whole brain uncommonly required after SRS because we keep doing SRS for the new lesions. SRS-SRT now represents the radiotherapeutic standard of care for most of patients with 20 or fewer brain metastases. Thank you very much.
Thank you so much, Dr. Majid. For the sake of time, probably allow one question, one burning question. Dr. 🗿𗗀.
you, Majid, for the presentation. My question is about the extracranial disease. So when do you choose your patients? For example, the patient has diffuse mets or, for example, post-chemotherapy, but then progression. So when do you choose your patients for the stereotactic? Thank you.
Well, this study, I don't think they looked at the extracranial disease. So they included everybody who is eligible. It was not in the ineligibility criteria to exclude those who have who have uncontrolled primary disease elsewhere outside the brain. But in reality, yes, actually, if the patient has no systemic options, deteriorating very fast, uncontrolled extracranial disease, I wouldn't probably be kind of pushing to treat 20 lesions with SRS. But what we are seeing nowadays in the clinic is that we are seeing more of those patients who survive long, who do well extracranially because of the improvement in systemic therapy, whose performance status is very good. So I wouldn't go with whole brain. Even before this trial, we were kind of pushing for stereotactic for multiple ones. But now we have this evidence to justify this.
Thank you.
Okay, thank you very much. It's an exciting topic. Definitely worth more of a discussion. However, for the sake of time, we need to move forward. It's my pleasure to present the next speaker, Dr. Bassem Youssef, who is an associate professor of clinical oncology at the American University in Beirut, who will be talking to us about the effects of tumor treating fields after stereotactic radiosurgery in patients with non-small cell lung cancer, the final results of a phase 3 study.
Good morning, everybody. It's a pleasure and honor to be here. I want to start by thanking the organizing committee and my dear friend, Dr. Ibrahim Abu-Gheda, for the invitation. This is the title of my presentation, Tumor Treating Fields After Stereotactic Radiosurgery for Brain Metastases from Non-Small Cell Lung Cancer, Final Results from the Phase 3 METIS trial. These are the disclosures. So local therapy for non-small cell lung cancer brain metastasis include resection, SRS, and whole brain radiotherapy that we usually try to avoid at all costs to decrease toxicity. Delaying intracranial failure while preserving neurocognition is an unmet therapeutic need. TTF fields has improved overall survival in phase 3 trials, including metastatic non-small cell lung cancer, GBM, and locally advanced pancreatic cancer. And it has been FDA approved in the management of metastatic non-small cell lung cancer, mesothelioma, and glioblastoma. The pivotal phase 3 METIS study was designed to evaluate the efficacy, safety, neurocognitive, and quality of life outcomes for TTF fields therapy following SRS for patients with non-small cell brain metastasis without known actionable mutations. Now, what are TTF fields? These are electric fields that disrupt processes critical for cancer cell division and may lead to enhanced downstream anti-tumor immune response. It is delivered non-invasively to the brain via a portable device that consists of a field generator and arrays placed on the skin. Different cancer types respond to different frequencies of TTF fields. For example, 150 kilohertz for non-small cell lung cancer, 200 kilohertz for GBM. This is the trial design. So it included patients with 1 to 10 brain metastasis from non-small cell lung cancer, and patients were randomized 1-to-1 to either SRS alone or TTF fields that were offered after SRS. Patients were followed up every 8 months, and eventually the patients, they received another, they were kept on TTF fields even after the second progression, and then it was stopped. So these are the key inclusion criteria. Patients ought to have a life expectancy more than 3 months with a KPS more than 70. They excluded patients with known somatic tumor mutations, including ALK, EGFR, ROS1, and BRAF mutations. Eventually, the study enrolled patients between 2016 and 2023 from 78 sites in 13 countries. The median follow-up was around 50 months. So the primary endpoint was time to intracranial progression. Secondary endpoints included time to neurocognitive failure, overall survival, and radiologic response. Exploratory endpoints included intracranial progression rates, quality of life, and time to distant intracranial progression based on IRRC analysis. When we look at the patient disposition, eventually 129 patients were treated with SRS plus TTF fields versus 158 patients with SRS alone. When we look at the baseline characteristics of the trial, both arms, the characteristics were well balanced between the two treatment arms. When we look at the TTF fields treatment, the median exposure was around 15 months, and the median monthly usage was 67%. Around 59% received immune checkpoint inhibition in the SRS plus TTF versus 71% in the SRS only. When we look at the results, TTF fields therapy following SRS significantly delayed time to first intracranial progression with a statistical p-value of 0.044, which translated into 28% relative risk reduction. TTF fields therapy following SRS reduced the risk of intracranial progression up to 24 months. There was no interarm difference in terms of overall survival, time to neurocognitive failure, or radiologic response rate. TTF fields therapy following SRS prolonged time to distant intracranial progression, although the p-value was not statistically significant. When we look at the patients who were treated with immune checkpoint inhibitors, the effect of TTF fields was more pronounced, and it translated into improvement in both time to first intracranial progression and time to distant intracranial progression, with significant p-values for both. When we look at the incidence of adverse events, it was similar between the two arms. One exception was for skin toxicity, which was more pronounced in the patients who received TTF fields therapy. When they looked at the impact on quality of life, TTF fields therapy did not worsen the quality of life for patients. When they looked specifically at the deterioration-free survival, the patients on TTF fields had significantly better outcomes than those who received SRS alone. In conclusion, treatment with TTF fields therapy following SRS significantly prolonged time to intracranial progression, which was the primary endpoint in patients with non-small cell lung cancer brain metastases. Time to distant intracranial progression was also delayed, although non-statistically significant. Effectiveness of TTF fields following SRS was more pronounced in patients who received immunotherapy. TTF fields after SRS was not associated with worsening of neurocognitive function nor quality of life. The safety profile of TTF fields therapy was consistent with that seen in other clinical trials, which mainly include skin reaction. And then by prolonging time to intracranial progression without causing deterioration of quality of life, TTF field therapy after SRS is a potential new treatment option for patients with non-small cell lung cancer brain metastasis. With this, I thank you for your attention.
Hey, thank
Any
you very
questions?
much for the excellent talk. TTF is always an interesting area. I'm not sure, maybe as a quick show of hands, who knows at their center if they actually do TTF or not? Okay, we have only one center where they use TTF, so not a very common area of practice. For GBM patients, yes. Okay. So we have some time for discussion if anyone has any questions.
So thank you so much, Bassem, for this great talk. So did they report the quality of life on those patients wearing the Optune device versus those are not? Because I remember when I was before, when I was in the US, a lot of physicians who prescribed it, usually radiation oncologists who prescribed it, the patient's quality of life was not that great because you have to wear it for 18 hours, you have to shave your head, sometimes it gets itchy. So it wasn't something that patients really enjoyed. Yet they're able to accrue that much patients. So what do you think on, did they report the quality of life in this trial?
Yeah, so as I mentioned, in this trial specifically, there was no deterioration of the patient's quality of life as per this trial. But practically, from the patients who were treated in GBM, the patients were reluctant to use it because of the inconvenience of the treatment. So as you said, they have to wear it at least 18 hours per day, and they have to consistently use this device. An additional problem was that all of these patients had to have their scalp shaved, and it also caused some skin reaction. So practically, like on trials, most of the patients used it, but in real world, some reports show that 1/3, maximum 50% of the patients did use these TTF fields. Again, in our country, we don't use it. And as I saw from the raise of hands, it's not commonly used, at least in the Arab world.
So the interesting thing about TTF that they never run a study and it's negative for whatever reason. So that's a disclaimer. I was their PI in the study, local PI for pancreas at Loyola and mesothelioma, La Luna. I mean, it's a horrible quality of life for most patients, right? To be connected to the device 18 hours a day. They have their tracking number where you know exactly how many hours the patient use it. None of them really comply with the 18 hours a day. But they are always positive for whatever reason. So it's an interesting device, let me say that. Yeah. And yes, they do not have representation in most of the Arab world for whatever reason. So, yeah.
Thank you very much.
Thank you very much.
So we'll move on to next speaker, Dr. 𝗿𝗱 𝗕𝗲. He's a well-known radiation oncologist in our region from Iraq to Canada. He is attending staff and associate professor, British Columbia University. And he will be talking to us about the efficacy of hypofractionated stereotactic radiotherapy with different dose fractionation regimens combined with concurrent Avastin and recurrent high-grade gliomas.
Thank you for the kind invitation. Thank you for the chair. So my presentation today is to, it's about efficacy of hypofractionated stereotactic radiation therapy with different dose fractionation schedules combined with the concurrent bevacizumab in recurrent high-grade gliomas, a randomized trial from China. Similar to the investigators, also I have no conflicts of interest to disclose. All of us know that the gliomas are the most prevalent malignancies of the CNS, and high-grade gliomas have a high incidence of recurrence and a poor prognosis in general, especially GBM. Hypofractionated stereotactic radiation therapy and bevacizumab represents a promising treatment strategy for recurrent high-grade glioma, and the optimal dose fractionation of of the HSRT remains undefined. So these are some of the previous reports. Usually, like for the recurrent high-grade glioma, we use 30 in 5 sessions, and but like in the literature, there are some group use 35 in 10, and some group use 27 in 3. So just this is the background about the fractionation protocols, 27 in 3 versus 30 in 5 versus 35 in 10. And they are like trying to answer whether if we will do a randomized trial, whether we will get a higher objective response rate in the high dose per fraction versus low dose per fraction. It's a phase 2 trial. The aim is to compare the efficacy and toxicity of the HSRT 27-3 versus 30-5 versus 35-10 plus bevacizumab, and to see which arm is better than the other one. The sample size is 102 patients, 34 in each arm. It's randomized by one, and the power is 0.05. Eligibility criteria: adult patients with recurrent grade 3 or grade 4. Size of the tumor is enhancing target lesion less than 3.5 in 1 dimension. And the radiation interval between the first radiation and the second radiation is 6 months and above. Karnofsky 60 plus, and adequate visceral functions. And the exclusion criteria: if there are more than 3 recurrences, and received radiation to recurrent disease, and the tumor is within 5 millimeters from the brainstem, or infratentorial leptomeningeal, and autoimmune disease. Again, these are the literature about the contouring of the GTV to PTV margin. Usually there is no CTV in the re-irradiation era. So our practice is to do the GTV plus 2 millimeter margin. If I am treating with the CyberKnife, I may put it as a 3 millimeter if I will treat with the LINAC based. In this trial, they contour the GTV with a 3 millimeter expansion, and it's the same principle of contouring in the 3 fractionation. And all the patients will receive bevacizumab on the first day of radiation therapy and repeated every 14 days till disease progression. And the dose of the bevacizumab is 10 milligram per kilogram. The assessment and follow-up based on the RANO criteria, it's an objective response rate. And also they assess the toxicity based on the CDC criteria. The endpoint, the primary is the objective response rate, and the secondary is the 6 months of progression-free survival and the overall survival and treatment-related toxicities. As we mentioned, it is 102 patients. The median age is 58 years. Follow-up median is 11 months, and they are balanced in the baseline demographics and the clinical characteristics. These are the patient characteristics. All of the criteria are almost comparable between the arms. The average time between the initial radiation therapy to the second irradiation is about also comparable, around 12, 14 months. And the tumor volume is a relatively small volume in terms of the median tumor volume, but sometimes it can exceed. The objective response rate, the first 2 arms are better than the third arm, which means that the high dose per fraction is probably producing better objective response rate. However, for the overall survival, there is no significant difference in between the three arms. And this is showing the progression-free survival and the overall survival. The progression-free survival is better in the first two arms, the 27-3 and 30-5 compared to 35-10. The overall survival is comparable between the three arms. In terms of toxicity, grade 1 and 2 toxicity is more with the high dose beta fraction, but there is no difference in grade 3-4 toxicities. And the toxicity usually is a little bit more of fatigue, loss of appetite, nausea, vomiting, headache, and insomnia. Alopecia. For grade 3-4, there is no difference in between the three arms. So potentially the important prognostic factors that the high dose beta fraction, the 27 or 30-5, 27-3, probably better than the 35-10. Those who are younger than 57, better. Male, probably better. For grade 3 versus 4, 3 is better. Tumor volume, it seems that they mentioned here in the opposite sequence, less than 7 centimeter is better than more than 7 centimeter. Karnofsky, for sure, the better who have higher Karnofsky, and the time, for sure, those who are like presenting with more relapse between the first and the second radiation have better prognosis. And in the multivariate analysis, the progression-free survival, those with the high grade is less, high volume less, also low Karnofsky is less and significantly influence the progression-free survival. And those with the overall survival, the tumor grade and the age and time for the initial radiation therapy to high dose stereotactic radiation therapy was associated with overall survival. The significance of this study, it is the first randomized controlled trial, but the limitation that it is from single institute and relatively small sample and longer follow-up is required. In conclusion, for the treatment of the recurrent high-grade gliomas with the high-dose stereotactic radiation therapy combined with concurrent bevacizumab, those with the higher single fraction dose like 7-3 or 30-5 demonstrated improved overall, objective response rate and progression-free survival compared to those with the lower single fraction dose 35-10. And thank you for the attention.
Thank you so much, Dr. Layth. You are perfectly on time. We'll have time for one or two questions, Dr. Eric.
Yes.
Thank you very much for the great presentation. My question is related with the targets. As far as I understand, the stereotactic radiotherapy or hypofractionated radiation was delivered to the contrast-enhanced lesion, but not to the flare, where we generally believe that flare is really showing us the real tumor volume. What's your perspective in that? I mean, when you see a patient with a recurrent or progressive tumor in follow-up, what do you cover and what to where do you prescribe your dose?
So, like, it's case by case basically, and there are many factors playing on the decision of re-irradiation. And the practice usually is to, like in our practice, is to offer, for example, after presentation in the multidisciplinary round whether to go with the systemic treatments like bevacizumab alone, or re-irradiation alone, or the combination of both. So all the three options are valid depending on patient circumstances, and whether you have it like fully funded or not depend also, like this is another factor, because in Canada not all of the like lines are available and funded by the health system. So most of the patients, like after discussion at the multidisciplinary, and if we will proceed with the radiation therapy, I will proceed with the just contouring the enhanced region with a 3 millimeter margin. And my practice is using 30-in-5.
Thank you.
Yes.
Last question with Dr. Rana. It's only because it's you. Huh?
Just a very, very quick one, because the GBM is just a horrible tumor. And recurrent GBM, we all know in this room that this is a palliative situation, although we are applying radical dose. So in England, we call them palliative now. So I think I agree that flare versus enhanced, I will go for enhanced because at the end of the day, it's a palliative approach. And I just wanted to highlight the fact that again and again, we fail to show any advantage of really bringing more and more intense radiation in recurrent setting. I think we need to focus much more on the molecular understanding of this tumor and look for help from the medical oncology colleagues to see what if they can have something to offer for these patients. This is not the first time we have seen that really there is no point to be aggressive in a patient who is relapsing within a year from GBM.
Yes, I agree with you. And also, like in other studies, those with the IDH mutant showed a better response for the re-irradiation. Those with the co-deleted PQ19 also showed a better response for the radiation therapy. So the molecular oncology nowadays is changing the paradigm for the treatment. It's for sure, yes.
Okay, thank you so much for the very interesting session. So I'd like to move to the next session, please.
Dr. Yusra, Dr. Khatib, of course.
Moving on to the next session, it's a privilege to welcome Dr. �11 𝗕𝗲, very accomplished radiation oncologist, currently the consultant head of Department of Royal Hospital, Oman. Let's move on with the next presentation. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Dr. Ibrahim, for the invitation, and thank you to the Best of Astro team for the organization. My topic today, sorry for my voice, I just had flu. So my presentation is about the quality of life and the 5-year long-term organ preservation in the early rectal adenocarcinoma, and this is the final result from the OPERA trial. For the non-GI rad-onc, just pay attention, OPERA is different than OPERA. So the OPERA, it was mainly for the TNT, including external beam radiotherapy only, while OPERA with E, it is mainly for contact brachytherapy. So what is contact brachytherapy? Contact brachytherapy is a unique RT technique which delivers high dose radiation, about 30 gray per fraction. It was pioneered mainly by Papillon and Lyon 1970. And the first randomized trial was published by JP Girard in Nice 2010, where it showed that 85% of the selected early rectal cancer can have organ preservation. So what is contact brachytherapy? So contact brachytherapy is a machine that delivers about 50 kV with sharp dose fall off, about 50% in 5 millimeter. So here we are using contact with the applicator. It is not with needles. And the position of the patient usually knee, chest, or lithotomy position. So it is very precise treatment and also adaptive, because with each fraction you can change the depth. It is indicavitary 30 gray per minute, fast and simple, and can be done in the OPD. So the idea of organ preservation was introduced first by 𝗕𝗲𝗪, where watch and wait achieved like 47% of the organ preservation in rectal cancer. But the first trial was the phase 3 OPERA trial, where they were looking for organ preservation. So the patients randomization, they chose patients operable T2, T3A, B, and should be less than 5 centimeters from the anal verge. Lymph nodes up to 8 millimeters were included. The control arm was mainly external beam radiotherapy with a boost of 9 gray with concurrent capecitabine. The experimental arm was mainly with the contact brachytherapy. So they divide the patient into tumor less than 3 centimeters from the anal verge, and those will receive the contact brachytherapy first, followed by the external beam radiation with concurrent capecitabine. And more than 3 centimeters, they will receive the pelvic radiation, followed by the contact brachytherapy. So patients who have a partial response, they will go to the surgery. Patients who have near complete response or complete response, they will go for watch and wait. So this study started in 2015 till 2020, included 141 patients, mainly in France and UK, and there were 8 departments using the Papillon machine. So the result, as you can see, first, here is the 3 years result. So the 3 years result showed that the rate of organ preservation, of course, was higher with the contact brachytherapy, 81% versus 59%. And those patients who have tumor less than 3 centimeters from the anal verge were even higher, so 97% at 3 years. No late toxicities, grade 3 or 4. Rectal spotting was more with the contact brachytherapy, mainly telangiectasia. And there is no difference in the low anterior section syndrome. This is mainly bowel syndrome. So the result was maintained, and as you can see here, with the 5 years. Again, it's higher with contact brachytherapy, 76% versus 56% with external beam. And again, the patient who have less than 3 centimeter lesion from the anal verge, they have a higher chance of organ preservation. Local recurrence was higher with external beam radiation compared to contact brachytherapy. You can see 16% and 33% with the external beam. Distance metastasis is the same, and overall survival was no difference. So the main issue was the telangiectasia or rectal spotting, mainly because of telangiectasia, and they noticed that it stopped after 3 years. This is the low anterior section syndrome. It's mainly the bowel dysfunction. They noticed that it is not significantly different between the 2 groups, and also the older patient, they have even a lesser chance of having bowel dysfunction. Quality of life was done by 2 questionnaires. They were the same between the 2 groups, and also the effect of quality of life on the global health was almost the same. Urine frequency is slightly higher with the external beam radiotherapy, so it's less with the contact brachytherapy. Urine incontinence were less with both groups. Anxiety, of course, was more with both patients. I mean, with both groups, usually after treatments. And the sexual dysfunction was almost the same between 2 groups in men and women. So the conclusion is that the OPERA 5-year result confirmed the 3 years outcome. The organ preservation is higher with contact brachytherapy, 79% versus 56%. And those patients who have tumor less than 3 centimeters from the anal verge, they even have higher organ preservation. So it is a well-tolerated treatment, no effect on the quality of life. It is a practice-changing trial. So in France and the European guidelines, it is implemented now. There is an ongoing trial for future, it's called TRISOR, where they do the neoadjuvant using fulfuronics, followed by brachytherapy. So I think contact brachytherapy is a reasonable machine to have in your center if you are planning to get or to add a machine into your center, because also you can use it for skin cancer and also for intraoperative breast radiotherapy. With this, I conclude my presentation. Thank you. Yes.
Thank you, Dr. Thuraya. My question is, how many patients do you think per year they are fit for the criteria for using contact brachytherapy for? Because like I remember maybe 15 years ago, I was at the King Hussein Cancer Center, and the head of department asked me, I was taking care of just the breast radiation therapy. And he told me, late, we want to think establishing partial breast irradiation using mammocyte.
Yeah.
And when I looked at the data at that time, for the ladies who are fitting the criteria of estro and astro brachytherapy, maybe just 3%. So per year, I will just treat maybe 3 patients per year from our cohort. So I told them, probably this is not the best modality that we need to establish it now in our department, think about other things. So, and if we will need to treat with partial breast radiation, this is 15 years ago, we can have this through the external beam radiation therapy. So do you think that, do we have a lot of patients that are fitting the criteria for the contact? This
Okay,
is the question.
actually, I agree with you. For a breast boost, I think it's like not worth it to have the machine for boost for breast radiotherapy, because the external beam radiation can do the job. But I mean, if you have the luxury of having this machine or do contact brachytherapy for rectal cancer patient in order to get organ preservation, maybe worth thinking about it. Because we have many patients, actually, and I face also that patient will refuse to have surgery. So, for example, we offer the patient concurrent chemoradiation, and that time of the surgery, patient refused the surgery, and then they end up with progression and mets. So, and then we have evidence that this study, we have evidence that contact brachytherapy, the local control is like double the external beam radiotherapy. So maybe not for breast, but you can consider it for the rectal CA.
So I think in our region, we don't have good screening programs for colorectal cancer. This is the reason that we have advanced rectal cancer tumors. And perhaps we don't identify these patients. We don't see 3-centimeter tumors in our practice.
Yeah.
The second thing that people are forgetting to look at the second arm. So having 55% complete clinical response at 5 years, it's amazing for external beam radiation therapy.
Yeah.
And I think we should focus on this number in our region.
Yeah, for sure.
What about the side effects from the rectal practice in terms of incontinence and other side effects?
Yeah, so they noticed mainly rectal spotting, telangiectasia. It's more with the brachytherapy, but it has resolved after 3 years. Regarding the urine incontinence, the incontinence was the same, but what is it? Yeah, so the urinary frequency and incontinence, frequency is a little bit with the external beam, but the incontinence were the same. So it is not that statistically significant.
And an answer to our colleague question, it's true we don't have screening, but we see more and more patient breast, for example, with DCIS and early diseases, and for rectum as well. Here we have colorectal screening, supposedly started at 40, and we start seeing more and more in younger patients and in the lower and middle thirds of the rectum.
Yeah.
That's, I think, we need, if you have a big volume, then we can consider that.
Yeah. Thank you.
Thank you very much. I think that ends the session.
Welcome to the third best of Astro Gulf 2026. We invite all attendees to the opening ceremony as we begin this distinguished gathering by raising the UAE national anthem in honor of our nation.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning and welcome everyone to the UAE and to Dubai. It's a great pleasure to welcome all of you to attend and to participate at the third Astro meeting here in UAE. We're very honored to host this event again in collaboration with our friends and colleagues from Saudi Arabia and also from Turkey. And I would like also to special thank Dr. Tamer Rafat for his support over the years to make this a reality. So today's meeting reflects our shared commitment to advancing cancer care through collaboration, education, and innovation by bringing together experts from across the Gulf and the Arab region to work together to improve the cancer care in our region. I would like to extend my sincere appreciation to ASTRO, our international ambassadors, partners, and the US Radiation Oncology Working Group, the first group to represent radiation oncologists in the UAE, and the leadership of Dr. Ibrahim Abu-Ghida and also other members. At EOS, our mission is to promote excellence in oncology practice, collaboration, which is very critical part in our networking with everyone from across our region. I encourage everyone to engage actively to share experiences and build lasting professional connections over the coming few hours. Thank you for being with us today, and I would like to have a special thank Dr. Ibrahim, Dr. Irfan, and also Dr. Majid, and everyone who was involved in making this reality, and wish you a very successful meeting today, inshallah. Assalamu alaikum.
Thank you. Good morning, Sabah al-Khair. Assalamu alaikum, everyone. Thank you so much, my dear friend and colleague, Professor Hamid. For those of you who don't know, Professor Hamid is an advocate for radiation more than most of the radiation oncologists that I know. So he's been a real sincere advocate. He trained and practiced actually at MD Anderson. And while he was there, he saw the true collaboration between medical and radiation oncology, and he's really pushing for this across our work on daily practices and our collaboration and conferences. So thank you for making this a reality, Professor Hamid, and I would like to welcome again this collaboration with the SARO, and we did one with the Turkish Society, but the one in SARO has really picked up thanks to our colleagues from Saudi Arabia. And I would like to welcome my dear friend and colleague, Dr. Majid Al-Ghamidi, who's the president of SARO, to also give us a few words of wisdom. Thank you, Dr. Majid, for being here.
Assalamu alaikum wa rahmatullah. Thank you, Prof. Hamid, Dr. Ibrahim, EUS, and my colleagues in SARO. And thank you very much for the ASTRO and Prof. Tamer for their support. So it is the third year for us to collaborate on bringing Best of Astro Gulf. And this is a real honor to have two societies in the Gulf region collaborate together in advancing our practice in the region. So we are very honored to continue collaborating to bring the Best of Astro, and hopefully we will continue alternating the place of the Best of Astro. And we would love also to maybe to get the conference hosted in other Gulf countries. So we do have so many guests now today from the other Gulf countries. So again, thank you very much, Dr. Ibrahim, Dr. Hamid, Prof. Tamer, my colleagues in SARO, and everybody who collaborated on this.
Assalamu alaikum warahmatullah. I didn't know I'm going to talk, but very briefly, I would like to first congratulate both Emirates Oncology Society and SARO. What you are doing is a success model for other areas in the world. Seriously, like this is the third year of a great success. Our great ambassadors from Emirates, Dr. Ibrahim Abu-Ghida, from Saudi Arabia, Dr. Mohammed al-Dahim, the leadership of Dr. Magid, Dr. Ibrahim al-Atin, and all the friends from SARO. I can tell you that I had a meeting before I come here with our ambassadors from Latin and South America, and they are trying to make something similar because you get people together, and that is the ultimate goal of ASTRO, is to, we are a smaller community, radiation oncology, and we have limited resources. If we do not work together, it's going to be very difficult, and that's what you do. So again, congratulations. Very quick for ASTRO, we are here to stay, inshallah. We are starting a new products like the Astro Mini Refresher. I guess most of you are familiar with the Astro Refresher, where we have like tumor sites. We have like a couple of hours for each tumor site. We are starting to produce mini refreshers, so you can host 3, 4, 5, 6, whichever tumor sites that you like at reduced cost for low and middle income countries, and even for high income countries like $2,000 per site. And we'll be committed to provide speakers if you want, or if you want to use your own. However, we recommend for the mini refreshers to use the same speaker who gives the refresher in the US, or a similar caliber person. Another news from ASTRO is that we are starting for our international members, international certification in medical oncology. So you as an international member in ASTRO can sit for a test, which will be administered during the annual meeting, and will give you a clinical competency in radiation oncology certificate by ASTRO, something similar to our colleagues in medical oncology. We may be able to administer the first pilot test this year during the annual meeting in Boston, but definitely next year will be the real one. So something to be watching for. And with that, I would like to thank you very much.
Introduce Dr. Ugur. Dr. Ugur is the ex-president of the Turkish Society of Radiation Oncology, very prominent speaker, and also a very dear collaborator with us. Thank you.
Well, dear esteemed colleagues, well, first of all, I'd like to congratulate all of you to be successful as the third Best of Astro Gulf, and I'm bringing the sincere and warm regards from our Society of Turkish Radiation Oncology colleagues. And I'd like to thank the program committee, and specifically Professor 𝗿𝗄 𝗕𝗲𝗀 and Dr. Ibrahim Abu-Ghida for their sincere hospitality and the invitation. Well, as you know, we were the first site, first overseas Best of Astro Istanbul in 2014, and since then we have been performing it. And this is a really great opportunity for all the colleagues to come together, to refresh themselves and to learn together for our patients and for our colleagues. And in addition to that, it's also important to know each other, because as Turkish radiation oncologists, and we are close to 900 now, 900 radiation oncologists and 350 in training. So it's a huge community, but most of our colleagues know the European colleagues or American colleagues more in comparison to the number of colleagues we know from the region, from the Middle East and Gulf. So we need to increase that interaction, and Best of ASTRO is the first step to know each other. And in Turkish society, we have a motto. It is radiating science and radiating radiant future. So when I look at your eyes, I can see that shining star in all of you. So thank you very much for your dedication, and thank you very much for the invitation. I believe we will do more, and we can come together more in near future collaborative meetings, and together with also Turkish Society for Radiation Oncology. Thank you.
So now this is the highlight of today's event. It's really a great pleasure to have the first ASTRO International Ambassadorship meeting outside the US. Today we are really honored and privileged to have 5 ASTRO ambassadors. So thank you, Dr. Tamer, again for your leadership in this. So my name is Brahim, and I will want to introduce all the ASTRO ambassadors one by one. So please join me in applauding them. The first, definitely not the least, dear friend, colleague, neighbor in MD Anderson, and co-fellow. He is, without all, everyone knows him, Dr. Mohammed 𝗿𝗱. He's the ASTRO ambassador in Saudi Arabia. Of course, I have to put myself in his picture as well. Again, second, Professor 𝗔𝗦𝗧𝗥𝗢, ambassador, ASTRO ambassador in Turkey. Really, really warm welcome for Dr. 𝗍𝗂. Dr. 𝗍𝗂 is the ASTRO ambassador in Georgia and her entire team over there. So thank you so much for coming. And now, it's really an honor. Unfortunately, Dr. Tamer, we want you on the stage now. Stop with the filming. So Dr. Tamer, of course, he is the vice chairman for the International Committee in ASTRO, and a very strong, but I want you to be on the stage to welcome and congratulate Dr. Noura Al-Hammadi, newly appointed ASTRO ambassador in Qatar, Muscat. Qatar, Doha, sorry. Dr. Tamer, so Dr. Noura couldn't make it to ASTRO, so Dr. Tamer got her the certificate all the way, signed by ASTRO leadership. Okay, so please, do you have enough chairs? I think 1, 2, 3, 4. Yes, so you're there. Okay, okay, Dr. Tamer, please. So today we thought of doing something different than science. First of all, I'd like to welcome you all again and thank our radiation oncology colleagues and our sponsors, and to discuss, a couple of things. I think Dr. Tamer started with the initiatives that ASTRO is leading. If you don't mind, maybe I'll ask a question for the ASTRO ambassadorships, and we can go one by one based on their country, their demographics, and then I can also answer from my end. Start with Dr. Mohammed. Dr. Mohammed, what do you think is the most common difficulties that the Saudi society and the Radiation Oncology Society in Saudi face in enrolling doctors, residents into ASTRO, or in general, in terms of difficulties you have been facing and you have overcome, or you are still facing? So if you can share your experience with us so that we can.
First of all, thank you so much, my dear friend, colleague. Thank you, Prof. Ahmed. Thank you, Dr. Ibrahim, for this. In Saudi Arabia, we're still a small community. Radiation oncology, the whole country, maybe the exact statistics known to Dr. Majid, but we're still less than 100 colleague, the whole country. Saudi Arabia is a vast, large country. We just established our local residency training program as well. This year, we graduated the first batch, five new radiation oncologists locally trained in Saudi Arabia. And also the SARO, the Saudi Association of Radiation Oncology, is a new society. So first of all, unity is the biggest obstacles. Now, alhamdulillah, I think we are good, unified a society in Saudi Arabia. We start collaborating regionally with EOS, with other society as well. ASTRO is the biggest umbrella of the whole world under the leadership of Dr. Tamer and ASTRO leadership. I think financial also is one obstacle, but it's not the only obstacles. It's still, we are thinking to sign memorandum of understanding with ASTRO, negotiate with ASTRO, trying to have such events more frequently and routinely in our region in Saudi Arabia. So all of that factors, maybe we can combine membership between SARO and ASTRO as well. So those are the idea came to my mind now.
Thank you so much. Dr. Ugur, same question from a Turkish perspective, much larger country, higher number of radiation oncologists, higher number of residents. You highlighted the gap between Turkey and the Middle East, even though geographically it's very close. So what do you think would be a potential area of collaboration, whether exchanging residents, exchanging other than the conferences as well, from your vast teaching experience as well?
Well, first of all, again, thank you very much for the invitation. It's a great pleasure to be together and to be able to produce together. Well, in the last 15 years, we have a great investment in radiation oncology, and currently, almost 95% of the departments are able to perform IMRT, and more than 50% are able to perform SBRT. Even in Istanbul, I can count more than 10 MR-guided treatment machines, and like 15 CyberKnives, and you can count on. I mean, for technological wise component, we are very well developed, and for that manner, for the last 15 years, we have really invested in our young generation to build their education and training on being able to perform when they have the machine and when they have the patients in their clinics. It was not easy because starting from 3D to IMRT and then SBRT is a very difficult transformation. But now we are able to have at least 80% uniform standard practice all over the country through our courses in Turkish Society for Radiation Oncology. However, because of the financial difficulties, it's very difficult for a young colleague to be able to participate ASTRO or even ESTRO in Europe, because if you consider the flight, if you consider the accommodation, if you consider the registration, it's almost half of a salary per month of a young colleague. It's huge. So for that manner, we have started Best of ASTRO in 2014, at least to bring the best of ASTRO to our colleagues. But it's not enough, because I believe that, I feel that these kind of congresses are important to know each other, to meet each other. And one of the problems in the Gulf region and Turkey, we don't have common congresses, we don't have common courses I mean, I'm not coming to the exchange of the residents, but even the professors, even the, the consultants do not know each other. So that is the first gap. We need to increase that interaction. And then when we know each other, we can easily exchange our residents. That's the second step, because we need to tell our young generation that that's the only way to produce and to collaborate. So ASTRO is doing a great initiative to increase that with Best of ASTRO. Now coming the refresher courses and also the examination, because that was one of the gaps also in overall Europe, Middle East, and US, because most of the medical oncologists are saying that they are already licensed and they are known by the system that they are medical oncologists, but for radiation oncology, it's a lack, it's a gap. So I believe we can complete that, and we can do it in hand all together. And as Turkey, as an ambassador from Turkey, I promise my 100% to do that together with you.
We'll hold you accountable for this. So thank you so much. Dr. Iter, so we know the challenges in Georgia might be slightly different than the challenges in Saudi or in Qatar. You've been very active in ASTRO and ASTRO ambassadorship. And again, thank you so much for coming to Dubai with the very pleasant group which you always bring. Tell us about the, the plans for the future for Georgia, and tell us about also the same question in terms of, what is the biggest challenge? So I'm hearing financially, even in Saudi, sometimes financially, and I'll leave the financial question for Dr. Tamer at the end, because it's going to have the hardest question. But, other than the financially, what do you think? What is the need? Where's the gap? And how can we all together help you fill in this gap?
First of all, thank you for having me today to participate in this. I think it's amazing Congress. And when I was looking at the picture you have presented on the slide, I was kind of thinking that it's not Middle East, it's a Middle Earth. So you have representatives having me from Georgia, Turkey, Gulf countries here. And if you look on the map, we are in the cross section of 3 continents. We could have a huge impact together. But what we have a gap in there is that we did not communicate it before. You had my group coming here during all 3 years as you started Best of ASTRO, and this is first time for me. And I think it's amazing that we all work together nowadays, because we can do research together. We can, as Gur said, we can have research for the residents as well. We can have some exchange programs. And I could not say more than agree on that, all the initiatives you have here. The first thing, for example, challenges in Georgia is that I first of all want to increase awareness of my country, because Georgia was the country where first Europeans came to the continent. But after the Soviet Union, nobody remembers that nowadays. So this is the first thing. Georgia is the developing country nowadays. We are a very small country, 3.7 million in the whole country. We have 6 centers for the country which are providing radiation therapy, and actually they are doing very bright and very well in what they are doing. We are opening new proton center probably next year. I'm not sure about the deadlines, what would happen, because this is a mega project for the country and everything could be changed by the time. But I think that what we see here, we work together. This was the self-organization done by ASTRO, and I cannot say more than thanks to them.
Yeah, thank you so much, Dr. Iter. And again, we're looking forward to welcome you every time with us. Dr. Noura, you have lots of titles and lots of responsibilities, and you represent the Radiation Oncology Society in a well-established country with a very solid vision in Qatar. Tell us more about, what's your plan? Okay, so now, you've been appointed an ASTRO ambassadorship, you're with us here in the team. And I really like the point that Dr. Majid was mentioning, and this is the whole purpose. This is Best of ASTRO Gulf. This is not Best of ASTRO UAE or Best of ASTRO 𝗲𝗂 𝗕𝗲𝗀 or Best of ASTRO Majid. This is the Best of ASTRO for the entire region. We do it here because a lot of our residents and fellows, they cannot travel to the US for financial commitment, visa purposes now with, the current administration. There's a lot of reasons where people can't travel now to the US. So tell us about, what's your plan, what's your vision, and how can we be part of this and help you to accomplish this? And congratulations again.
Thank you. First of all, the radiation oncology department started in the state of Qatar at 2004 with the National Center of Cancer Care and Research. So you can imagine it was a new thing, a new field, something maybe we did not study in the medical school. I was the first and the only radiation oncologist in the country. After 10 years, there was another colleague, Dr. 𝗿𝗱 𝗕𝗲𝗀, another radiation oncology in the country. So you can imagine we are only two. Wow. And I had to develop the department and to recruit the people from abroad. And thank goodness I have a very solid team. And we are reaching a state-of-the-art department. We have 3 linear accelerator, 2 true beam, and 1 ethos, and cyberknife and brachytherapy, CT scan planning, MR simulator dedicated since 2011. We are proud. We are one of the first who introduced it. We have a PET CT planning as well. And, after dedication and building the state-of-the-art department, I started in 2009 with the IEA to host the radiation therapists and medical physicists and to help those countries to move from 2D to 4D. And that was the vision, to educate and to dedicate, this state-of-the-art technology for those countries who doesn't have this technology. So we started it with a medical physicist and radiation therapist. After building the department, I'm so proud to tell everyone that we got accredited before 2 days for the Arab Board program for radiation oncology, alhamdulillah. So when I started it last year, and it's a 5 years program, and then they came from the Council of the Arab Board, and they did the evaluation, and they give us the accredited before 2 years. And now we have 6 starting residents from last year, alhamdulillah. We are not reaching like Saudi Arabia, where we are working on it. And I was so happy because we have 2 medical schools back home, Weill Cornell and Qatar University, and we are actively involved in pre-med that we are teaching them about the, the importance of the physics and importance of the radiation. And we are hosting them over the weekend to know more about the radiation oncology. And when they are in year 4 and 3, we are taking them as an elective. And I have lots of candidates, I'm sometimes refusing, which is really good, and I'm so proud. And we are anchor of center. We have been appointed this year in IEA for the coming 4 years. So you can imagine that we can receive more and more for educating.
So you are a very good target to send people to. That's what I know. Okay, great.
Please,
definitely do that.
Thank you.
Great. Thank you so much, Doctora. Congratulations again. And then the last question.
I think the last question should be for you first. So you should answer.
I'm avoiding it. So I'm doing. Actually, I have one point. Actually, I mentioned this during our Astro meeting, and this is where I really want everyone's attention, please, guys. How many is ASCO member? ASCO, American Society of Clinical Oncology. Okay, look. Okay, wonderful. So you see, a lot of radiation oncologists are actually ASCO members, including myself, because we need access to journals, we need access to ASCO. There is a lot of events happening. I would encourage you all to ask your medical oncologists before they escape, Dr. Humaid, to be part of ASTRO, because we want our medical oncology colleagues to be also part of ASTRO. There is a lot of science, actually it's overlapping. I really don't think that the division of radiation oncology is separate than medical oncology. I always used to hate the British system. Sorry, excuse me, Dr. Anab, but I think they're right. Having someone who's site-specific, understanding the medical and the radiation part, it's extremely important because we are treating the same disease. I still feel like we have this gap, and us being part of the EOS, we're actually trying to bridge this gap. We're not trying to say that we don't have any identity. No, we do have a very solid identity, but our presence under the Emirates Oncology Society help us to really bridge this gap and block because we're working on the same disease with the same patient population. So this was my comment I wanted to say. بدك تسألني سؤال ولا أسأل؟
Yeah, it's the same questions that you ask everybody. Okay, the status in UAE and how can you?
Yes. So currently we are having, so this society, alhamdulillah, there is another society and a third society that has joined, which is great. And for me, it's always good to have this because you enhance. So I'm very excited. There is a big actually event next week here also in Dubai, which tells us that people are becoming more and more aware of the field. Now, our limitations is training. I will be very honest that we don't have a solid residency training. Now we are actually in the process of forming a national training sector where me, Dr. Falah, Dr. Carla from Cleveland Clinic, and Dr. Rana and Dr. Majid will be part of the committee to evaluate residents. So there is a eagerness from the government to try to push for a residency program. I think through the centers dispersed across the UAE between Abu Dhabi, Dubai, Al Ain, and Northern Emirates, there's good exposure for the residents. Now, the most important thing is it's going to be a national kind of residency program similar to the one in Saudi, and I think it will be very successful. I think that there is a lot of eagerness. I do get sometimes, hopefully we get an elective for students actually from your own university very soon in summer. So we are also open for this right now. My biggest limitation, I feel like all of these trials that we're presenting today, very few is coming from our region, even though we are seeing very difficult cancers and very weird cancers and very young patients with cancers. So luckily now we are formulating a group, I think with Dr. Ali Husni from Canada, Dr. Isa, with a new kind of form, kind of similar to the NRG, but similar to the region. Dr. Dahim is with us, a lot of people from the region, a lot of people here in the room. We are formulating this to start to open these clinical trials across the Middle East and the Arab region. Now we'll be happy to have Turkey and have Georgia, with us because at the end you also have a lot of numbers. Egypt is with us as well with a high volume. So this is, I think, if we are able to formulate this, it's good. It's sometimes, it's not working together, or it's I would not say the centers or the doctors. The doctors all want to work together. It's the bureaucracy. It's the layers that you have to go through to send the patients, to send the details, to send the de-identified data. Every country has its own security rules. So this, I think, once we overcome this, this will really expedite it. But I think in the Gulf region and GCC and in Jordan, Egypt is also very open for this. I think we're getting there, inshallah, very soon. Okay. Now I can ask you a question.
Go ahead.
So Dr. Tamer, financing. Everyone is telling you we don't have money to send students. Even this conference, I had a lot of difficulty raising money for this meeting. So we know, now a lot of pharma companies are interested in Astro because of the immuno, SBRT era, etc. So when do we start? And I'm saying this very bluntly, we want to make bigger conferences. We want to send our residents to the US. We want to get them enrolled in Astro, but they cannot afford it. Pharma companies can afford this easily because we know how much money they make from selling one immunodrug. My suggestion and my question to you, and I hope that you take this to the Astro leadership, is that we need Astro's weight on pharma, not only on Electa and Varian and because these people, they sell you the device and that's it, you're gone. They will only be interested in you before they sell you. Once they sell you the device, salam alaikum, khalas, they'll be no more interested in you. But pharma, because it's a continuous thing, right? So is there any push to try to get, like we have AstraZeneca today, partnering with us, which is good, but this is all because we have very strong medical oncology talks, and our medical oncologists understand the value of radiation. What is your vision as an Astro leader, other than what you're doing in terms of our education program, exams that you mentioned to us? Let's talk about something realistic. How can next year we have a best of Astro in a country that cannot host a best of Astro?
Okay, that's actually a great question. And I'm going to take a step back, okay? So 10 years ago, Astro, to be very blunt and honest, was not interested in international outreach much. There was no support from the CEO, and we were struggling as a subcommittee to even become a committee or a council. In the past couple of years, things has changed drastically in Astro. We have a new CEO who happened to be the first radiation oncologist to be a CEO. So he's a radiation oncologist, Harvard grad, ex-MD Anderson, leading very large private practice in Texas, who now is the current CEO. His name is Dr. 𝗿𝗱 𝗕𝗲𝗀𝗧. interestingly, when he interviewed for the job, one of the four main goals for him was international expansion and outreach. And when I say this, it's not only having you pay money to be members in Astro, it's what is the added value for you to pay this money. First, you mentioned, Dr. Noor, that you have 6 residents now. There is no reason those residents will not be Astro members, because just to remind everybody, for any resident or fellow, international membership is free. So there is no fees for all those residents in this room or elsewhere to apply, and please expand the word. And they understand by their membership, they have tons of educational products that you have free access to, including e-contouring sessions, including webinars, and there is an Astro Academy. Many of these sessions are either free or like for $10 or $20. So if you are a member in training, if you are a resident, if you are a fellow, please apply. It's a free membership, and you will get a lot of benefit and understand the value. Now, if you are coming from a low middle income countries and low income country, for the first time also ever last year, we instated significant discounts. It's like 25% only membership fees for the low income countries and 50% for low middle income countries. And again, it's not only reducing the fees, but also exploring the value of these fees that you're paying. Now, last year, we actually had a meeting with the Corporate Council, and Dr. Sorbi Gruval, who is the chair of the International Committee, and myself presented the vision for international growth and outreach. And most of leading pharma companies are members of this corporate. There was significant interest. Now we are just trying, and that would be with the help of everybody on this stage, right? The ambassadors who can guide us, like we're here to learn from you. What can we offer to expand the membership of Astro, but also to benefit every radiation oncologist that we historically did not have access to, but you are most aware with your individual countries. So they were very receptive to any idea, including supporting early and mid-career to travel to Astro meetings, including an Astro fellowship for training in the US paid by through these corporate organizations. So we're working on this. Certification is one of the things that we, and if you know, ESMO is providing the certification for medical oncologists. They started with like like 10 or 20. Now it's 22 countries are running it in parallel. A couple of countries, including Switzerland, consider it an alternative for their board certification. That is not our ultimate goal, but we would like to be the body who provides some recognition for radiation oncologists in countries, including Egypt, where the majority of practicing radiation oncologists are actually clinical oncologists. So we are going to advocate for this, and we're going to listen to you and do whichever you think is best for your own members.
No, we'll make sure that we'll meet all the sponsors today with you. So I think for the sake of time, we can move to the coffee break. You guys can ask any one of us any question. We will come back. So we are 15 minutes behind the schedule. I highly require and request all speakers to please stick to time. And for questions, just for burning, very important questions, just because a lot of the speakers are traveling right after the meeting. So we really don't want them to miss their sessions or miss their flights. So we have 15-minute break. We'll come back at 11:20. 12:20. Enjoy the coffee break and see you for the GU session, which will be the bulk of the meeting because there's a lot of abstracts. Thanks. Yeah. Yeah, we need a group photo, please, before everyone escapes. Some people might be traveling, so group photo. Sorry. So everyone, please join the stage. Group photo, then coffee. سارو تفضل. احلى دكتوره. والله بعض ما عندك. لا لا لا. لازم يكون حاولون. اي we have to party. والله تشرف ما فيه. شرف والله تشرف. والله والله. يلا ready وقت.
بعدين فين من الموضوع ده بس منظر مش حلو خالص.
للآخر. سوري. تعال. هيك تعال. What? Everything I would send you.
احسن بايت.
3 more.
So guys, we will call everyone while they come. Sorry, we just want to try to catch up on time. We'll move to the bulk of the meeting, which is the highlight of ASTRO last year, which is GU malignancy, side that I like to treat. Me and my colleague, Dr. Hussam Hijazi. Dr. Hussam is a very well-established radiation oncologist in Jeddah, a very dear friend of mine. And thank you so much for being with us. I know you're flying soon, so we try to stick to time. Dr. Rana here? The speaker is not here. Where's Dr. Rana? I'll skip him. We need Dr. Rana. What's his talk? Dr. Rana, so it gives me great pleasure to introduce to you all Dr. Arfan Rana. Dr. Arfan is a very senior consultant, not that senior, he's young and by heart, clinical oncologist, radiation oncologist, excellent friend and dear colleague. He's also part of the Emirates Oncology Society Radiotherapy Working Group. You'll be talking to us about 2 abstracts, I believe. Yeah. This is you.
Thank you. Thanks very much. Thank you it's an honor for me to be here. So when I found that I will be talking about this NRG trial 005, it made me really excited and very quietly happy and smiley inside, and I will tell you why. And for that, I will have to have a very 1-minute background for that, and starting with disclosure that I was PI for PACE trial and one of the co-author. And when our colleagues presented in ASTRO a few years ago, the PACE trial, they were blasted because we kind of messed up in the control arm. And the control arm from the PACE trial was that we were supposed to compare SBRT versus the standard radiation, which is exactly this trial. Our trial was bigger. But when the control arm was being decided, we thought that we should go 78 and 39, which is the international standard at that time. So we came up with 78 and 39, although UK standard was 74 and 37. In fact, UK standard was 60 and 20. So NHS did not allow us to do 78 and 39, so we had to come back to 60 and 20 as control arm. But everybody in the room said that 60 and 20 was equal to 74 and 37. So we kind of made it up at that point to make it 62 and 20. I say made it up based on the BED and all kind of equivalent results from the biological equation. So the PACE trial, SBRT versus radiotherapy, which was 62 in 20, and that is when we were blasted in that ASTRO meeting that where the 62 in 20 comes from. So all medical oncologists should shut their ears. I hope there is nobody here. That's how we decided 62 in 20. Interestingly, for PACE-C, we have reversed it back to 60 and 20. So that's the background story of how we suffered in PACE trial. And now we will just look at this trial, which is Americans were deciding at the same time. And in my opinion, they messed up with experimental arm. And I will explain to you why. So this is the slider, I guess. Okay. Right, this is the co-author, Rodney Ellis, and the other affiliations. So we all know that in intermediate risk prostate cancer, there are so many radiation schedules. In England, mostly we have already settled that it is 60 and 20 based on CHIP trial. But when it comes to SBRT, more and more people are using SBRT for intermediate risk prostate cancer. And we did a very large study for PACE trial to show that it was not inferior to the radiotherapy given as 60 and 20 or 62 and 20. Hence, in UK, we do a lot of SBRT for prostate. So Americans were waiting for this trial. And very interesting part is that these smaller trials were informing the cohort selection. And the hypothesis was, as opposed to our hypothesis in PACE study, where we said that we want to prove that SBRT is not inferior, their hypothesis was it will be superior to moderately hypofractionated IMRT. So they issued two co-primary endpoints. First of all, it was all related to the quality of life with GI and GU toxicity. And the second was that, of course, you want to see whether the disease-free survival, biochemical control kind of stuff can go better with SBRT. So standard risk group of intermediate, favorable intermediate risk prostate cancer, where there is no debate about lymph node radiation. So all 3+4, 3+3 cancers. And the other difference between this trial and what we did in PACE study was that we did not have any patients with spacer or any rectal balloons or anything. But in this study, it was allowed, and you will see that half of the patients had it. But most important part, in my opinion, where as I said, I'm quietly smiling inside, is this part. So in this part, the IMRT was standard, 70 gray in 28 fractions. Nobody argues about it. And or 60 gray in 20 fractions, which was our UK protocol. So I think the big difference, which will come to at the end to show why I think that GI toxicity was different, was this, which is 8 millimeter expansion. In PACE trial, we did not allow 8 millimeter expansion. And SBRT part, this is where the fun starts, because SBRT, anybody who practiced prostate SBRT knows that the standard prostate SBRT has been 36.25 in 5 fractions, with the prostate itself receiving 40 gray. And that has been around for nearly 2 decades now. So for some reason, they decided to not give 40 gray to the prostate itself. And they decided just we'll give 36.25 in 5, which most people will agree that this was an underdose. Margins were standard, exactly what we used in PACE trial as well. So radiotherapy details, a CTV was just a prostate plus minus 1 centimeter of proximal seminal vesicles, exactly what we did in PACE trial. 70 gray and 28, as I said before, or 36.25. But the interesting part, I think, which led to some problem is this one here. That the PTV max dose was allowed to be 38.8, when actually the prostate itself should be receiving 40 gray based on all the SBRT protocols we have been doing for 20 years. Nobody argues about any of those. And in fact, we have moved on now to the flame with the dominant lesion getting extra boost to 50 gray. So this was really a step backward. So Sample size was calculated based on the fact that you want to have 80% power to decide if there is any difference made by SBRT on the toxicity domain. And similarly for the disease control, 89% power, that would have given you 590 patients. But when you count for any non-compliance or fall-offs, then you have 691 patients. And in fact, they did manage to recruit 698 patients, all of these hormone-naive, intermediate risk prostate cancer. So standard patient will be Gleason 7 patient, 95% of them. Organ confined disease, nearly 60% patient had spacer and or rectal balloon, and PSA was less than 10 in majority of the patients, so nothing surprising. Now, this is where the fun part starts. So if you look at the now bowel outcomes from the health-related quality of life, you would see that the conclusion was that SBRT was better and IMRT was inferior in terms of bowel toxicity. But remember, go back to the previous slide where I showed 8 millimeter margin in the modern IGRT with fiducials, 8 millimeter margin. Nobody gives the 8 millimeter margin for 60 gray in 20 fractions. So that is what caused more toxicity in IMRT and smaller margin for SBRT, despite the fact that 60% had spacer in both IMRT and SBRT arms. So it is really surprising to see that number, but the only explanation, in my opinion, is larger margins allowed. Similarly, here you have urinary outcomes. Interestingly, they didn't see urinary outcome difference, although in PACE trial, we did see urinary outcome were inferior in SBRT, but not statistically significant. But perhaps that is because we were giving a standard SBRT, which was 40 gray to the prostate. So secondary outcomes, again, it was favoring the sexual domains and urinary incontinence. And the dose was lower, to be honest. I mean, it was always going to be favoring that. Disease-free survival, this is where the real crux is. And here you see that the SBRT people did not do very, very well. I mean, this is only a 3 years data, and intermediate risk prostate cancer takes forever to show the outcomes. And even at 3 years, the curves departed from each other, and you can see the SBRT dropped lower than the IMRT. So 89% at 5 years versus 92% at 5 years. And the curves perhaps are going to depart further as time goes on. The only happy news they had was that, yes, it is biochemical failure at 3 years, which is a 4% versus 8% failure, double the failure. But overall survival was same, and the local controls were same. But that takes time. I mean, you don't fail with PSA in intermediate favorable risk cancer and within 5 years show overall survival advantage. So biochemical failure is a big thing for these kind of patients. And of course, as I said before, that rectal manipulation made a difference in both arms. So summary, the bowel size significantly better with SBRT, but that in my opinion is based on the fact that you allowed 8 millimeter for IMRT and no difference in the urinary, which is a bit surprising, but not surprising because SBRT was colder than what it should be. Secondary outcomes, the sexual domains and everything was a bit of favoring, but no DFS superiority for SBRT. And that is where the study ends. And this is just the memoriam for Dr. Fang, who passed away a couple of years ago, the big prostate GU oncologist, passed away of his cancer as well. Okay, so this is where we'll stop.
So thank you very much, Dr. Irfan, for this great presentation. We'll open the floor actually for 1 or 2 questions. I know it's a very interesting topic, but we'll try to limit the questions. Okay, so I have 1 question here. Yeah, you just mentioned that during this study, 60% of the patients used spacer. So my question, what about the other 40%? What was actually the setup?
Yeah, that's a very interesting question. So spacer devices, the bigger trial which we did in PACE trial, nobody had spacer device. So the spacer device, they were not able to control that who gets and who doesn't get it. So they were just monitoring that how many people are practicing spacer. And in American practice, 60% were practicing spacer. But did it make a difference? That's another different discussion. In my opinion, it does make a difference in grade 1 and 2 side effects, not in grade 3 side effects with modern IGRT. But if you are going to give 8 millimeter margin, you better put spacer.
Yeah. That's it.
And he has no problem coming for these 20 fractions IMRT, what would you advise him on? Would you push him to SBRT or just give him the fractionated treatment?
Excellent question. So I think we have for favorable intermediate risk prostate cancer, we have 3 equivalent options. We have moderately hypofractionated radiotherapy, we have SBRT, and we have prostate brachytherapy. So which we practice here, Saad is sitting here, he's also very keen enthusiast of brachytherapy. So these are the 3 options which we have a discussion with the patient. And the SBRT data is not mature, although PACE is nearly 900 patients, now very long, prolonged data. And in UK, most patients will have it. So I think if there is a spacer device gonna go in, then I will be more comfortable to give SBRT. But standard program for intermediate risk cancer, still as of today, I would say 60 gray and 20 fractions, easy going. But SBRT is a very, very nice treatment because it's 5 sessions, you are done, and the side effects are same as we showed in the PACE trial and in our experience as well. So those are the 2 options, are equal options. We offer both options to the patient depending on how they perceive this radiotherapy. Data is more stronger for 1620, less for SBRT, but still there as an option. So in my practice, I would say out of 100 patients, about 10, 15 patients will pick from external radiation options, will pick SBRT, 80% will pick the conventional radiation. In UK, most patients were moved on to SBRT after COVID.
Thank you so much, Dr. Rana. So we move on to the second speaker. It's really a great pleasure and honor to introduce my dear friend, Dr. Chad Tang. Dr. Chad is faculty of GU Radiation Oncology at the University of Texas and the Anderson Cancer Center. He pioneered many, many trials since he was a resident, now as a faculty and an assistant professor. He'll be talking, he's a GU radiation oncologist. He has a lot of knowledge to share. Please listen to his talks and please tell him how do you convince your oncologist to do kidney SBRT, because all kidneys at MD Anderson, I would say most of them are being treated by this superstar over here. So please join me welcoming Dr. Tang from MD Anderson. Thank you so much for your time.
Great. Thank you so much. Thank you for the organizing committee and especially for my dear friend, Dr. Ibrahim Aboughida, for this kind invitation. It's a wonder to be here. Okay, so I'm going to talk about the LUNAR study. And this is a very interesting study. The background is metastatic therapy is an emerging tool for prolonging at least PFS in patients with oligometastatic prostate cancer. And that we do have this one agent, which is PSMA, and using PSMA PET-CT and the therapeutic derived from that, we can potentially prolong the patient's PFS. So even with SBRT, progressions do ultimately occur, and they do occur quite frequently. So as we talked about, PSMA-based radioligand therapy with lutetium-177 is a very interesting option. It's used mostly in patients with castrate-resistant prostate cancer, but I think it's very interesting to bring it up front in the more castrate-sensitive oligometastatic space. So the hypothesis of this study was that adding PSMA-based radioligand therapy with lutetium-177, PNT2002, which is now owned by Lilly, I believe, to metastatic therapy in men with oligometastatic prostate cancer can prolong PFS in this disease state. So here is the study. So in patients with oligometastatic disease, defined as 1 to 5 sites based on now 100% based on PSMA PET, the patients are randomized to 2 cycles of lutetium PNT2002 given at 6.8 gigabecquerel followed by a repeat PET, and then SBRT to all sites versus SBRT alone. And mind you, there is no hormone therapy given in this study. So it's observation after SBRT versus adding lutetium. Not lutetium, the PNT202. The primary outcome was progression-free survival, defined as time from randomization to PET-based progression or salvage hormone therapy initiation or death. And the definition of PET-based progression is presented there. And the definition of PSA for repeat PET is presented down there lower. So you had a trigger to do a repeat PET depending on how your PSA goes. So this is the patients enrolled in the study. They assessed 100 patients for eligibility and randomized 92 patients. There's a little bit of dropout in patients who received or randomized to SBRT alone. This is the characteristics among both arms. As you can see here, there was a low PSA in this population who were all normal eugonad, and there was also an exposure to prior metastatic therapy in a substantial subset of patients. Most of these patients were M1A or M1B. So here is the different distribution based on the PSMA PET, M1A, M1B, and lesion count based on PSMA PET. So it's 1 or 2 to 3 are the most common. And here's some examples on the imaging scans of this avid lesions. This is the primary endpoint, progression-free survival. So the median progression-free survival increased from 7.4 months in the patients who had metastatic therapy alone to 17.6 months. And the majority of these were new lesions. In addition, if you look at the per lesion basis, patients who received SBRT alone had a 2% failure on the lesion level versus 0% in patients who received the 177 lutetium PNT. Hormone therapy-free survival was equally also improved. Patients increased from 14 months median to 24 months hormone therapy-free survival in patients who, favoring patients who had the lutetium therapy. And repeat metastatic therapy without hormone therapy was delivered, probably prolonging hormone therapy-free survival. Toxicities, so always an interesting aspect. There was no significant increase in toxicities with the addition of the radioligand therapy, as can be seen here pretty much throughout all the different endpoints. However, the follow-up is a bit short, so we'll have to see longer term if there's a bigger fall, if there's more toxicities. One interesting correlative that was analyzed across this population was the T cell receptors. And what they showed here was that after radiation therapy, regardless of whether you had it with or without the radioligand therapy, patients who had a TCR rearrangement had better progression-free survival with a hazard ratio of 0.46. In addition, they looked at a set of germline biomarkers, which are a number of single nucleotide polymorphisms, and show that if you had an adverse or high-risk germline biomarker signal, you did worse regardless of what you received, MDT or NBT plus radioligand therapy. So in conclusion, adding 2 cycles of lutetium PNT2002 to SBRT significantly improved progression-free survival in men with recurrent prostate cancer without any increase in toxicity. PFS was defined based on PSMA, and the lesion count in the baseline was also defined based on PSMA. Furthermore, a few interesting correlative signals emerge. First, increased TCR productive rearrangements at 90 days, so a 3-month follow-up, was prognostic, regardless of whether you had the radioligand therapy or not. And also, if you were in high-risk germline variants, this was also prognostic, regardless of whether you had radioligand therapy or not. However, there is still a lot of room to be had. 64% of patients who received the radioligand therapy still progressed, suggesting there's further space for optimization in this disease site. And this is from the UCLA team. Okay. So any questions?
Thank you very much. I think we have a question here.
Thank you very much, Dr. Shad. It's just like, I think I feel that, do you think it's fair to compare a local treatment versus combination of local and systemic treatment? And systemic treatment perhaps also not a well-optimized, half-cooked systemic treatment, in my opinion, because if we are going to compare a local treatment only, which is SBRT, with plus minus systemic treatment, then we should have allowed the ADT as well, a proper systemic treatment, and that would have numbed the effect of maybe lutetium to see there is no difference, and we are just wasting time to give those 2 cycles of lutetium.
Yeah, so I think that's a good question. I think the key point here is trying to have castration resistance. I mean, basically, you go net testosterone. So that's really the key point. And I think this is the first study report out, Lunar, but there are 3 studies that are looking at this. So we have PSMA DC, which is a big phase 3 Novartis trial, looking at their lutetium, agent in 500 patients, all adjuvantly. That's going to report out. And then there's an Australian group who is running 1 cycle before, 1 cycle after Popstar 2. So this is the first of 3 studies that we report out. And I think you also need more follow-up for Lunar. But I think it's a very interesting question about preserving eugonad in these patients with metastatic prostate cancer. And I think there's going to be a lot more in this space. So whether or not adding hormone therapy is going to be beneficial, it's a great question. And there's a number of studies that are also looking at this. Radiosa reported out showing benefit. There's DART, and there's the NRG GU011. So this is a bit of a Wild West, I think, in the ligomet space. So I think it's very exciting, but also a lot of things are happening.
Basically, what it is saying is that you don't have to start ADT from the start. You can actually defer it, the inevitable use of ADT at some point.
Yeah, 100%.
So upfront versus deferred, the ADT.
Yeah, 100%. And you saw those PFS curves are falling. I think the median follow-up in this study was only 20 months. So I think a lot of patients are going to get ADT, but they get a couple years without ADT. And I think that's a benefit for some men. Please.
Yeah, so thank you, Chad, for this excellent presentation. And it's interesting to see how using Loop-SMA helped increase progression-free survival likely by treating occult metastatic disease. So my question is, when we consider patients with very high risk localized prostate cancer, does it make sense to try to use or to add Loop-SMA in this setting in addition to local treatment, whether radiation or surgery, plus hormonal therapy?
Yeah, it's a good question. I think this provides rationale to suggest it in patients with high risk disease, but the studies aren't available yet. So I wouldn't do that tomorrow. But I think there's a number of studies going on with Novartis that are looking at adding lutetium PSMA for high risk prostate cancer. So more to come, I think.
So thank you very much. Thank you, doctor. So we'll move to next study. It's going to be presented by Professor 𝗷𝗂𝗪. He's a well-known faculty member in the Department of Radiation Oncology, head of the Department of Radiation Oncology Center at American Hospital in Turkey. So please.
Well, I'd like to go over the bladder adjuvant radiotherapy, basically the phase 3 multicenter randomized controlled trial of adjuvant radiotherapy or observation for post-cystectomy muscle-invasive bladder cancer, which was presented by Professor 𝗿𝗂𝗪. And the initial idea was from Egypt, as you know, previously published, adjuvant radiation treatment. And to keep it in mind, the easier way is remembering the BARTs. So it's bladder adjuvant radiotherapy trial. And this is a phase 3 Indian trial from Tata Memorial. As you know, Tata Memorial is a really shining star in Asia nowadays with lots of phase 3 trials. The basic idea was looking at the high-risk patients who have or have not received neoadjuvant radiation, neoadjuvant chemotherapy, and had cystectomy, and comparing it observation versus adjuvant radiation treatment. So looking at the literature, the cystectomy was initially supported by chemotherapy and adding 3 to 8% of overall survival benefit with cisplatin. But then came immunotherapy with an additional 6 to 8% of overall survival benefit with the recent CheckMate trial. So this trial had at least pathologic T3 patients, at least not positive patients, surgical resection positive or not, and lymph node less than 10 dissected in this group of patients. And the patients who had initially neoadjuvant chemotherapy and downstage afterwards. So one arm received none as observation, and the other arm received 50.4 gray in 28 fractions to the pelvis and cystectomy bed. So when you look at the literature, you can easily see that this is the group of patients who were involved in the CheckMate 274, and nivolumab showed disease-free survival benefit following cystectomy. And this is almost the same cohort, which is similar to the Ambassador trial, where Pembro showed disease-free survival benefit for this group of patients. So the problem here is patterns of failure is not the same in systemic treatment or in patients who were treated with postoperative radiation treatment, because mainly it's firmly believed that most of these patients are failing distantly. However, when you look at the literature, you can easily see that almost 30% of these patients are failing loco-regionally. So this study really aimed to find out what will happen if we treat this group of patients. And we also know that chemo does not decrease the local regional recurrences, because when you look at the neoadjuvant chemotherapy plus cystectomy versus radical cystectomy group, there's no difference between the regional or local failure in this group of patients. So what happened in this trial? They aimed to treat the pelvic nodal disease, the common iliac, internal and external iliac, presacral obturator, as well as the cystectomy bed. But the important part of this trial is it's an IGRT trial. It is an IMRT trial sparing the stoma and also the bowel. So the risks of acute side effects and late side effects are really down. And the important point in this group is also we need to point out that the neobladder is only 2.6%. I mean, in our center, it's almost 50%. When I see a patient in my clinic after cystectomy, 50% of these patients are having neobladder. But in this trial, it's 2.6%. So it's giving an ease to treat these patients and not to mess up with a neobladder. And 77% of these patients are clinically initially pathologic T3 or 4. 70% received neoadjuvant chemotherapy, and 41% were pathologic and positive after surgery. So 77 patients in radiotherapy arm and 76 patients in observation arm. The initial endpoint was the local recurrence-free survival at 2 years. So they met it. The BART, bladder adjuvant radiation treatment, provided 11% local regional control benefit. So at 2 years, the patients who received radiation were 87%, and the observer group is 76%. And when you look at the per protocol, it is way higher, 93%, 75%. So the group who got the most benefit were the patients who had node positivity after surgery or who had neoadjuvant chemotherapy before their surgery. When we look at the disease-free, cancer-specific, and overall survival, there's no real significant benefit, but there is 12 to 15% of improvements with radiation treatment. So it looks like that it's not a study well-powered, and it's almost there, but need additional patients to show that. And there's the important point here is also there's no isolated local regional recurrences in the group of patients who received radiation treatment. And in the other group, it's evidently better, evidently more, like local regional recurrence is 25% in the observer group, and in comparison to 8% in radiation group, and distant metastasis is the same. So what we need here, it looks like that what we need here to improve the distant metastasis while radiation treatment is improving the local recurrences. And last year it was presented again by the same group with a very favorable side effect profile. Only the grade 2 GI was higher with radiation treatment. However, the long term was not different. And we can easily say that immunotherapy and radiation treatments can be combined because their side effects are not really matching, so different side effects. And the opportunity here is radiation seems to decrease the local regional recurrences, which is not really targeted by the systemic treatment. And I'd like to really congratulate this group, Tata Memorial, to provide a great trial like this in the era of targeted treatments or immunotherapies, where they showed there is still benefit with radiation treatment to this group of patients. And we need to be aware of how to combine these two in this group of patients. But again, we need to be also careful. These are patients who didn't have neobladder. 97% of them are not having neobladder. So that's the critical point. We need to be careful while we are delivering radiation to this group of patients. So let's raise the bar together. Thank you very much.
Thank you very much, Dr. Ugur. So we'll open the floor for any question.
Yeah, I think it's an excellent effort from a very large center. And I think that reflects the type of patients seen in the setup in India and Pakistan and in all these countries. And as you pointed out towards the neobladder and all kind of stuff, I mean, that is the kind of number which you see in an average population and average practice there. But one thing I take home from this one is that we kind of always thought that the local control does not really translate into the overall survival in bladder cancer. In the past, when there was any positive node, surgeons used to reject cystectomies or all kind of stuff because they said, well, it's a systemic disease. I think this study, in my opinion, just tells us that that is true. But do you think that in your practice, if you encountered a patient who had a positive margin after cystectomy and had a T3 disease and 5 lymph nodes were resected, would you offer this patient the adjuvant radiotherapy or would you just give them systemic therapy?
Well, that's the critical discussion we always do in our multidisciplinary tumor boards in Monday morning at 7:30. Because I underline that this group of patients will be failing locally, even though we can prescribe immunotherapy to this group of patients who has already received neoadjuvant chemotherapy, because more than 90% of these patients are receiving neoadjuvant chemotherapy and then having cystectomy. And they're receiving immunotherapy now in Turkey. I mean, even though it's not supported by the social security system, they're getting it by pocket paying. So I'm trying to ask our colleagues where we can put radiation treatment to this group of patients. Before we didn't have any trials showing that the toxicity is at least manageable. Now we can say that the toxicity is manageable and we are not really increasing the risk of immunotherapy side effects in this group of patients post-cystectomy. So I'm struggling to put radiation to this group of patients in somewhere after they heal from the cystectomy. And it can probably be at least 3 months following cystectomy when they have a status that they can receive pelvic radiation treatment. But we are not there yet. We are still struggling for that.
Okay, one last question.
Thank you very much. Very nice study. We've never been sending patients for adjuvant radiotherapy after cystectomy. But obviously, field is changing quite fast now. What you mentioned about immunotherapy. Now, immunotherapy is coming in the perioperative setting. We already have one approved study using immunotherapy, pre-op immunotherapy. Now we are also having very potent agents like EV coming with the PAT-CR reaching 57%. So obviously that is a very difficult regimen to give as well, and it adds toxicity because there will be a regimen given post-op as well. So how do you see this incorporating into this regimen, which is changing now?
Well, I believe we need to be also pointing out in this trial that the radiation treatment is not like 10 years ago. We can also spare the bone marrow for the sake of any systemic treatment that they can receive. So maybe if I would be presenting this trial, I would be also underlining that the bone marrow is not really injured for systemic treatments afterwards. So we need to be seeing where we can really put radiation treatments after cystectomy in the era of well-designed targeted treatments or more stronger systemic treatments. But I'm really pro to offer radiation treatment to this group of patients. And in a couple of patients, we have succeeded to do that, and they tolerated it very well.
Dr. Tang, last question.
To where we put, I think, this treatment is, I think ctDNA in bladder cancer, it's very interesting. And I think that, I think in the future it's going to help us, just like PSA helps us in deciding when we're giving this salvage radiation therapy. But I think more data needs to come for that first.
Absolutely. And it's not standard, and it's very expensive still in Turkey. I mean, it costs almost the treatments. So that's the problem, because we would love to do that for each patient. Unfortunately, because of the price, we cannot.
Yes, Doctor? Yeah, Dr. Faiz.
We are talking now about the role of post-operative radiation treatment. But I can see the coin is flipping, and there is like a good role nowadays, and there are many clinical trials randomizing patients to receive immunotherapy along with organ preservation. Quality of life is important, and we need to advocate for the best quality of life for our patients. So I think the future should be toward organ preservation with integrating immunotherapy and maybe the ctDNA.
I agree that we need to be really encouraging organ preservation. However, because in many centers, the patient is first seeing the urologist and then being informed about how cystectomy can be very life-saving in their profile. Sometimes it's very difficult to argue after they had surgery and receiving neoadjuvant chemotherapy, then having surgery. But when we see these patients all together, we have patients like that. And if these patients are really manageable for functional preservation of their bladder, we always try to start with chemoradiation and then offer organ preservation to this group of patients. But that depends on where these patients are entering the institution.
Right. Great. So thank you so much. For the sake of time, we'll thank you so much, Dr. Ugur. We'll move on for the next talk. It's great pleasure to introduce Dr. Ramez Abu-Hijleh. Dr. Ramez Abu-Hijleh is a consultant radiation oncologist specializing in GU radiation oncology at King Hussein Cancer Center. He is a very active figure over there and is leading a lot of clinical trials. He'll be talking to us about some updates, again, in the GU world. Tfadal, Dr. Ramez.
Assalamu alaikum. I would like to thank the organizing committee, especially Dr. Abu-Ghayda, for the kind invitation. So today I will talk about the use of SAPR in systemic therapy naive oligometastatic kidney cancer. The final results from phase 2B study presented at the last ASTRO by Dr. Ryan Asadi from UT Southwestern. So it's not working. So this is the outline of the talk. They started with the background and epidemiology about the RCC. As you know, the global incidence is exceeding 430,000 patients with really high mortality, approximately 1/3 of this number. The median age at diagnosis 75, multiple risk for this disease, including the VHL, as you know, and multiple germline mutations. The metastatic disease presentation represent 15 to 20% of patients, And interestingly, the disease recurrence or distant metastases can be in approximately 30% of patients. If you look at this year, 5 years relative survival, you can see that the figures are really striking in terms of difference between the localized disease and the metastatic one. For example, localized disease, it's 93.3 versus 18.2 in metastatic disease. The treatment options, as you know, the systemic therapy, immunotherapy, TKIs, in addition to localized ablative therapies, including the metastatectomy and SABR. The systemic therapy, grade 3 toxicity can reach or approximately 30% up to 85%. So as a background, you know that metastatectomy improves overall survival in selected patients with metastatic RCC. You can see this table from multiple series from Mayo Clinic, Resort Study, Kim et al. And Faris et al. All of them showed survival benefit with complete metastatectomy. However, the RCC traditionally thought to be radio-resistant, as you know, because we tend to use the conventional fractionation. However, with the introduction of SBRT, the story is different. SABR can offer up to more than 95% local control with minimal toxicity. Also can use SABR again for different or sequential treatments as well. A retrospective series from UT Southwestern on 47 patients treated with SABR to 88 lesions. They offered 2 years local control of 91.5% with really low grade 3 toxicity. So the purpose of this study was to evaluate the delay in time to start systemic therapy as a surrogate for progression-free survival. This was the primary endpoint for this study, the delay to start systemic therapy more than a year in more than 60% of patients, with other secondary objectives, a modified PFS, we will come to this later, in addition to PFS of subsequent therapy, overall survival, cancer-specific survival, local control, toxicity, and quality of life. For statistical analysis, the number of studies is really small. 23 patients provided 80% power significance of 1 to detect 20% difference in 1 year at time to delay start of systemic therapy. Kaplan-Meier survival for survival estimates and mixed modal analysis for quality of life. They defined a pragmatic definition for modified PFS, which includes, they defined the events as any event not amenable for a future or sequential SABR, which includes more than 3 sites, new sites in one imaging, new sites of metastasis not amenable for SABR, a total of more than 6 sites of metastasis which require SABR, local failure in SABR already treated site, or development of brain metastasis. They use the RACIST 1.1 criteria, and while the development of a new metastasis objectively indicate failure in the context of systemic therapy, the story is different with the focal therapy, as you know. The modified PFS parameter provided an objective balance to the complex multifactorial subjective decision-making process to start systemic therapy. Between November 2017 and February 2021, they accrued 23 patients. Most of them, 17 of them had IMDC favorable risk. 19 were clear cell RCC. Almost all of them were systemic therapy naive. 33 lesions were treated upon enrollment, with 36 lesions sequential SABR in 11 patients. The most common site was the lung, followed by abdominal lymph nodes, and finally bone on the spine and non-spine. The SABR regimens were 25 grays in one fraction, and 12 grays times 3 and 8 grays times 5. Regarding the events, after a median follow-up 45 months, the modified PFS, more than 3 sites in one image occurred in 5 patients, new sites not amenable for SABR in 3 patients, a total more than 6 sites in 2 patients, and no failure in SABR treated sites, and 1 patient developed brain metastasis. 5 of those patients died, 3 of them not suitable for systemic therapy, while 2 died of unrelated medical conditions. Freedom from systemic therapy at 1 year was 91%, which is much higher than the pre-specified 60%. The median time to start the systemic therapy was 55.6 months. Eventually, 9 patients initiated systemic therapy. The median modified PFS was 40 months. And as I mentioned, SABR-treated sites had a local control of 100%. The PFS of subsequent therapy was 5.7% months. They received a first-line regimen of multiple combination of immunotherapy, as you see here. The overall survival and cancer-specific survival at 18 months was equal at 91%, while at 3 years, the overall survival was 68.7 versus cancer-specific survival 87%. Regarding the toxicity, there was only 1 case potentially related to SABR. It was a case of colitis, grade 3, and there was no statistical positive or negative effect on the quality of life. So the rate of a grade 3 toxicity was 4% in this series. As interpretation and impact, this is the first phase 2b trial for systemic therapy naive oligometastatic RCC. Prescribed benchmark was much exceeded, affirmed and extended upon prior retrospective analysis. It applied a novel objective criteria to define disease progression for subsequential local therapy and preserve quality of life. However, the limitation, we still need to validate patient selection criteria for those patients and small sample size, single institution, single arm study. Bottom line, SABR may offer a safe alternative as first treatment line for oligometastatic RCC, allowing for delay in the initiation of systemic therapy. However, phase 3 randomized trial still required. Thank you.
Thank you so much, Dr. Ramiz. Open room for questions, 1 or 2. Okay, so I'll ask you a question then. So Dr. Ramiz, so thank you so much for this. So tell us in your daily practice at KKC Cancer Center, when you're seeing metastatic RCC, what is the practice? Is it always jump on systemic therapy? Are we doing SBRT or SABR for these lesions to delay systemic therapy? You know, what's the input of the medical oncologists in those cases?
Thank you, Ibrahim, for this really nice question. Our practice, actually, just last week, we had a patient with only single lung nodule. In those patients, actually, we start with metastatectomy. But sometimes, if the patient has subsequent lesions or 2 lesions, for example, we took a biopsy from 1, or the radiologist is affirming those are metastatic lesions. Usually, we start with SBRT now. So actually, I think what's happening here, SABR is doing the job of metastatectomy, and now we have also ongoing clinical trials for SABR for cytoreductive, actually. Maybe Chang is more aware of that. So I think SBRT is starting to test the role of surgery here in the metastatic settings of RCC.
Got it. Okay. Well, thank you so much. Any other question? Or we can move. Oh, Dr. Rana. Oh. Leave a mic with Dr. Rana during the GU session.
To play the role for Hassan Ghazal. I don't know how many people know here about Hassan Ghazal. Okay. So I think it's an excellent study in one way. That I think in our MDTs, it gives us now ability to convince medical oncologists that yes, you can hold off a little bit. So I think, of course, the case selection is extremely important to me. As you rightly pointed out, single dot and a slow natural history of disease. And this is where we used to sometimes even used to just observe, not even metastatectomy. So those type of patients can we observe even longer by using SPRT. And I think I deal with my surgeons by saying that it's a multimodality approach. So it's a possibility that there is a peripheral lesion in the lung, and then there is a little bit not peripheral lesion in the lung. He can do a VATS procedure and chop that one off, and I can take care of the other two lesions in the lung. So similarly, there's a one bone, one lung. I can take care of bone, you can take care of lung. So it's a multimodality approach, I think. But the good point about this one, in my opinion, is that it now gives you a weightage in the MDT against this kind of discussion whether jump into systemic or not.
I totally agree. Yes.
Thank you so much.
Thank you.
We'll move on to the next talk. Thank you so much, Dr. Ramiz. So again, Dr. Chad Tag again to discuss the fast track and the fast track 2 clinical trials. This is for primary renal cell carcinoma. Thank you.
Great, thank you again. All right, so I'm here to discuss now moving on to the primary renal cell carcinoma. This is a pool analysis of fast track and the subsequent fast track 2 study presented by my good friend Dr. Siva at Astro this year or last year. Okay, so this is a graph showing the differences in total nephrectomy and partial radical nephrectomy in patients who have primary renal cell carcinoma. As you can see, there is a preference for a radical nephrectomy, not nephron sparing, over partial nephrectomy. Now, comparing different options for primary renal cell carcinoma, you do have partial nephrectomy, which is used in a minority of patients, interventional procedures such as cryo or RFA, and then the new kid on the block is SBRT. So the advantages of SBRT is that it avoids general anesthesia. We can treat difficult locations, parahilar tumors, tumors close to collecting ducts. We can treat larger tumors than both cryo or RFA. It's non-invasive. However, there's one disadvantage is that you don't get much pathology out of this. You don't get a pathology report after you do SBRT. So 5-fraction SBRT is very common, as you can see in here. But there's also other alternatives, 3 fractions, 1 fraction, depending on the size of the lesion. So what about these 2 studies? So the first study that was done was Fast Track. It's a single institution done by Dr. Siva at Peter MacCallum. It enrolled 33 patients between 2012 and 2014. And this led to the TROG Fast Track 2 study, which was multi-institution done throughout almost all of Australia, enrolling 70 patients with 70 primary renal cell carcinomas. The treatments that were done were very similar between the 2 protocols. It treated 26 gray and 1 fraction for small renal cell tumors, so less than 4 centimeters, or 42 gray and 3 fractions for larger tumors, greater than 4 centimeters. And this is considered to be a biologic equivalent for renal cell carcinoma. There's 2 different BEDs that are often used for this disease. One is 2.6 and 6.9. You can see it's very similar regardless of which of the 2 BEDs you're using. In terms of planning, there's generally an ITV done based on 40 CT. A 5 millimeter isotropic expansion is done for all these tumors. Here's a nice little 4D showing this motion. Fast Track 1 used predominantly 3D conformal radiation techniques with beam angles shown above, but IMRT was also used. And Fast Track 2, I think, predominantly used all IMRT-based techniques. Here's the different study characteristics in the patients. You can see here that they're pretty similar, about median age, a little higher in 70s. ECOG was pretty good, and you're generally treating T1 tumors, T1A, T1B tumors, with a median dimension of about 4.7 to 4.6 centimeters, very similar between the 2 studies. More patient characteristics in Fast Track 1, they enrolled pretty much all clear cell renal cell carcinoma. In Fast Track 2, they enrolled mixed histologies, which included the usual suspects, papillary and chromophobe for the most part. The median GFR was a little bit higher in Fast Track 2, about 61 versus Fast Track 1, which is 55. Here's the adverse events. as it can be seen here, there is only an 8% risk of grade 3 adverse events. There were no grade 4 or 5 adverse events. The most prevalent adverse events in grade 3 was abdominal flank pain, nausea and vomiting, or colon obstruction, as can be seen in the table. In terms of efficacy, there was only one progression after median follow-up in both studies. So that results in a 3-year progression-free survival or local control of 98% and 5-year also 98%. In terms of freedom from distant failure, the median follow-up of 3.5 years once again, we saw at 3 years is 93%, which fell modestly at 5 years to 83%. Cancer-specific survival, there was only one death associated with kidney cancer, which yields a 5-year cancer-specific survival of 98%. And finally, here are different competing risks for different types of failure events. Deaths did occur, but this was an older population. As remembered, at the time of enrollment, most patients were about median age of 70, mid-70s, 77, 75. So there were some deaths that occurred, but these were mostly due to competing risks, not due to the kidney cancer. So renal dysfunction, this is a curve showing the renal GFR over time. I generally counsel patients that what you would expect to see is at about 2 years, you have a plateauing of a GFR reduction. And this GFR reduction is about a quarter or so of your GFR in the beginning. So you can see here, the median GFR was about 60, and it plateaus at around 45, 40, 46 at about 2 to 5 years out. So the median size of 4.6 centimeters is significantly bigger than what you see in trials or retrospective series looking at IR techniques, and also for partial nephrectomy. There is the thermal ablation series, you generally see the size of about 1.9 to 3 centimeters. In terms of GFR reduction, renal function decreased at about 12 mLs per minute at 3 years and 16 mL per minute at 5 years, similar to other techniques. Only one failure was observed among 103 patients with SBRT, and the adverse event profile was excellent, with less than 10% rate of grade 3 adverse events. There were no grade 4 or 5 adverse events. As noted, most of these adverse events were due to flank pain or due to fatigue or nausea. There's a question about whether using steroids or antiemetics prophylactically is going to assist in this population. Finally, can we use different techniques to spare the functional nephrons and therefore reduce the GFR impact? I think more research seen in this space. So in conclusion, to our knowledge, this is the largest analysis pooling 2 prospective trials with 103 patients. High dose single and 3 fraction SPRT shows high efficacy, nephron sparing, and is safe. And the findings support use of this technique in patients with primary renal cell carcinoma. So thank you.
Thank you so much, Dr. Tang, for this very nice talk. I'll leave questions. Pretty sure we're going to have questions here. Yes. Dr. Saeed.
Thank you very much. I think an excellent study. But in terms of MDT discussions, we often come across patients who may have a problem going for surgery. Is this the patient group you're talking about? Because it's replacing partial nephrectomy, not radical nephrectomy. So in terms of preserving kidney function, how does it compare with partial nephrectomy? Because that's the question in the MDT, really.
Yeah, so I think if you look back, it's about equivalent to partial nephrectomy. And for patients that have like 4 centimeter, 3-4 centimeter tumors. And there was a recent analysis, the pooled meta-analysis that showed it was not very different than IR techniques, which is your other competing technique. So in terms of nephron sparing, I think depending on the size of the tumor, partial versus IR techniques, you're seeing equivalent results at about 2 years.
Dr. Rana?
Thank you very much. So yeah, I mean, first is the quick answer to Dr. Hamad said, because I work in the same population. So we have not been able to replace the partial nephrectomy with this one, but we are discussing this as a replacement of cryo and RFAs. So I had three cases last year, and the first one was gifted to me by a radiologist with a mass hanging very next to the bowel. We couldn't put that any RFAs or anything in it, and that's how I ended up starting my. And all three cases had a solitary kidney. So the last one I did had a solitary kidney with multiple lesions, again outlining the importance of multimodality because there were multiple tumors. So we decided to work with interventional radiologists. So he RFAs a couple, and I blasted one as well because otherwise patient was going to, and the GFR is still fine. It's 6 months now. My question to you is about in your practice, I find it very hard in terms of the response assessment.
Yes.
So what is your take on that one? Because MRI scans, biopsies, I mean, Dr. Muhammad Ali, we worked together for some time. So I worked on all my three cases. I worked with him from Peter Mac. So, I mean, so far I get a feeling that there is no consensus on that one. So I want your take on the response assessment. How can I convince my MDT that don't worry, radiotherapy is still working?
Yeah. So I think response assessment is what the urologist or the IR doc is going to kind of point at you in the conference and say, well, it's still enhancing. It's still the same size. It's worth noting in Fast Track 2, when Dr. Siva wrote the protocol, he took out the 3-month follow-up because it was too confusing. So he follows the patient after 6 months because it looks a little swollen after 3 months, and and then the report says it grew a little bit. Patients freak out. I think in terms of response assessment, this is a general problem that plagues all of radiation oncology. There is, reams of papers about response assessment after lung SBRT, whether you have pneumonitis or not, response assessment after gamma knife radiation therapy. We have to live with it. We have to kind of be okay with, being a little bit more nuanced and looking at the growth rates over time. That's all of radiation, I think. There's no going around that because you still have a mass that is there afterwards. So I think you have to be comfortable. You have to have radiologists you trust when they're saying it's a little bigger. You say, is it really a little bit bigger? And you have to kind of reassure the patients a lot of times and not scan too early. Yeah.
My problem is that it's not lung because here the urologist is sharpening their knife to go back in as soon as I say, well, or radiologists say, well, maybe radiation didn't work. So as soon as they see that lesion slightly getting bigger or still enhancing, they say, well, you've done your job, let us do our job now. So that is where, how do I convince them, no, it is still working. This is the difference between the kidney SBRT and the lung SBRT, in my opinion, because urologists are still on your back to say, I'm going to go and chop it off.
Well, that depends on who you have your thoracic surgeon too, because they can be on your back just as much as a urologist and sharpening their knives and trying to take the lobe out of the lung. I think what you need to do is you have to basically follow sequentially starting at 6 months and maybe not look at a 3-month scan and just rest assured and have the same radiologist read, because if you have different radiologists read, it starts getting confusing a little bit. But it's difficult. And I think you have to, as a MDT group, be comfortable with not rapid responses after SBRT.
Chad, I have a question. How do you, like when you start this program, you mentioned about the pathology, and I looked at the fast track, most of them had histological diagnosis.
Yeah.
So in your current practice, are you mandating a biopsy for these patients or not? And knowing that these are most patients are elderly and at high risk, are taking blood thinners. So and a lot of, in this part of the world, a lot of people fear the biopsy. They tell just take it out. Why do you want a biopsy? Biopsy can cause seeding, and biopsy can spread the disease. We hear this left and right, and even from some doctors as well. So tell me more about the technical approaches in getting this done at MD Anderson.
Yeah, so we don't mandate a biopsy per se, but we recommend it if we can, because sometimes you do have metastatic disease or a lesion that is equivocal and we're not sure. It's good to know the histology of that disease. We can compare it to any future sites. So we try if possible, but a lot of these patients, they're not anesthesia candidates. They're too old, too frail for biopsies. If it's not an option and the lesion is showing sequential growths over imaging over time, then we will be happy to do radiation without it. So when possible.
Just monitor it for, at least for the first scan, you won't treat, you will monitor for the next scan, see the growth and then treat?
Yeah. Anything less than 2 centimeters, we won't treat generally because we can just observe those. Anything greater than 2 centimeters, we probably would want to see some growth before we treat.
Dr. Bassem, last question.
Yeah, so thank you, Chad. You showed in your slides that the medium size is around 4 or 5 centimeter. Is there an upper size where you feel uncomfortable treating, and what would be your dose fractionation for these large tumors?
Yeah, I've treated very, very large tumors. I'm treating literally like a 15 centimeter one right now. If it gets too big, I start doing 5 fractions a lot more often. So I do 40 gray and 5 fractions, and they're so large, I can just boost the middle of it to like 50 or 60 gray because they're 10 centimeter tumors. I get a little bit worried about treating 42 gray and 3 fractions when it's so large and you can't look at every bowel interface because you're just bowel everywhere around it. So I start going down to 5 fractions in those. But usually the reason why they're coming to you is there's no other option. So, and they're starting to cause pain, starting to cause hematuria. So what can you do, right? So you just do the best you can. You're okay with a little bit less coverage on the PTV, GTV, and you just do the best you can, right?
Thanks.
Thank you. Thank you so much, Dr. Tang, for this great talk. Moving on, it gives me great pleasure to welcome Dr.𝗷𝗂 𝗕𝗲𝗀. Dr.𝗷𝗂 is the head of oncology at Dubai Hospital. He's a very avid clinical oncologist, unfortunately practicing medical oncology here, but he knows a lot of radiation, and he'll be talking to us about also a new abstract.
Thank you very much, Dr. Ibrahim and the organizing committee for inviting me. I'll be talking about this study looking at the role of apalutamide in patients with biochemically recurrent prostate cancer following surgery and the use with radiotherapy. Now, we have had lots of studies about use of hormone therapy in prostate cancer with salvage radiotherapy, but there's always lots of variation in the practice. And most recent data we had from the radical HT that 6 months was not that useful. It's probably 24 months, but 24 months obviously comes with toxicity. And it's quite challenging in the clinic really to discuss which patient should be receiving hormone therapy. And we use our clinical parameters normally, PSA, Gleason score, positive margins, nodes, etc., to decide. So this is the background of this study. So once you have a surgery, there's a very high risk of recurrence, and depending on obviously on the pathological features. So the term they've used, change the term now, they call it early secondary radiotherapy. I call it salvage radiotherapy, but I think you guys call it now early secondary radiotherapy. So lots of studies have been done, but there are not really any biomarkers to tell us which patient may derive benefit in terms of hormone therapy. And when we use it in unselected patients, lots of studies suggesting there's no overall survival benefit, although there is improvement in progression-free survival, PSA recurrence, metastatic-free survival, but overall survival gain we have not seen actually with any of the studies. And recent meta-analysis looked at low PSA levels, especially less than 0.3 or between 0.3 to 0.5. There was not really much benefit in terms of adding hormone therapy. So how do we select our patients who may derive benefit from hormone therapy? So what they've come up with is, PAM50, this is a 50 gene panel used in breast cancer. It's not in the clinic actually, but it's something they use to classify breast cancer into different subtypes. So that's what they have adopted into prostate cancer as well. So they've classified them into luminal B, and then others are non-luminal B or basal types. And what we see and that luminal B subtype may drive benefit from the hormone therapy. So that's the background. So this is the hypothesis that if you identify patients who are luminal B, they may drive benefit from hormone therapies. In this case, apalutamide, which is an androgen receptor inhibitor, is a drug that we use commonly in patients with metastatic disease. So these are the methods. So they've defined these patients who are node negative, so low risk patients, but PSA between 0.1 to 1. So I think they're limiting it to very low PSA levels overall. And then looking at other subtypes. So what about the margins of these patients? What about the P-SRT levels and the P50, PAM50 molecular subtype? So luminal B versus all others, which is non-luminal B. And they randomized them to 6 months of placebo versus 6 months of apalutamide orally. And then once they have evaluated the biomarkers, so this is how they're going to evaluate it, looking in the non-luminal B as well as the luminal B. And then we have the statistical analysis. So the primary endpoint here is the progression-free survival, and then number of key secondary endpoints, including metastatic-free survival, distant metastasis, and salvage hormone therapy use toxicity, because I think that's quite important as well. So these are the statistical analysis. They were aiming to recruit up to 276 to 324 patients. There appears to be a lot of appetite because they actually managed to recruit very fast as opposed to what they predicted. So lots of patients very quickly enrolled in the study here. So these are the results. So if you look at the patients within the study, positive margins, I was a bit surprised, 48-50% positive margins in this particular study. Is it something we see that often? Very high risk disease, T3 stage 55%, but majority of them are node negative. Again, looking at the, looking at the luminal subtype, so luminal B is almost 44% in both groups. And they also looked at some patient had decipher score, but obviously it's not the routine practice that we use this score. So these are the patients in the study. Let's look at the results of the study. Very interesting, actually, the patients who with luminal B subtype with 6 months of apalutamide, we see a very significant biochemical progression-free survival benefit. Hazard ratio 0.45. That's very significant for only 6 months of duration. Obviously, this is a small follow-up. What about patients who are non-luminal B? So this is very interesting, actually, no benefit. So I think selecting patients with luminal B subtype seems to drive benefit only with 6 months of hormone therapy. I think these are the take-home messages from the study. They also looked at other outcomes like metastatic-free survival, again, positive outcomes, so it's delaying the metastasis as well. And we did not see that in patients with non-luminal B as well. So selection of the patient, I think, seems to be crucial. And these are the survival, obviously, it's early data. Majority of the patients are living longer. We have very few patients who had any event overall. So far, no difference between the two groups. And this is looking at those events. What about toxicity? Obviously, 6 months of hormone therapy has some toxicity. Apalutamide in particular can cause rash. So for some patients, so that's reported again 5% in the study. And then the overall cohort, I think they looked at other side effects. There doesn't seem to be much significantly different between the groups. So in summary, I think it's the first study looking at the gene signature to validate, to prospectively validate this biomarker in this patient subgroup. So this is, I think, very encouraging data. I think probably we need more studies and a larger trial to confirm the benefit. With this, I will conclude. Thank you very much.
Thank you, Dr. Syed, for this. I'll leave room for questions.
It's very interesting concept. I don't know if we have access to PAM50 or not. But first, to answer your question about the 50% positive margin, that's perhaps biased for those people who are already returning for salvage radiation. The question is that, what do you think that if PAM50 is that strong predictive biomarker, and we still have confusion about use of ADT with radiation, not only for salvage setting, but even for the high risk and upfront, favorable, unfavorable, intermediate, and all kind of stuff. Do you think this proof of concept will translate into those studies where they can do that the same thing for ADT versus not ADT for other type of prostate scenarios with radiation?
Yeah, I think very important question. But PAM50 is not new, actually. It's been out for quite some time, but it's not in the clinic, unfortunately. So it's not commercially available for us to do it. So it's mainly investigational, even in breast cancer. So it's never been actually used commercially for us to deliver treatment. Maybe they may start to think about it. I think it probably answers the patients in the low risk category. I think in the high risk category, more node positive disease with doubling time, very short, high Gleason score, I think we are quite comfortable in giving longer duration hormone therapy. I think the problem is when we think about whether I should give hormone therapy or no, these gray areas, because some patients you don't want to give hormone and they may have a recurrence. And 6 months, we know from the data, there's not much difference. So I think maybe it is suitable for that group of patients to start with. but it is not yet available commercially. I don't know if someone can have more information about PAM50 being available.
I just sent it to our pathologist, actually. So I asked this question. Dr. Tang, you have a question?
I think PAM50 will become available as part of the Decipher grid. So it's not going to be the main Decipher score, but if you look, they have this whole grid that has PAM50, PORTOS, all sorts of other correlatives. It is a phase 2 study, so they're working energy right now to develop a phase 3 study. So I think they're going to try to confirm it before it goes, that's standard of care.
Okay, thank you, Dr. Tang. All right, so we'll move on for the next talk. Thank you, Dr. Tillman. So it's a great pleasure to introduce a dear friend of mine, of all of us, Dr. Saad Al-Rashidi. Dr. Saad is an expert in brachytherapy and the founding president of the Middle East Society of Therapeutic Radiation Oncology, MISTRO. He'll be talking, unfortunately, today about the SBRT in the part of radiation, but he's a prostate cancer expert and guru. So thank you so much for being with us, Dr. Saad.
السلام عليكم جميعا وشكرا لبروف حميد الشمسي على الدعوة الكريمة ولك دكتور أبو غيدة. Really, it's honor to be with my colleague here in UAE. And, as Dr. Abu Ghaida mentioned, I'm brachytherapist, but, it's okay really to carry whatever they assign me to do. And I will come after, it's tough to come after Dr. Rana, especially, he already presented the trial. So this is moving up and down. Sorry, I'm struggling, I think, with this. Can you please? Which one? I tried, yes. Okay. Now it's okay. So I think Dr. Rana already explained some of the trial aspects, so I'll go quickly here. So it's moderately hypofractionated IMRT, which is the American design trial 415, 70 and 28, compared to the British protocol or Dr. Dearnley, which is 16, 20. And comparing that to the ultra hypofractionated regimen, especially in they call it intermediate risk, but really those 415, they are ultra low risk and maybe like low risk patient with a small intermediate risk patients. So that's the study. And the patient allocation is 3+4 with PSA less than 10. Again, they are low risk patient with some intermediate risk patient, Gleason 6 and with 10 to 20 allowed. The other arm is as I mentioned, the 70 and 28, as well as allowed the CHIP trial 16-20. So the radiation technique, as mentioned by my colleague, Dr. Rana, really most of what we've been using in North America and Europe as well, who trained there is the CTV to the prostate, plus you allowed a little bit of margin to cover some of the seminal vesicle, and you allow the PTV with some reservation that Dr. again Rana alluded to. And the dose a little bit cooler. We used to even the Sunnybrook protocol 40 and 5, but here is a little bit colder as 38 gray to the GTV, or sorry, to the CTV. Also, some of the the technique characteristics is the use of the spacer, or what being used sometimes was barrigel, that we used to separate a little bit of the rectum and allow higher dose to the prostate, but it would be used 60%. And I'm not really sure, from the audience here, how many of you using the spacer here? I don't think it's feasible even in our region that you use the spacer, and the technique is a little bit need more training, more reproducibility. So it's a little bit tough to apply it to our region here. So the patient outcome, it compared some of the questionnaire that they use clinically to compare the patient and compare the two technique or the two doses. And the bowel or the EPIC survey, more than 4 points used, or urinary rotation, erective subsexual, as well as the other quality of life measures, including the sexual and use of the other hormone. So the result, as you see here, and I think it was also mentioned by my colleague, is maybe favoring, if you can see some of the domain here, the ultra-hypofractionated regimen, with some reservation, because I think it's already mentioned that you may be allowed a lot of margin with the really image-guided, strict image-guided daily CBCT with 8 millimeter. None of us probably are doing it anymore. So that's probably you would have a lot of radiation to the bowel as well as to adjacent organs. It is here with the analysis is favoring some of the some of the bowel domain as well as the sexual domain is in favor of SBRT. Same for urinary incontinence. Again, it was not really well defined. The surgeon will tell you at 1 year maybe they are the same. Here is not like it's a very flawed definition. Maybe at the 3 year they are the same. Who knows? So the urinary also incontinence is more in favor with the SBRT rather than the hypofractionated regimen. Same with the other like toxicity analysis, especially the grade 3. It's a kind of really, if you give ultra hypofractionated, that if you follow more, it may be really the opposite with the hypofractionation. So in summary of the key findings, significant fewer SBRT patient compared to the VMAT or image guide, the IMRT hypofractionation in terms of the sexual and bowel domain, and also the urinary incontinence at 1 year. So in context of the comparing of the other what's been published so far, it's a kind of like similar with SBRT again with a short follow-up. We need a longer follow-up to see the maturity, and also if you may be like catching some complication down the road, but that's what's been analyzed so far. So my take-home message from that is, I think it's too early. The limitation of the technique was done in a really good setup, focusing on 60% that's used the spacer. That probably will limit the SBRT complication, or if you are pushing the dose so high compared to the hypofractionated what we are using. So I agree with Rana, treat a lot of prostate, kind of maybe like 10% of my practice that I'm using the ultra hypofractionation. Again, with rectal balloon sometime, and sometime we use the spacer because we use it in our brachytherapy patient as well. So not really something that I will be adopting in the practice, especially in our practice here. Thank you very much.
Thank you so much, Dr. Saad. Leave room for questions. Yes. Quick, and we have one in the back.
Not Dr. Rana, because
no,
we already asked.
خلاص, Dr. Rana enough. He presented the first half. He cannot.
Thank you, Dr. Saad, for this excellent presentation. My question to you is, where do you see brachytherapy for prostate cancer in the future with the advent of SBRT?
Wrong question for Dr. Saad.
I kept it like an open question.
It's very irritating.
No, maybe it's going to be better or more. I'll leave it to you.
Still there is really a big role, especially with the high risk. You know, for me, like we're keeping it for, I think it's out of the context of the trial, but you know, for the high risk, we still boost the domain, as well as now with the new imaging, with the new finding, we even boost with the PSMA for the significant lesion. And for the high risk and the ultra high risk is really, again, it's promising. With the SBRT, comparing it to the SBRT, I think there are some, you may be aware, trial in the world, especially with the Sunnybrook trial that's running with the low risk and intermediate risk, that you know, you may compare the SBRT versus the brachytherapy for the intermediate or unfavorable intermediate risk prostate cancer. But you know, still we need like some years to mature and say, we don't need the brachytherapy. Maybe we'll go with this like, you know, fancy technique, and you know, We're so good at it. The challenging with this PRT is still really, which is I probably warn, like, not every center like to adopt anything that's done outside our region, is you need a strict preparation, and you need really a strict rectal manipulation, as mentioned. If you are really so good in doing the rectal isolation with the spacer or barrigel equipment or instruments, and you manage to keep the dose to the rectum solo, I think it's okay to maybe do it for the intermediate, but I still have some reservation for that.
Thank you, Dr. Saad. We have a question in the back.
Yeah, very crisp presentation, sir. My question was also the same. If you were to redesign this trial, do you think it would be a fairer comparison, SBRT versus brachytherapy for a particular set of patients?
No, the trial here is low risk, and it's a low risk and maybe favorable intermediate risk. So we're not comparing it to the brachytherapy. Maybe like if you are saying like we may compare it to the LDR, like the low dose, but especially the high dose, and the two fractionation brachytherapy, as you may know, failed already. So we cannot do it for the intermediate and low risk. I think SBRT is still maturing and maybe good for the intermediate and low risk, but I would not compare it with the brachytherapy.
Thank you so much.
And LDR already exceeded the 20 years follow-up, and we know that it's so mature, the result.
Thank you so much, Dr. Saad. So please thank Dr. Saad for us today, and thank you so much, Dr. Saad. I appreciate it. And then the last but not least of of the GU talks, it's the results of a very important trial that we've been waiting for. Going to be presented by Dr.𝗷𝗻𝗄 𝗕𝗲. Thank you so much, Dr. Ramez.
Hello again. Thank you, Dr. Ibrahim. I actually feel privileged to present this really important study. This is a hot topic, and it was debatable for decades in the history of prostate radiation oncology. The issue of elective lymph node irradiation in patients with unfavorable intermediate risk or high risk prostate cancer. So this is the 𝟑𝗿𝗓𝗄 presented by Dr. Makrosh, the well-known figure in prostate cancer. So nothing to disclose. The purpose of this study, as you know, is to assess whether prophylactic whole pelvic radiotherapy improves overall survival compared to prostate-only dose-escalated radiotherapy, which is currently the standard of care in patients with a protocol-defined unfavorable intermediate or favorable high-risk prostate cancer. So you should interpret the results in caution, because this is not the usual intermediate and high risk that we know. It is a protocol-specified criteria, as we'll go through now. 40 years ago, the local recurrence was the dominant mode of failure. However, after the introduction of dose escalation and ADT, the local control has improved dramatically. So now we are seeking the control on the lymph nodes. Most of you are aware of the old R2OG 9413. This study was launched in the early 90s. 2x2 design, testing the new adjuvant and adjuvant ADT with whole pelvis and prostate-only radiotherapy. At that time, it showed that a new adjuvant ADT and whole pelvic radiotherapy improved the progression-free survival and biochemical failure in patients with risk of nodal involvement more than 15% as per Roche formula, which is 2/3 of PSA plus Gleason -6 multiplied by 10. However, there was no survival benefit. There was major drawbacks on that study. So the question is addressed again using this R2OG 0924. So they aim to quadruple the size, aim to detect the small difference between the arms, made big fields bigger, small field smaller. What means with that, in the old R2OG, we used to cover the pelvic lymph nodes with field only with L5 S1 limit. Now we cover bigger volume to include the common iliacs at the level of L4, and the small field smaller We are talking here about the prostate itself. In the previous, they tend to include 12x12 or 11x11 fields. Nowadays, as you know, we include only the prostate with a few millimeters around. Leverage the dose escalation, and most of you are aware that dose escalation is nowadays standard of care, and refine patient selection compared with old R2G studies because they included patients with PSA up to 100. So they included localized prostate cancer with estimated risk of lymph node involvement more than 15%. They included unfavorable intermediate and favorable high risk, in which defined as Gleason 7 to 10 with PSA less than 50 and clinically early disease and no T3 disease, because this is predated the NCCN group definitions. They stratified patients according to the risk group, radiation boost, whether brachy and IMRT. Actually, what they did in the whole pelvic radiotherapy, they covered the whole pelvis with 45 grays, followed by boost to 79.2. Also, duration of ADT, whether short-term or long-term ADT. Keep in mind that the staging here was done using the conventional imaging, not the PSMA, because it was earlier than that. And the clinical staging actually was done with palpation using the DRE. The risk groups, Gleason 7 to 10 with early disease, PSA less than 50, or Gleason 6 with advanced disease or heavily involved cores more than 50% and PSA less than 50. In addition to Gleason 6, T1C to T2B and PSA more than 20. Again, according to the boost time, IMRT or brachy, duration of hormones, short or long-term ADT. The first arm was prostate-only radiotherapy with neoadjuvant hormones and boost to prostate and proximal seminal vesicle versus neoadjuvant hormone with whole pelvis radiation, then the boost. Just clarification, this is not the NCCN risk groups. As we mentioned, it was designed 5 years earlier. They included a subset intermediate from the R2G 9413, which is sandwiched between the older, again, R2G with favorable intermediate risk and the newer R2G 1115, which includes higher risk group for enhanced ADT. Nearly all patients on this study had a PSA 7 to 10 with a few bulky Gleason 6 disease. They started accrual in July 2011 till June 2019. They accrued 2,590 patients with ineligible percent was 4.5%. As you see the arms here, for both of them were equivalent regarding the demographic and clinical characteristics. Median age 69, 3 quadrants were white. There was almost equal distribution between risk groups. 85% had PSA less than 20, and 80% received IMRT, 20% brachy, and 2/3 received short-term ADT. The primary endpoint, as we mentioned, is overall survival, while the secondary endpoints were prostate cancer-specific survival, distant metastasis, biochemical failure, in addition to quality of life. It's important to mention here that the p-value for interim futility test was 0.018, which is not less than a strict protocol pre-specified p-value of less than 0.005. However, because the survival curves were typically identical and the low number of events, it was a favorable outcomes. So the research team decided to release the results now. Again, out of 2,473 patients, 30% received long-term ADT, 20% with brachy boost, 98% had a Gleason between 7 and 10. Median follow-up was 7.3 years. Only 64 patients had a follow-up beyond the 12 years point. Whole pelvic radiotherapy, unfortunately, did not improve the survival. The 10-year overall survival was 68 with hazard ratio of 1. Among the 514 total deaths, only 44 has been reported due to prostate cancer, and 139 were coded unknown, being adjudicated. As you see here, the overall survival curves were identical with hazard ratio of 1. Similarly, the prostate cancer-specific survival curves again were identical. Similarly, the distant metastases, there was no difference with hazard ratio 1.04. So there was, again, as I mentioned, no difference noted in the risk of distant metastasis. However, the cumulative incidence of biochemical failure, as per Phoenix definition, which is nadir plus 2, at 10 years was 17% in the prostate only versus 13% in whole pelvic radiotherapy. The hazard ratio here is 0.82, but as you see here, the confidence interval just crossed 1 here. So the two-sided test was negative, but the one-sided test was significantly positive. Another important observation, if you look at the biochemical failure curves here, you can see after 6 years of follow-up, the separation is getting wider between the both curves. There was a more GI grade 2 toxicity with whole pelvic radiotherapy with significant difference. However, the more important grade 3 and more, there was no difference between the prostate only and whole pelvic radiotherapy. Also, there were no differences between grade 3 and 2 GU toxicities between both arms. So as a conclusion, at 10 years, whole pelvic radiotherapy did not appear to improve overall survival for unfavorable intermediate or favorable high-risk prostate cancer. However, there is a relatively short follow-up with median of 7.3 years. Only 64 patients reached the 12-year follow-up. And as we know, most of prostate cancer-related deaths expected to happen beyond the 10 years. Shall we call this study negative? Macrosh is still against that before its time. He bought 2 studies. The first one, Igner et al., in which you can see that with time, the prostate cancer specific mortality increased between 10 and 15 years, increased by about 66%. And again, from the Scandinavian study data, which compared watchful waiting with radical prostatectomy, again, the risk is much higher at 20 years compared with 10 years. So conclusions, whether the early modest trend in biochemical failure will translate into differences in prostate cancer and ultimately overall survival remains to be seen. Future studies incorporate biomarkers may help identify subset of patients who might benefit from whole pelvic radiotherapy. The high prostate cancer survival rates with relatively low morbidity confirmed that ADT with prostate only radiotherapy is an excellent option for unfavorable intermediate risk and favorable high risk prostate cancer. Macrosh did this nice quotation from Albert Einstein sign at his office at Princeton. Not everything that counts can be counted, and not everything that can be counted counts. So Macrosh commented on that count what you can count and hope that it counts. I would add to that, count what you can count, but sometimes there is nothing to count. Thank you.
Great, ختامها مسك, great end for this extensive GU session. So maybe a question or two from the audience. Oh, you have 2. Dr. Eater. No, Dr. Eater. Keep the mic. You will ask.
Thank you. You're very lucky to have this presentation because I believe
really
that
important
was
one.
the most questionable trial that was presented the last Astro. So if you were following to the MedNet, you will find that this was the topic where we had lots of discussions. Do we treat nodes after this trial? Don't we treat it? And before the trial, we kind of feeling like safe when we were treating pelvic nodes as elective. And nowadays, when we have these results after 10 years, we don't really know that. And if we search for the guidelines, they don't say anything. They say this is the discretion of the treating physician. So it's us who decides what to do. And I want to really know your opinion. What do you think? For example, if you have a patient who has a risk of lymph node involvement like 80%, 70%, do we need a threshold where we treat the nodes or where we don't?
Thank you, sir. This is really the $1 million question. Actually, the NCCN guidelines pushed this into different directions and gave answer maybe to this question. Let's go back to 2019, as far as I remember, the NCCN guidelines in the radiotherapy protocols or guidelines, they endorsed the use of elective lymph node irradiation for unfavorable and high-risk prostate cancer. And they mentioned it is recommended. And in 2022, they changed the recommendation to strongly recommend elective lymph node irradiation, obviously after the BOP-RT study, which included a much higher risk group because 80% of that study had T3 disease and higher. Just 5 days ago, the 2026 NCCN guidelines just came out, and they said for unfavorable intermediate, it's not recommended anymore, explicitly like that. And for high risk, as you mentioned, it's left for the discretion of the radiation oncologist. However, they said if the risk of lymph node involvement more than 20%, then you can go and give elective lymph node irradiation. How I approach this in my clinic, actually, first, if there's multiple risk factors, patient young, in early 60s, fit, Gleason, locally advanced disease with a high Gleason score, the risk of lymph node involvement is really high, all the factors are really high, then for sure I would at least discuss with him the issue of elective lymph node irradiation. Add to that, in patients with query findings on PSMA, and we come through those a lot actually, if there is a mild uptake in the pelvic lymph nodes on the PSMA. So as a precaution, those patients, I would add whole pelvic radiotherapy as well. As you know, because we now use the new techniques with VMAT, arc therapy, so the toxicity, as you see here, is really low.
Just a very quick comment on that one, because this is such an extremely important trial.
Yes.
I mean, my history goes with RTOG 9413 for 25 years, because in England, first Macrosh messed up our protocols in England. We never used to do pelvic radiotherapy. And then 9413 published, and we started selecting patients for pelvic radiation. And then he published the negative result. So I challenged him in ESCO nearly 20 years ago, and he got angry, and he was talking the same kind of comments you were talking about, quoting Albert Einstein or all kind of stuff. I think that is the reason they read this trial. But the best part I want to highlight is that in England, we found it very hard to go backward and say, how do we define the patients who are not going to treat pelvic lymph nodes in high risk? I think the timely publication was from Anthony D'Amico, where he published the data from the Macrosh equation itself. And he said that when Macrosh equation was invented, mathematical modeling, 15% meant that the actual risk was 8% for lymph node positive. But in the contemporary series, if you apply Macrosh equation mathematical 15%, the actual risk is only 3 to 4%. So he suggested that instead of ditching the idea completely, we should raise the bar to 30% Macrosh equation, right? And that is what I have practiced all in my life. And this is what many people in England now. And if you plug in Macrosh equation more than 30% risk, I think that will follow those patients you're talking about for the ultra high risk patients. So in conclusion, my answer to that question is that if you have a patient sitting in front of you and you apply Roche equation and the answer is more than 30%, mostly these are those patients who you are going to give ADT for 18 months or more. So that is another clue. In this trial, 2/3 of patients had short course of hormone treatment based on investigator choice. That already told you that these patients did not have high risk because investigator was only giving them short course of hormones treatment. Only 1/3 have high risk. So technically, if you have a patient who you are going to give 2 years of hormones treatment, or the Roche equation is more than 30%, those are the patients. I think we should go ahead and give them the pelvic radiation rather than completely ditching it, leaving Einstein aside.
I totally agree, Rana. Actually, I think, again, as you mentioned, the problem here is with the eligibility criteria. Actually, I had this discussion with Makrosh himself. I remember in the ASCO GU in 2018. At that time, the PROTECT study was just published. So I was asking him that, because many of the patients here in this study with favorable or Gleason 7 were actually eligible for the PROTECT study. So I asked him that the whole radiation failed to provide any survival benefit in those patients. How do you expect that adding whole pelvic radiation electively would end up with overall survival? So maybe, as you mentioned, those with higher risk group or those with, again, according to his equation, 20% or 30%, maybe the better patients who would receive benefit from whole pelvic radiotherapy.
Wonderful. So I think this trial raises more questions than answers them, but it's great. So thank you so much. I'd like to thank all the GU speakers for this very, very heavily session. We'll move on to the better half, which is the gyne oncology. It's been my pleasure to introduce Dr.𝗂𝗂𝗧𝗏. Dr.𝗂𝗂𝗧𝗏 is a radiation oncologist working with us at 𝗓𝗏𝗬 Medical City in Abu Dhabi, Mohammed bin Zayed. She's been with us from day one. She will be moderating the session. So thank you, Dr.𝗂𝗂𝗧𝗏.
It's my pleasure to welcome our first speaker, Dr. Zainab. She is a distinguished radiation oncologist with over 15 years of experience in the high precision radiotherapy, including IMRT, VMAT, stereotactic techniques, and brachytherapy. She has advanced training from Georgetown University and also a member of ASTRO. Dr. Zainab, all yours.
Thank you. Thank you so much for the kind invitation and congratulations for the best of ASTRO. So here I'm going to talk about the impact of MMR status versus the clinical pathological risk factors on locoregional recurrences in stage 1 endometrioid adenocarcinoma, patients treated with brachytherapy alone. So to start with some context, like the endometrial cancer is the 4th most common cancer and the 5th most common cause of death in women. In 2025, there is estimated 6,900,000 new cases and about 1,400,000 deaths among the world. 5-year survival is 81%, and it's the only cancer with decreasing survival in the last 4 decades. So most of the patients present with localized disease, so it carries a high survival, should be 95%. So traditionally, the treatment or management of endometrial cancer was driven by the total hysterectomy with axillary lymph node dissection of the pelvis. And then the adjuvant treatment is being stratified according to the clinical pathological stage, as in the big trials of the PORTEC and the GOG trials. The recommendation now of the molecular profiling and the MMR testing is more incorporated into more of the clinical guidelines. So to understand some biology, there are four hierarchy of the molecular profile of the endometrial cancer. Among this is the MMR proteins, which is the four proteins mainly driving the MMR, which is MLH1, PMS2, MSH2, and MSH6. There are three kinds of deficiency in the MMR. The first one is the autosomal dominant germline mutation that leads to the Lynch syndrome, which is a minority of cases, around 3%. The second most common is the somatic deficiency of the MMR, which is the loss of one or more proteins. The third common, which is our focus today, is the MLH1 promoter hypermethylation, which is usually with the deficiency in MLH1 and PMS2. In their primary results, they found that most of the recurrences happening in the MMR deficiency, like 71% of the local recurrence-free survival. So that triggers an alarm that it's not only the clinical pathological stratification. And they found even regardless the local treatment of external beam radiation therapy, these kind of patients, they have the most pelvic recurrences. So to address these findings, they narrow in their analysis after this trial, they narrow the patients to only stage 1 disease, which receive vaginal Volt brachytherapy alone, and they excluded 14% of the stage 2 and 22% who received the external beam radiation therapy. And the aim is to examine the impact of MMR status on pelvic recurrence-free survival in a homogeneous cohort of stage 1 endometrial carcinoma, status post-surgical staging, and received brachytherapy alone. So they included stage 1 endometrioid carcinoma in a multi-institutional retrospective cohort, about 11 North American institutions. All the patients receive hysterectomy and lymph node dissection. All of them have a non-MMR status, received vaginal Volt brachytherapy as adjuvant therapy, and then subsequent standard of care follow-ups. So the exclusion criteria was all non-endometrioid histology, whoever received chemotherapy or whoever received external beam pelvic radiation were excluded. The endpoint was the pelvic recurrence-free survival, include vaginal and pelvic recurrences, and the distant recurrence. So after exclusion, there were 478 patients. Like 1/3 of them were with deficient MMR, and 3/4 of them, which is 110 patients, with MLH promoter hypermethylation. The strength of this trial is the homogeneous cohort. Like all the patients were stage 1, all of them had surgical nodal excision, and the median nodes sampled were 10, median tumor size was 3.8 centimeter, and the median follow-up was 37.5 months. So in multivariate analysis, they found that the MLH promoter hypermethylation were in elderly patients and were in higher grade 2 and 3, and almost coming on the high intermediate risk group. And surprisingly, there was no significant difference in the lymphovascular invasion, tumor size, or the depth of the myometrial invasion. So in general, the findings that the pelvic recurrence-free survival was relatively high, it's 95%. But when they look more into the MMR results, they found like it's 2% only in the proficient MMR, while it's 7% in the somatic deficient MMR, and 16% in the MLH1 promoter hypermethylation. But in generally, it's a low incidence. In their multivariable analysis, they found that the deficient MMR is the only variable that led to a high pelvic recurrences with a hazard ratio of 8.4. And also the provoking findings about this trial is the MLH1 promoter hypermethylation predict both the pelvic and the distant metastasis together, 9% and 10%. So there are multiple ongoing trials currently exploring the MMR, like in the PORTEC trial, which they are stratifying stage 1 and 2D MMR into both arms, the vaginal brachytherapy versus external beam radiation therapy. The Rainbow Green trial, which stratifying the higher stages, stage 2 and 3, between external beam radiation therapy plus or minus durvalumab. And the PORTEC 4A trial with stratifying stage 1 and 2 DMMR between vaginal brachytherapy alone or the molecular profile-based treatment. But how MLH1 promoter hypermethylation fits into this, it's still a question. So there are several limitations of this trial, which is it is a retrospective design, relatively short follow-up, the lack of poly and P53 testing, because we know the hierarchy like among the poly, which carries the best prognosis, and the P53, which comes the least prognostic factor. Low number of recurrence events, which is a limiting statistical power, inability to quantify lymphovascular invasion due to recent standardization. But in conclusion, the somatic deficient MMR and the MLH1 promoter hypermethylation are prognostically very significant. The MLH1 hypermethylation patients were older, more than grade 2 and 3 tumors, and a high intermediate risk. Worse outcome comes with higher rate of vaginal and pelvic recurrences. Clinical implication of MLH1 promoter hypermethylation represent a prognostically distinct subset of dMMR endometrial carcinoma. The treatment impact findings support prospective investigation of this treatment escalation. So future studies will be needed for this promoter hypermethylation. And thank you for your attention.
Thank you, Dr. Zainab. Any questions from the audience?
They're all very complicated.
Yes. Maybe I will ask one question to you, Dr. Zainab. So do you think now with the advent of molecular biology, there should be a shift in the decision of the treatment options, especially for the stage 1 endometrioid cancer patients?
Definitely. In my opinion, a molecular profile is a must as like a template in the pathology of any endometrial carcinoma. To start from poly, if the poly is showing some investigation or some findings, there is no need to go for the hierarchy. Otherwise, we have to do the P53 and MMR. It's incorporated in many of the labs nowadays.
Yeah, and it's coming up in the guidelines as well. But have you started in the real practice following based on these?
For the P53, yes, we have. But for the poly, still we don't have it in-house. We have to send the specimen. So it's by request, patient to patient.
And how about MMR status?
Yes, we have it.
You are stratified in
yes. Okay. But not in the sub-classification of the MMR. It's only deficient or proficient.
Okay. All right. Thank you.
Thank you.
Okay. Now moving forward to the next talk, which will discuss the implications of advancement in the systemic therapy in the high-risk endometrial cancer. It's my pleasure to introduce our next speaker, Dr. 𝗿𝗱 𝗕𝗲𝗀. She is a Chief Medical Officer and Head of Radiation Oncology Division at Christina Keele Oncology Center at 𝗂𝗂𝗬𝗎, Georgia. She is dual board certified in radiation oncology as well as radiology and has completed international fellowship training at United States. Welcome, Doctor.
Thank you. So I think I'm also listing the
lucky presenters and speakers here because the clinical trial I'm going to speak together with you today is very also controversial and interesting because we are radiation oncologists, and all the time when we are talking about radiation oncology, we have so many new drugs, and we want to dig down what type of interaction does this immunotherapy drugs have together with the radiation therapy. So today we are talking about the keynote 𝗵𝗿𝗀 clinical trial, which was a G1 trial for the high-risk endometrial cancer. So these are learning objectives. And as I am talking about the proficient MMR status for endometrial cancer, I will try to be time proficient at the same time. So as we know, as my previous speaker told, endometrial cancer is the cancer in where we see the increase in mortality. While we're making steady steps to decrease the mortality, we're actually seeing the increase. So it's evolving as our treatment evolves, and high-risk endometrial cancer stays the area with the unmet need. Maybe we are doing something wrong. So estimated 5-year survival is around 60% coming from the PORTEX-3 and GOG2 58 clinical trials. And you see different IDs of this clinical trial, but actually it's a one trial. So I will refer it 𝗵𝗿𝗀, and this is because it was registered by different groups in different parts of the world. So just to remember from the previous manuscript, what were the results from the primary interim analysis is that they did not find improvement of DFS in the all-comers population, but they did find the overall not overall survival, disease-free survival benefit in the dMMR subgroup. Now we have a third interim analysis when we have the pMMR subgroup analysis. And these are the key eligibility criteria when they involve high-risk endometrial cancer. This could be stage 1 or 2 with non-endometrial histology, or it could be P53 expression, aberrant expression, or mutation to include in the high risk. And if you talk about stage 3 and stage 4, they were included regardless of the histology. So again, this trial randomized between chemotherapy plus pembrolizumab compared to placebo and chemotherapy together. And radiotherapy was left optional. This is, I think, the key point here, because radiotherapy was left at the discretion of the treating physician, because investigators wanted this clinical trial to be as inclusive as possible. And this trial never asked the question if the radiotherapy is effective for this kind of patients. We do it more or less of radiation in this group. And after the randomization, the group was stratified with the pMMR status to differentiate between dMMR and pMMR tumors. And in the pMMR stratum, they defined the strategy of radiotherapy. They also stratified according to the histology and FIGO 2009, which is quite different from what we have now in 2023. So primary endpoints were DFS and overall survival, but I can tell you that this clinical trial is still ongoing, not recruiting already, but overall survival data is not mature enough for the publication. So quality assurance is really high. It was done under the IROC, which is the RTOG energy group. And being optional does not mean that this was not like the standard of treatment during this clinical trial, because minimal dose of the external beam radiation therapy was 45 gray, and brachytherapy could be given as the addition to the external beam or alone. So demographically, it was a very balanced clinical trial. So 60% of the patients were white. Lymph node involvement was noted in 40%, and the histology also was well balanced. And in the pie chart, you can see the difference, the stage distribution between the groups, how radiation therapy was used. So it's very important, because if you look at the external beam radiotherapy group, you will see that with or without actual brachytherapy, the patients involved in this kind of treatment were mostly stage 3. But if you look in the middle to the brachytherapy alone group, it was mainly stage 1.
This is kind of very interesting slide because it shows how we use radiotherapy across the world. So globally, 65% of the patients in this clinical trial got radiotherapy. But if you see South America, it was almost 96% who get radiotherapy. And Europe also favors in radiation therapy. But if you look at the East Asia, we have completely different picture here. And looking to digging down inside, if you look at the Japanese group, they did not use radiation therapy for any of those patients. One could have an impression that Japanese group only involved very early stage 1 non-endometrial histologies in their group, but actually that's not true, because if you look at the data, we will find that 55% of the patients who never got radiation in this trial were actually stage 3. And this value stays the same for South Korea and Taiwan. So this is very interesting because during the chart rounds and tumor boards, we are asking this question. So in the adjuvant settings, do we give brachytherapy? Is it external beam? Is it the combination? And when we are talking about the adjuvant settings, it's not always easy to define what is the impact of each of those kind of treatments. And if you look here, the curves are almost the same. But in favor of brachytherapy, which you see on the first line with the light green, this is because of the stage distribution, because they included stage 1 patients for this treatment arm. And addition of cisplatinum did not really affect the survival course, and this is specific-free survival. Here you will see at 12 months and 24 months, this is almost the same. But I don't think there is problem with the efficacy of concurrent cisplatinum. This is probably the reason of this is probably the selection bias of the patient for the concurrent treatment. And here also we see that for each groups, the disease-specific survival reflects the stage distribution. In the middle, we have the brachytherapy alone group, and survival and disease-free survival is quite different from that group. But what we see, this is a consistency between these 3 distribution groups, because we know that there is no any consistency of the radiation where pembrolizumab adds extra value for survival. And for the whole trial, this is, I think, the most important slide here, because we see what type of recurrences this patient had. And you see here in the green color that the most recurrences this patient had, doesn't matter what type of treatment it was mostly distant recurrences. But the patient who got brachytherapy alone, this is the patient who got the local recurrence rate as much higher as the patient almost who'd never get any type of radiation therapy. And this is kind of slide which gives us idea that radiation therapy not giving any extra benefit for this specific survival, it's still doing what it has to do, because this is decreasing the local recurrences, and this gives us the pelvic control. This is the stratification according to the histology, the endometrioid histology. There you see the stage 1, stage 2, stage 3, and stage 4, and there is no extra benefit of radiation therapy here. And it's very thought-provoking when we talk about non-endometrioid histologies, because if you look down to the curves which reflects the stage 3 and stage 4 together, with or without radiation therapy, these are the groups who benefit most. And this is very important to note. Adverse event was very well tolerated. There was no extra additional adverse events in context of pembrolizumab, and this is kind of the information we should note before we start new clinical trials in future. So in conclusion, in the pMMR endometrial cancer, pembrolizumab did not affect the survival over the disease-specific survival, so regardless of radiotherapy, and patients who got external beam radiation therapy had fewer local regional recurrences. And analysis showed that in stage 3 and stage 4 non-endometrial histologies had the most benefit from the radiation therapy, and safety was manageable. This is acknowledgement of all centers who participated in these clinical trials, and Merck was the sponsor of this trial. And thank you for your attention.
Dr. Ita. Any questions from the audience? Yeah. Dr. Anaya.
Thank you very much for excellent presentation. I think this study, Pembro, not really working in proficient MMR is not really a surprise, but most of the slides were just showing exploration of role of radiotherapy, in my opinion. And that is also very, very interesting because in Europe, we did PORTEX studies and in Americans under GOG were showing that in stage 3, you don't need to give radiation. And in PORTEC, we were saying in stage 3, you don't need to give chemotherapy. So those studies published at the same time as well and made everybody confused. And as you highlighted that the difference is only in terms of where your recurrence is going to be. So do you think that this study adds into that American version of saying that in stage 3, if you are doing an optimal systemic chemotherapy after full surgical staging, which we sometimes don't do in Europe, we don't do lymphadenectomies in all patients. So if you do a proper surgical staging with lots of lymph node resected and you are giving optimal chemotherapy to these patients, do you think that this study is agreeing with American concept of saying that there is perhaps no need of pelvic radiation?
The first thing is that radiation therapy was not randomized, it was stratified, but it still gave the information to us. I believe this is the additional value of this study is the histological classification of high-risk endometrial cancer. So they never say this is the same for each histological type. They stratified between the endometrial cancer and non-endometrioid endometrial cancer. And they said that probably the radiation therapy is the most effective for the stage 3 and stage 4A non-endometrioid histologies, which we know is the serous carcinomas, it's the carcinosarcomas, it's a clear cell, which probably has the worst outcomes that we predict while treating this kind of patient. And I think, yes.
Any more questions? Okay, I think we're done. Thank you.
Thank you.
Dr. Ijaz. Let's move on to the next session, head and neck cancer. We have Dr. 𝗷𝗚 to moderate the session.
Assalamu alaikum. I think we're ready to start our head and neck session. We're happy to be here. Thank you, Dr. Ibrahim. And I'm more happy to introduce our first speaker, a dear colleague, Dr. Mohammed 𝗷𝗱, a radiation oncologist at King Faisal Specialist Hospital Research Center, well accomplished, not just for being the ASTRO ambassador. Dr. 𝗷𝗱 is also the chair of the graduate medical education at the center and has a lot of contribution in the education program at the level of the Saudi program. Without further ado, the stage is yours, Dr. Mohammed.
Thank you so much. It's been a pleasure to be here today. First of all, I'd like to thank the organizing committee for this opportunity. I'm going to present a TORPEDO trial. The result of this trial was shocking and it was presented at the plenary session in ASTRO. It's a toxicity reduction using a proton beam therapy for oropharyngeal cancer, a phase 3 trial of IMPT versus IMRT for multi-toxicity reduction in oropharyngeal cancer. So as we all know, the management and standard of care for locally advanced oropharyngeal cancer is the IMRT with high-dose cisplatin concurrently. Though we achieve excellent oncologic outcome, the issue with severe late toxicity is concerning. There is a large deterioration in health-related quality of life measures, and there is numerous observational data suggested that clinical advantage of proton beam might mitigate those late toxicity over the IMRT. Mostly speaking, the weight loss as well as the G-tube dependency in 12 months in favor of the proton therapy. So there is a need for randomized clinical trial to justify the use of proton given the increased treatment cost. So this is a phase 3 randomized clinical trial targeting oropharyngeal squamous cell cancer patients requiring concurrent chemoradiotherapy and bilateral neck treatment. They randomized 2-to-1 more with IMPT versus IMRT. The total dose of radiation is 70 gray in 33 fractions, along with high dose cisplatin, 100 milligram per square meter, given week 1 and week 4. And their primary objective is to assess whether IMPT compared to the IMRT is associated with the reducing late toxicity. And they have two outcome, the clinician reported co-primary endpoint, and they use either the significant weight loss, grade 3, 20% or more compared to the baseline, or the G-tube dependence at 12 months. The other cohort is the patient's reported output, the patient's reported endpoint, and they utilize University of Washington Quality of Life Physical Composite Score at 12 months post-radiotherapy, and they target the symptoms that is really burden on patients: saliva, taste, chewing, swallowing, appearance, and speech. So to ensure a valid comparison between IMPT and IMRT, they did really extra and good job with quality assurance and make it centralized in the United Kingdom. So in terms of the radiotherapy, they use the same organ at risk, target, and constraint. They use the same plan optimization prioritizations parameter, and they use fully optimized function sparing radiotherapy. And then they also have a national radiotherapy trial quality assurance where all being prospectively collected the informations. And in terms of the supportive care and patients reported outcome measures, they make it central as well, and it's independent from the treating clinicians, and they test a covariant for analysis of the primary endpoint based on the T, end staging, smoking history, PMI, and the baseline of quality of life physical composite scores. So they recruit very well over 3 years, and they complete their accrual ahead of the schedule. They have 20 centers in the United Kingdom, and if the patient gets randomized to a proton, they need to travel to Manchester or to London to receive the proton therapy. And they calculated their sample size to be 201, and they have 205. This is the concert of the trial, 2-to-1 randomizations favoring IMPT. They have a limited number of withdrawal. They did not allow crossover between the arm of the trial, and they have a great data that's available for analysis. The baseline of the study and patients' characteristics is well balanced. Median age is 57 years, majority being male, white, employed, and almost half of the patients cohort were T3, T4, and only 20% they have bilateral neck involvement. 1/3 of this cohort either current smoker or have a heavy smoking history. And the compliance to radiotherapy and chemotherapy was excellent. So the result, the first cohort is the clinical co-primary. There were 178 patients evaluable for the result at 12 months. For the feeding tube was extremely low in the IMPT and IMRT, only 1.7%. However, for the weight loss, that's surprising. It is much worse with the IMPT, almost 18%. That is triple the amount of weight loss seen with the IMRT. And if we have two composites of those factors, the IMPT did worse compared to the IMRT. And the author thinks that IMPT did not decrease the G-tube dependence or weight loss at 12 months. other is the patient's reported outcome. They have 154 evaluable patients at 12 months post-radiotherapy. And when they did University of Washington Quality of Life physical composite score for the symptoms, saliva, taste, chewing, swallowing, appearance, and speech, there were no different in the IMPT or IMRT. And they also did a pre-planned analysis with using MD Anderson dysphagia inventory score, MDADI, and there is also no difference with IMPT or IMRT for those. So here's the quality of life physical composite score with time interval shown in the x-axis. The IMPT is in blue color, the IMRT is in red color, and you can see initially IMPT doing better with the physical composite score until we reach week 6 post-radiation, and moving afterwards, it's coming the same, and in 12 months post-radiation is almost identical. And looking into specific symptoms, appearance is the same between IMPT and IMRT at 12 months post-radiation. Similarly with the speech. Swallowing at 12 months, there is no difference between the two modality, as well as chewing, taste, and saliva. So despite I don't have a better in clinical symptoms and quality of life, but clearly the IMPT showing that it's associated with reduced dose to the organ at risk, namely the contralateral parotid gland, oral cavity, larynx, inferior constructor, and swallowing muscles. It's all in favor of the IMPT, but no clinical benefit and no effect to the quality of life. And in Netherlands, where they use a model-based enrichment to decide which patients is going to receive proton therapy based on a model that's taken into account the normal tissue complication probability, and if this patient has a higher risk on complication, that those patients receive the proton therapy rather than photon. Here, they look into these patients. 50% of the patients are eligible as per the Netherlands criteria, and then there is no difference with the quality of life measures. There is the good thing that there is no difference in local regional control or overall survival. Both arms did extremely well. The IMPT in local regional control is 94%, IMRT is 97%, and overall survival is 95% at 2 years. So the author conclude that for local advanced oropharyngeal cancer, there is no benefit of the IMPT compared to the IMRT. If you have a good quality, full optimized IMRT, this will outperform in terms of better late toxicity and better quality of life, and physician and patients assured no requirement to access IMPT. This is the thanks of the author. And this research was funded fully by UK Cancer Research. Thank you for your time.
Thank you, Dr. Mohammed, for the excellent talk. And as we're heading to lunch after, we'll allow for one question. Okay.
Yes.
So as you mentioned, this was like a troubling study for many centers, right, in the US, because it brings the ethical and moral question, which is what do you do now, right? So I'm curious, in your practice, if you have access to proton therapy, are you going to send all your patients to proton now, or what you should do?
Yeah, so I think, as you said, this was after Dr. Stephen Frank's study. It's clearly a proton in oropharyngeal cancer is beneficial, and there is also a hint of overall survival advantage as well. And now this came, and so now there is 2 ongoing randomized study that I'm aware of. One in Scandinavian country, early tonsil cancer, the randomized photon versus proton. We are eagerly waiting to see the result of that. The other one is the $35. But $35, they took a different approach that they based on the Netherlands model. They expect who will benefit more with the proton, then they will randomize between proton and photon. I think the result will depend on those two clinical trials.
Thank you.
Thank you very much for the excellent talk, Dr. Mohammed. We'll now like to invite the next speaker. I'd like to invite Dr. Bassem Youssef, who we introduced earlier from AUB, Lebanon. He will be talking to us about the DART phase 4 study.
Hello again. It's my pleasure now to present this very interesting study from the Mayo Group entitled Phase 4 Analysis of De-Escalated Adjuvant Radiotherapy for HPV-Positive Oropharyngeal Cancer, a pooled analysis of the MC1273, MC1675, and off-study patients. So we'll start with a quick background. The same Mayo Group has previously published the phase 2 trial and the phase 3 trial in patients with resected oropharyngeal cancer. And what they did is that instead of using the standard adjuvant radiotherapy dose of 60 gray, they used a much lower dose, which is 30 gray total dose given as 1.5 gray twice daily over 2 weeks with concurrent chemotherapy. And the initial results were quite interesting with very high progression-free survival of the patients. So what they showed is that toxicity was less, and they also showed that outcomes were very good except for the patients who had pathological N2 disease. The objectives were to characterize patients off study. So what happened is after these 2 publications, additional patients were treated off study. So in this study, they wanted to compare the outcomes between those patients included in the studies and those who were not. They wanted to understand if cancer control rates are similar, and they wanted to determine the overall effectiveness of those de-escalated radiotherapy in this large cohort. The methodology, it was a retrospective cohort study. All patients received de-escalation, including the MC studies. The dates were between September 2013 and April 2023. The exclusion criteria was history of prior head and neck cancer, pathologic T0 or T4, the use of induction chemotherapy, and unknown HPV status. The comparison between the on and off study groups was done, and they looked at oncological outcomes, including local recurrence, progression-free survival, distant metastasis, progression-free survival, survival, disease-specific survival, and overall survival. So from a total of 705 patients, eventually 282 patients received de-escalated radiotherapy, and off-study were 106 patients, whereas on-study were 176 patients, receiving the dose described previously. I had to add that patients who had evidence of extracapsular extension received an integrated boost to up to 36 gray. When we look at the characteristics of the patient, the majority had T1 or T2 disease. There was more patients with pathological N2 in the on-study group because eventually off-study, much less patients were included, only 3.8%. When we look at the survival outcomes of the studies, looking at the overall cohort, the outcomes were very good. When we look at the progression-free survival at 2 years, it was 93%, whereas at 5 years, it was 87%. The rest of the oncological outcomes were excellent, all approximately reaching 95%. When they looked at the progression-free survival of the entire cohort, it was close to 95%. When they looked at on and off study patients, there was no difference between the 2 groups. Now, in these Kaplan-Meier curves, we see that there were inferior outcomes for patients who had evidence of extracapsular extension, with a 5-year progression-free survival of 80% versus 95% for those who didn't. Similar poor outcomes were noted for patients who had pathological N2 disease. which were close to 55% at 5 years. So looking at the overall cohort with consideration of the pathological end stage and ECE status, we see that the group who did the worst was again patients who had pathological N2 disease. So the key points in the study were that the characteristics were similar, except fewer PN2 patients were de-escalated off study as anticipated by the previous NCA results. The 2-year oncological outcomes were similar between on and off study groups, with local regional failure-free survival of 97%, progression-free survival of 93%, and a very high overall survival of 98-99%. Patients with intermediate risk disease had excellent 2- and 5-year progression-free survival of around 97% with DART. And this is similar to previous de-escalation studies below. When they looked at the limitations and future directions, so in their institution, there was a standardized practice with intraoperative frozen section to really make sure that the margins are negative, and they had a relatively homogeneous patient population. There was no real definition or reporting of elective nodal irradiation. Was it 1 millimeter, less, more? It was not really defined. And it's unknown whether 30 or 36 gray delivered as 1.5 gray BID or as 3 gray once daily makes any difference in terms of toxicity, knowing that once daily is more convenient for most patients. In conclusion, patients treated with DART on and off study had excellent oncological outcomes, and this regimen has shown decreased toxicity comparing to standard of care. For patients with intermediate risk, meaning PT1, T3, without elective nodal irradiation, DART represents a standard of care at their institution. As for patients who have extranodal extension, further selection criteria may be helpful for those de-escalation. And with this, I thank you for your attention.
Thank you very much for the excellent talk. We'll have room for just one question. Dr. Thoraya.
Thank you, Dr. Yusuf, for the presentation. Would you be confident applying this on our population, given the fact that our biology is always aggressive disease?
Thank you for this question. To be honest, like in my country, and I'm sure in many Arab countries, the incidence of oropharyngeal cancer is so little in comparison to the Western world. And I really noticed that when I did my fellowship 10 years ago, when I went to the States, like the vast majority had P16 positive oropharyngeal cancer in my head and neck rotation. Whereas in my previous 13-year practice, I have seen, I would say, 1 patient per year on average. We have such a low incidence of HPV positive oropharyngeal cancer. Adding to that, most of them are diagnosed with locally advanced disease that I have treated with concurrent chemoradiotherapy. I cannot really think of a patient who underwent resection and was referred to me for adjuvant radiotherapy. So looking at the really positive results in this trial for these select patients with intermediate risk group that do not have these adverse features, no pathological N2, no extracapsular extension, I think I feel comfortable offering this dose de-escalated treatment in case if I face any of these patients in my practice.
Thank you very much for this excellent talk. I think moving to our next talk, I'd like to welcome Dr. 𝗍𝗂 𝗕𝗲𝗀, who's a radiation oncologist at King Hussein Cancer Center. Dr. 𝗍𝗂 will shed a light on the role the pembro would add in the head and neck cancers.
Thank you, Anam, for your kind introduction. So it's my pleasure to speak to you about subgroup analysis of KEYNOTE-689, where pembrolizumab was added to the current standard of care for resectable, locally advanced head and neck squamous cell carcinoma. Neoadjuvant pembrolizumab followed by adjuvant pembrolizumab given concurrent in combination with adjuvant radiation therapy, with or without cisplatin, based on pathologic features, followed by a single agent, pembrolizumab, has been approved in the United States FDA for adult patients with resectable, locally advanced head and neck SCC with tumors express PD-L1 CPS score greater than or equal to 1 based on results of the phase 3 keynote study 689. In this trial, the presence or absence of high-risk pathological features, namely positive margin of less than 1 millimeter or extranodal extension, inform the use of post-operative cisplatin and inform the use of post-operative adjuvant radiation therapy dose. Today, I am here to present to you the details on post-operative adjuvant therapy in Keynote 689 and to present an exploratory analysis of outcomes based on post-operative pathological features. Patients with stage 3 4A, laryngeal cancer, hypopharyngeal cancer, oral cavity cancer, B16 negative oropharyngeal cancer, and B16 positive stage 3 oropharyngeal cancer with good performance status, and patients who had tissue for PD-L1 staining were included in this study. Then patients were stratified according to the primary tumor site, tumor stage, and PD-L1 status. Then were randomized in 1-to-1 ratio to the current standard of care, which is surgery followed by adjuvant therapy, or to investigational arm to a new adjuvant pembrolizumab for 2 cycles, followed by surgery, followed by adjuvant pembrolizumab concurrent given with radiation therapy plus minus cisplatin for a total of 3 cycles, followed by 12 cycles of pembrolizumab. The primary endpoint in this trial is event-free survival per RECIST 1.1, and this trial had central radiological review. And the secondary endpoints were, the first one is major pathological response. Also, they had central pathological review for pathological slides, and major pathological response was defined as 10% or less residual invasive SCC in resected primary tumor, plus all sampled regional lymph nodes. Other key secondary endpoints were overall survival and safety. So if you look at the treatment characteristics, 363 patients were included in the investigational arm, 351 in the standard of care arm. Both arms had well balanced in terms of PD-L1 CPS score, whether it was 10 or more or 1 or more in both arms. In the new adjuvant therapy part of this trial, 99% of patients in the investigational arm were able to receive at least 1 dose or more of pembrolizumab. In the standard of care arm, 2 patients incidentally received pembrolizumab, and this was reported as major deviation in this trial. In the study of surgery, approximately 89% in both arms underwent surgical resection, while in the investigational arm, 15.2% permanently discontinued all study therapy at this phase, while in the standard of care arm, 11.7% discontinued all study therapy at this phase. The data cutoff was 25 July 2024. Median follow-up was 38.3 months. So if you look at the reasons for surgery not performed in both groups, so this is the surgical trial. You can see that in the investigational arm, 4.1% had disease progression and 1.1% had adverse events to pembrolizumab. And in both arms, 8 patients did not undergo surgical resection and they received definitive concomitant chemoradiation therapy. And if you look at the surgical outcomes, you can see that in the investigational arm, more patients had R0 resection, and in the standard of care arm, more patients had incomplete R2 resection. And if you look at the risk group between two arms, you can see that in the investigational arm, 52% had low risk group, while 42% in the standard of care arm had low risk group. While in the standard of care arm, patients had a much higher number of high risk group as compared to the investigational arm. The median pembrolizumab doses given in this investigational arm was 15. And in terms of radiation dose, investigational arm, the median radiation dose was 60 Gray, while in the standard of care arm was 66 Gray. And more patients in the standard of care arm received 3 doses of cisplatin as compared to investigational arm. And if you look at the low risk versus high risk group, all risk group in this study received 6 Gray, while high risk group received 66 Grays. This slide shows event-free survival results by risk subgroup and whether you are a low risk or high risk group. The addition of pembrolizumab to the current standard of care improved event-free survival, and both groups had similar hazard ratio of 0.74, 0.73. Regarding the safety, it's similar to what published in the New England Journal of Medicine. So in conclusions, event-free survival results favored the use of neoadjuvant and adjuvant pembrolizumab across both surgical, high and low risk subgroups, consistent with the primary analysis of the trial. Neoadjuvant and adjuvant pembrolizumab added to standard surgery, and post-operative chemoradiotherapy was associated with fewer participants having high-risk features, fewer participants receiving a high radiation dose and cisplatin. The safety profile of neoadjuvant and adjuvant pembrolizumab added to standard of care was consistent with the prior reports in participants with or without high-risk pathological features. And the take-home message, neoadjuvant pembrolizumab surgery and adjuvant pembrolizumab concurrent with and after post-operative radiation or chemoradiation is considered now as a new standard of care for eligible patients with resectable locally advanced head and neck cancer. And thank you for your attention.
Thank you for this excellent talk. And any questions?
Thank you, Aisha, for the great presentation. So taking this trial into account for cases with early stage who turn to be a locally advanced post-op, would you consider adding pembro concurrently and in the adjuvant settings?
So this trial is designed for locally advanced head and neck cancer, not early stage head and neck cancer.
You face a case where it's turned to be locally advanced post-op.
So you resect the tumor, then surprisingly you find the tumor is locally advanced, not early stage laryngeal cancer. So it's actually is extremely rare because in 2026 we have excellent clinical and radiological examination for evaluation for patients with head and neck cancer. But of a clinical trial, I would not offer these patients adjuvant concurrent pembrolizumab with radiation therapy, the maintenance pembrolizumab. I don't have any justification to add pembro in the adjuvant setting.
May add also, it's unclear here which regimen drives the benefit, whether the neoadjuvant or the adjuvant, because it's set to be delivered in all phases. So I agree with you. It's not sufficient to take away a part of it and apply it to other cases.
Actually, the addition of a new adjuvant pembrolizumab, as shown in this study, so will affect the probability of having positive margin and extracapsular extension. So it's a kind of downstaging for the initial tumor. So in this study, less patients received higher radiation dose, 66 gray, as compared to 60 gray, and lower number of patients received concurrent cisplatin with pembro and radiation therapy.
Thank you very much, Dr.
Thank you.
Issa. I think we'll conclude our session, and we're all excited to go to lunch.
Thank you so much for the moderators as well. So lunch will be served here in Zia, which is right next to us. But because we are running slightly behind of time, so we will start at 2:55. And the reason I say 2:55 because you get additional 5 minutes to get the coffee. 3 p.m. we are starting sharp. People need to travel. So please enjoy lunch. Call whoever left us to go come and eat, and then we'll recharge. Thank you so much. All right, so I promised we'll start at 3 and we'll stick to our promise. It's a very warm welcome to Dr. Sangeeta. Dr. Sangeeta is a consultant radiation oncologist as the head of radiation oncology at SSMC, Sheikh 𝗕𝗲 Medical City, a part of SAHA. She'll be moderating the hematological malignancies updates in radiotherapy. Thank you so much, Dr. Sangeeta.
Thank you, Dr. Ibrahim. So our first speaker for this session would be Dr. Yusra, and Dr. Yusra is a consultant radiation oncologist in𝗓𝗿 Medical City. She has a wide experience, having trained in one of the biggest centers in India in AIMS, and then having a fellowship from Royal Marsden, and now she's here to talk to us about decreasing the dose of consolidation radiotherapy in diffuse large B-cell lymphoma and as a phase 2 trial.
Very warm welcome to all of you. Thank you very much, Dr. Ibrahim, for giving me this opportunity. And I think it's a Herculean task to keep everyone awake now. And I've heard flights are due, so they've asked me to speed it up. So coming to this trial, I'll keep it very short with just the messages. So they basically try to decrease the consolidation dose of radiation in DLBCL. So since the time of training, we know that diffuse large B-cell lymphoma requires something like 30 gray to 40 gray for consolidation. They're bringing it down to 20 gray, that is lower than the low-grade lymphomas. Yeah. Okay, so these were the disclosures. So we know that consolidation has a play in diffuse large B-cell lymphoma, mostly for local control. That 30 gray dose was standardized and established in the pre-rituximab era. Now, this trial was started because there was a phase 2 study from Duke's University where they had just 60 patients who they gave only 20 gray for consolidation in DLBCL and a 10-year local control of 98%. So this motivated the ILRO group to go ahead and do a large trial studying these set of patients. So patients above 18, stage 1 to 4 DLBCL, which was 85% of the patients, or other high-grade B-cell lymphomas, they received CHOP-based chemotherapy, and the response assessment was PET-CT scan-based. The primary mediastinal B-cell lymphomas were not included. Now, this was the dose that they used. So 19.5 to 20 gray in 1.5 to 2 gray. And the primary endpoint was 5-year freedom from local recurrence. So they had 240 odd patients, median age 65 years. DLBCL was around 85% of this group, with the bad cytogenetics being 9%. Majority, of course, was stage 1 and 2, bulky disease being 30%. Now, most of them received the conventional chemo, the R-CHOP or the R-EPOCH, and radiation was mostly IMRT. Response assessment was based on PET-CT scan. Now, the statistical analysis for this is they assumed that if there were less than 9 recurrences in this entire cohort, it was assumed to be a good outcome. And if there were more than 19 recurrences, it was supposed to be a bad outcome. So you see that there was a total of 16 relapses, although their primary endpoint was in local recurrence only, and there were only 4 local recurrences in this entire cohort of 240 patients. So if you look at the failure from local recurrence, at 3 years, it was around 98%, and even at 5 years, it was around 97.4%. And the PFS and OS matched that of what we used to get at the time we had 30 gray and 40 gray. So they concluded that reducing the dose of consolidation radiation from 30 to 20 gray did not compromise the local control. It was a heterogeneous in risk factors, with the bulky disease being around 32%, and the prognostic factor, the IPI score of more than 2 was more than 50%, and 9% had the bad cytogenetics. Now, the limitation of this trial is that it is phase 2, and they concluded that the phase 3 non-inferiority study was deemed impractical due to the required patient numbers. So just to add like 2 words from my side, it is very interesting to note that the 2026 NCCN guidelines have been modified based on this trial. It's phase 2 and the papers are not out yet. But if you look at the NCCN guidelines of 2026, you will see that a complete response for DLBCL after 6 cycles of R-CHOP chemotherapy, the dose has come down to 20 gray. And they don't even give the option of adding 30 to 36 gray, what we were used to. So this is a drastic change from 2025 to now. Now, I also had the opportunity to attend the ILROG conference last week. So the same group that studied this, so I spoke to a few of the authors. And regarding the extranodal sites, so we know only for nodal, so we do not know if this is applicable to the extranodal site. So this is my first question. Can we use it if this is for extranodal DLBCL? The second question is any of them taking it into clinical practice yet? The answer is no. So this is, although this is now the only option in NCCN guidelines from 2026, it's probably still not ready to be used in clinic till the paper is published. So these were their acknowledgement, and that's it. Thank you. I finished in 5 minutes.
So thank you, Dr. Yusra, for keeping up with time as
No
well
problem.
as giving us a very intellectual talk about this. Any questions from the audience? I have no questions either. Dr. Ibrahim's just taken the mic.
Thank you so much, Dr. Yusra, for this excellent talk and nice conclusion also from your end. So telling me more about the, so today, as of now, we follow the guidelines, and the guidelines should have quickly adopted this.
Yes.
Despite that,
Yes.
even their own authors. So today in clinic, what's your preferred regimen? When you're seeing these patients who meet this criteria, are you still giving, because we're giving higher doses for Hodgkin lymphoma, and now we are de-escalating. So your thoughts about this, specifically now with the new eras of radiation techniques and all the technologies that you can use?
I mean, I think this is the right time probably to discuss this option with the patients. But I think it's mostly patient-based discussion. And this is why I had this query during the ILROG conference. If Dr. 𝗿𝗱, she was one of the authors, I spoke to her. So she said that probably we will take it for very few selected patients where we give radiation to sensitive areas of bulk. But if it's a very safe area to treat, we'd probably still stick to our 30 grade till the whole paper is out. So yes, yeah. Yes, Dr. Fala. Okay, so the primary mediastinal B-cell lymphomas were excluded. So they are not included in this at all. So for that mediastinal group, we still stick to our old dose of 30 to 40 gray. I mean, 30 gray in setting of complete response. So they were excluded from this.
Thank you, Dr. Yusra.
Thank you.
So our next speaker for this afternoon would be Dr. 𝗲𝗏𝗄𝗏 𝗔𝗦𝗧𝗥𝗢. And Dr. 𝗲𝗏𝗏 is a radiation oncologist in King Fahd Specialist Hospital with wide knowledge and expertise, having trained in Canada. She has a fellowship in breast and lymphoma oncology, and this is her home territory, talking to us about lymphoma trial.
Thank you, Dr. Sangeeta, for this kind introduction. Thank you, Dr. Ibrahim, for inviting us. It's my pleasure to present this abstract that may address an important radiation oncology question and have an outcome, a favorable outcome on the patient's prognosis. This phase 1/2 trial is discussing about repriming radiation therapy for relapse refractory non-Hodgkin's lymphoma after having an incomplete response to CAR T-cell therapy. Which way? Green one? That doesn't work. This one? Oh, okay. Sorry about that. Okay. So patients who have relapsed refractory non-Hodgkin's lymphoma that are treated with CAR T-cell therapy, the CD19 CAR T-cell therapy directed to these PET-avid disease, usually 40% only achieve complete response by day 30. Okay, and of those who do not achieve a complete response, there is 70% of patients who would still fail. And this provides a good clinical question whether providing those patients with radiation, would it help in repriming CAR T again with radiotherapy? There is preclinical and early clinical studies that suggest that there is a potential synergy between the mechanism of action of radiation and combining it with CAR-T. There are also some retrospective clinical data that suggest that consolidative radiation to the PET-avid disease on day 30 post-CAR-T may alter the pattern of relapse and improve the local control and progression-free survival in these patients. And hence the clinical trial was done. The goal was to look at radiation therapy after CAR T cell to improve the outcomes in those patients who are likely to fail CAR T cell alone. And the hypothesis behind that is that giving an early salvage focal radiation to the sites of incomplete response on day 30 after doing the PET scan post-CAR T cell is safe. This is the phase 1 trial, and it will eventually improve the conversion to complete response from the historical percentage of 30% to double its percentage, which is reaching up to 60% in the phase 2 trial. So they're reporting their preliminary results of the phase 1/2 trial here. So defining the incomplete response, this would be Deauville-4 criteria. And basically, for their phase 1 trial, they have enrolled 6 patients who have taken the definitive radiation doses. And what they noticed that there was no grade 3 or more dose-limiting toxicity related to radiation. And hence, further phase 2 trials were done. And what they used was a hypofractionated regimen between 5 to 10 fractions that were equivalent to conventional doses of either 40 to 50 gray, or if there was a requirement to decrease the dose, they were equivalent to 20 to 32.5 in EQD2 formula. And basically, the objective is to focus the radiation to the sites of PET-avid disease post-CAR T cell on the day 30 of PET scan, and this would minimize the lymphopenia and would result in a more favorable immune microenvironment. So if you look at the pathway, so patients are having, biopsy-proven relapse refractory non-Hodgkin's lymphoma. They get infused with CAR T, and then their PET CT on day 30. If they had a complete response, which is usually achievable in 40% of the patients, they just go for observation. But if they had a partial response, which is seen in about 60% of the patients, then radiation is given to the sites of the residual disease. If there were more than 5 sites of residual disease, then treating the sites would be at the discretion of the radiation oncologist. Mostly pick up the symptomatic sites and the sites that are bulky. The primary endpoint of this study was to look at the overall metabolic complete response on day 90. Some of the secondary endpoints were looking at the rates of complete response, partial response, stable disease, progressive disease, and overall response rate, and looking at the progression-free survival and the overall survival at 1 year. Some of their exploratory objectives is also looking at the interaction between the CAR T cell and the radiation, further knowing the biology behind its mechanism of action. So in terms of results, 14 patients were enrolled in this trial over 3 years. Most of these patients had diffuse large B-cell lymphoma. A few of them were transformed from low-grade lymphomas. And 57% of these patients who had primary refractory diffuse large B-cell lymphomas, they had a median of 2 or more lines prior to getting CAR T-cell. So out of these patients, 6 of them had only single sites of residual PET-avid disease on day 30. 5 of them had 2 sites, and the remainder had more than 3 sites. And this is the distribution of the 27 sites that were radiated. If you look at the dose fractionation, they were given either 30 in 5 or 36 in 10. The results, so the first thing is the safety of this technique. It was pretty safe. There was no grade 3 or more dose-limiting toxicity related to radiation, and majority of the toxicities were level grade 1, ranging from nausea, vomiting, alopecia, pneumonitis, and some skin toxicity. And the primary outcome is that the metabolic complete response was achieved in about 50% of these patients. So 7 out of 14 of these patients did achieve a complete metabolic response. Out of these 7, let's say about 5 of them, they still continue to be disease-free at 1 year. So that's a very good percentage, all right? And if you notice that patients who had fewer numbers of residual disease at day 30 actually did better than the patients who had more disease, obviously. The local progression-free survival at 1 year is about 67%. The overall progression-free survival is 36%, and the overall survival is about 57%. This is a case example. This is a 60-year-old male patient who was treated for stage 4 diffuse large B-cell lymphoma with R-CHOP and had a chemorefractory disease. He was then treated with CAR-T. And on day 30, if you notice post-CAR T, there was still residual right external iliac lymph node. So giving them, salvaging them with radiation, it did end up by having a complete response on day 90. So in conclusion, this is a good exploratory phase 1/2 trial that is looking at early salvage definitive dose radiation to the sites of incomplete response on day 30 post-CAR-T PET-CT for the relapsed refractory non-Hodgkin's lymphoma. It did show that there was a safety and there is about 50% of conversion to metabolic complete response. Though their trial did not actually meet the pre-specified hypothesis of doubling this percentage, but we do understand that if we give some focal radiation to some limited sites of residual disease, this may be a good strategy to for selected patients, especially if they had 1 to 2 sites of residual FDG-avid disease. And obviously, we will still need some future studies to understand the biology and synergy between radiation and CAR-T. Thank you.
Dr. Thakri, any questions from the audience?
So thank you so much, Dr. Ali, for this great talk. So in your opinion, where are we in now CAR-T is really becoming more and more involved even in an earlier stage. As a lymphoma radiation therapy expert, what is your intake on that? Like when is the prime time in your clinic today in incorporating radiotherapy with CAR-T?
So we're still doing it in our center for practice. We're doing it as a bridging therapy. So bridging pre-CAR-T. We haven't reached to this level. I think this is probably the first trial that is looking into that. And definitely, I don't think we've had any case discussions or referral from the hematologist again after they were infused with CAR-T. Bridging, yes, we've done, and this is what we're doing up until now.
Those bridging, because I had one case actually. I
Yeah.
emailed Dr. 𝗿𝗱 from MD Anderson just to get her input on this. It was a very large disease, and it was like really next to the kidney, and it was a paravertebral mass that they were salvaging. Is it one of those diseases that we don't treat the entire volume? Because she's like,
Yes.
the kid, so because we are used as radiation oncologists, we just treat the whole GTV and then add a CTV.
That
So
is
so
how
it
you
was
treat
very
it.
intriguing to me. Is like, leave part of the tumor. It's fine. Don't treat it.
True.
Just be aware of the patient's kidneys. This is what she advised me because she needs every single nephron for her
Absolutely.
chemo. So tell us more about this, because still it's kind of the concept for us as radiation oncologists. We used to contour the whole tumor and treat the whole tumor, and
Yeah.
then in this setting, we are treating part of the tumor.
It makes sense because obviously what you're trying to do is palliate symptoms, try to control it before it starts progressing, as long as the patient is waiting for the infusion. So in this sense, it makes, you probably may treat a partial volume just so that patient is, controlled symptomatically. Rather than treating him, to the full tumor and compromising and adding the toxicity, because we do want to give a good dose. We usually give like 30 and 10. That's usually my dose range that we give. So definitely, taking into account that the patient is still going to go for further, systemic therapy or infusion, and there may be toxicity, it's okay probably to limit, as long as, if the patient has a really bulky residual mass. Thank you.
And next we have Dr.𝗶𝗿 𝗕𝗲𝗀, who is a consultant and head of radiation oncology at Advanced Care Oncology Center in Dubai. He's well experienced, and with his wide knowledge, he's going to be here to talk to us about pembrolizumab and ISRT as an alternative to transplant.
Okay, thank you. First of all, I would like to thank Prof. Hamid and my friend Dr. Ibrahim and the organizers for this invitation. Actually, I have the opportunity to share with you this prospective multicenter phase 2 study about pembrolizumab and involved site radiation therapy as an alternative to transplant in patients with localized failure following first-line therapy for Hodgkin lymphoma. Historically, the first treatment in case of recurrence or refractory disease, Hodgkin lymphoma, usually we are going for high-dose chemotherapy and autologous stem cell transplantation, with giving us a cure rate of about 75%. but the problem is coming with significant morbidity and mortality, which represent sometimes another treatment for the patient. With the arrival of new drugs such as brentuximab and immune checkpoint inhibitors, they have demonstrated some efficacy regarding this kind of tumors, and they open the door for new concept what's called transplant sparing approaches. So using these new drugs, by this idea, we know that Pembro, there is effect of Pembro regarding, in case of Hodgkin lymphoma. We know also the effect of radiation. Now came the question about using both of them, Pembro plus radiotherapy, so we may benefit from the synergistic potential effect of both therapeutic options. So the question raised by this study, can PD-L1 inhibitors supported by localized radiation provide an alternative to high-dose chemotherapy followed by stem cell transplant in patient with localized failure following first-line therapy of Hodgkin lymphoma? This is the main question raised by this study. This is a phase 2 multicentric study. The inclusion criteria is about stage 1 to A Hodgkin lymphoma with non-bulky disease, local relapse or after chemotherapy only, or combined modality therapy. The primary outcome is complete response after Pembro ISRT. The secondary outcome, response to single agent Pembro, 2 years progression-free survival and toxicity. Also, there was an exploratory outcomes. Actually, this is the protocol of the study. So the patient will do baseline PET CT scan. He will start with pembrolizumab 200 milligram every 3 weeks for 4 cycles. Then patient will do PET CT simulation in case of Deauville 1 to 3. That means take complete metabolic response. He will complete by 20 gray of radiotherapy only. In case of Deauville 4 to 5, it will consider as responded to the protocol or responded to Pembro. Then patient will do biopsy. If negative, he will receive 30 gray of radiotherapy. In case of positive biopsy, the dose of radiation will be 36 to 40 gray. In case of Deauville 5, these are progression of the disease. Here also will do biopsy. If the biopsy will come negative, patient will receive consolidated radiotherapy by 36 to 40 gray. If the biopsy is positive, the patient will be excluded from the study. These are the patient. Number of patients is 22 patients. The median age is 36 years. So almost 50% male and 50% females. Most of the cases were stage 2 Hodgkin lymphoma. Most of them relapsed after either chemotherapy alone or radiation alone, but we have also 36% of the patient refractory to chemotherapy alone. The common regimen of chemotherapy is ABVT. Now about the result. So finally, we got 22 patients. 1 patient progressed after receiving Pembro, so this patient is excluded from the trial. Then 21 patients completed the protocol of 4 cycles Pembro. They did their PET CT scan. Sorry. So they found that there is 7 patients. That means 32% of the patient got complete metabolic response to 4 cycles of Pembro. This patient received 20 gray of radiotherapy, but unfortunately, 2 of them relapsed again. 10 patients, so 45%, got PET CT post Pembro Deauville 4 to 5. Biopsy was negative for 3 cases. This patient received 30 gray of radiotherapy, did not got any relapse. The 1 positive biopsy, 32%, they received more dose of radiation, which was 36 to 40 gray, and there was only 1 relapse among this category of patient. 18% of the patient had PET CT post Pembro Deauville 5, and this patient got positive biopsy, then excluded from the study. So the objective response rate from Pembro alone was 77%, and the complete metabolic response was 32%, and by adding involved site radiotherapy, the objective rate increased to 94%, and the complete metabolic response to 94%. With median follow-up of 35 months, the PFS at 2 years overall was 61%, and it was 80% at 2 years among patients who received radiotherapy. In comparison between patients who got refractory disease and the relapse, so obviously the one who got relapsed had the best PFS comparing to the case of refractory disease. Just to note that the cases who got relapse after this protocol, they had the chance to have another salvage therapy, which different according based on the situation. About toxicity, overall, this protocol was well tolerated with minimal grade 3 toxicity. So to summarize, Pembro with ICRT yield excellent complete response rate and minimal toxicity, suggests that Pembro and radiation or other immune radiotherapy combination as potential attractive alternative to high-dose chemotherapy and stem cell transplant in localized favorable recurrent or refractory disease. Additional follow-up and longer cohort may help inform similar transplant-sparing approaches. Finally, the authors did some criticism and some conclusions. The future direction and remaining question about the timing of radiotherapy, about also the dose, because we got that most of the failure came with the group who received 20 gray only. Also, the question about if there is other type of immunotherapy that we can combine to radiation. Are we able now to use this study as in our practice? The authors suggest that the patients who are not a candidate for more intensive systemic therapy due to comorbidities and poor PFS, they may benefit from this kind of treatment. Patients who not want more aggressive therapy also can benefit. In case of relapse-only cases, because we saw that for refractory, the benefit is minimal, and patients with certain genetic molecular features in the exploratory outcome analysis may benefit from such kind of combined treatment. Thank you very much for your attention.
Thank you, Dr. Ismail. I had a question, but you've answered it in the Q&A session. I was thinking about the 20 gray dose. Was it too low for this? And of course, the other one was about patient selection. Are you in a position to implement this for selected patients? And how would you, I know the patients who are not fit for, stem cell therapy would be your target population. What about patients who are not otherwise, they want to avoid stem cell therapy? Would this be an option for them at all, or would you steer away from it at this point?
Well, actually speaking, like the authors concluded their study, we can use it as guiding, just to guide us. Of course, if we have to select cases, we have to avoid the refractory disease. It's clear. You mentioned that the outcome is bad. For the recurrent cases, I think we should not use 20 gray, because it's clear, obvious that the patient with complete metabolic response who received 20 gray, they got more local recurrence compared to other scenarios. So if I will use it, I can use it for selected cases who are not candidate for stem cell. But sure, I will not use 20 gray. I will use more 30 to 36 or more, even 40 gray.
That's interesting, because on the other, the higher risk group, they did use 30 gray in one of the arms. Would you prefer to use something higher than 30 gray for the DEVIL 1 to 3?
Well, actually speaking, the number of patients in the study is very limited. So we cannot use exactly this protocol because if the other arm is number of 4 or 5 patients. So we cannot take this number as guide for us. But what we know usually that in general, in oncology in general, we know that recurrent disease is more aggressive than the initial disease. So obviously for recurrent disease, we have to take care more than we cannot use the de-escalation in the situation of recurrent or relapse disease.
Thank you. Any questions from the audience? Thank you.
Okay, so it gives me great pleasure to introduce the moderators for the next session, which is going to be lung cancer session and thoracic. We'd like to call on the stage both Dr. Eater and Dr. Faiz. Dr. Eater was introduced earlier, but it's given me a great pleasure and honor to introduce my dear friend, Dr. Faiz. Dr. Faiz is a consultant radiation oncologist. He's accomplished a lot of things during his career. He's currently serves as the clinical director at the Oncology Center at the Armed Forces Hospitals, Southern region of Saudi, and the clinical director of oncology services in the Ministry of Health of Saudi Arabia. He's also the vice chairman of the Oncology Network of the Radiation Oncology Consultant at King Faisal Medical City. And Dr. Eater, of course, needs no introduction. She's a very well-established CMO and the clinical director and the Astro ambassador to Georgia to moderate the lung cancer and thoracic malignancy session. Please join me to welcome them.
Thank you so much for the nice introduction, and thank you for the invitation. It gives me great pleasure to introduce Dr. Ahmed Abu Shehri. Dr. Ahmed Abu Shehri is a consultant radiation oncologist who completed his training, the residency training program and fellowship at Princess Margaret Hospital, Toronto. He will be speaking today about the comprehensive patient-reported outcome from the NRG-LU005 randomized clinical trial of concurrent chemoradiation plus minus atezolizumab in limited stage small cell lung cancer trial. The floor is yours, Dr. Ahmed. Thank you.
Jazakum Allah bil khair. Good afternoon, everyone. It's my pleasure to be amongst all of you today, and thank you, Dr. Ibrahim, for the invitation and for the well-organized event. In the next few minutes, I'll be talking about the patient-reported outcomes from this NRG trial, a randomized trial of chemoradiation plus minus atezolizumab in limited stage small cell lung cancer. So this is the schema of the original trial. So it's included patient with limited stage lung cancer with the good performance 0 to 2 with 1 pre-registration cycle of chemotherapy, and then they are randomized to either the standard, which is chemotherapy for another 3 cycles plus thoracic radiation 45 gray given BID or 66 gray daily, with the other arm just adding atezo concurrently and in the adjuvant settings up to 1 year. So this is the conclusion of the NRG trial, that there is no benefit of adding atezo in the overall survival. And they were looked, and then on further analysis, when they looked at the radiation schedule, this is exploratory analysis, and they found there could be a benefit of BID fractionation compared to once daily fractionation. So the objective of this patient-reported outcome trial is to analyze if the patient-reported outcomes, and then the pre-specified PRO's hypothesis is clinically meaningful decline in long-term PROs at 15 plus months after chemoradiation would be lower with immunotherapy as measured by validated functional assessment of cancer therapy, a trial outcome index FACT-TOI. So the PRO's instrument used in this trial are the FACT-TOI. They used EQ5D5L for the quality adjusted survival, the QAS, and PROMISE trial, and each administered at baseline, end of chemoradiation at 3, 6, 15, and 21 months post chemoradiotherapy. So CMD in FACT-TOI was defined as equal or more than 5-point decline from baseline. The QoS was estimated using EQ5DL 5-day index scores and restricted mean survival. CMD and longitudinal trend were evaluated on the multivariate analysis, adjusted to treatment arms, certification factor, and baseline factor TOI. So the compliance was more than 85% at baseline, stabilized at 60 to 68% through 21 months after chemoradiation. Higher PRO completion rate correlated with better baseline performance status and good pulmonary function. So the FACT-TOI decline on both arms
and this is expected during chemoradiation, but improved by 3 months and remained stable or exceeded baseline by 6 to 21 months. So it is similar in both arms. And while the factor I changes from baseline were similar at 15 months on both arms, there are fewer patients had better CMD in the immuno arm, 25 versus 37.8% at 21 months. Again, in terms of the QoS, the other instrument used in the trial, it is both similar in the atezo versus non-immunotherapy arm, and again, in PROMISE, it's both similar in both arms. Looking into what is interesting is the radiation schedule, that 52.8% of all patients received BID radiation, which was associated with better quality of life than single daily fractionation radiation across all time points, and it is noticed here. And again, when they looked at the CMD, the percentage rates of CMD is better in the BID fractionation at the time of end of chemoradiotherapy and maintained even at 15 and 20 months post treatment. So on multivariant analysis, significant predictors of lower CMDs in addition to baseline factor, what is noticed is the BID fractionation at the end of chemoradiation, 15 and 21 months, when the patient took cisplatin at 15 months and with immunotherapy at 21 months. So to conclude, as hypothesized in the study that the addition of atezo to chemoradiation was associated with a clinically meaningful improvement in long-term quality of life based on this instrument, the factor II, as well as similar quality adjusted survival with no negative impact on fatigue. This is the hypothesis. So to their knowledge that they're while satisfied but not randomized for radiation schedule, this is the first large clinical trial to report that the BID versus daily fractionation was associated with not only improved median overall survival, but also to more favorable PRIs from the patient perspectives and with significantly lower clinically meaningful decline in the factor I multivariant analysis. So conducted in the context of modern radiation, more than 90% IMRT used in this trial. This analysis helped to address lingering concerns about BID radiation impact on the quality of life and provide further support for using twice daily fractionation in limited stage small cell lung cancer directly from the patient perspective. And this is good to hear from patient voices that the BID fractionation outcomes are good from the patient perspective. And thank you.
Thank you so much. Do we have any questions here? I have a question, Dr. Ahmed. So what do you do like currently in your practice? Do you offer the BID fractionation or the one daily fraction for limited
so
stage?
the standard is using the BID fractionation, but sometimes we have some logistics with a number of patients on the machine, so we had to use the single daily fractionation, but the standard, our protocol is BID fractionation.
And does anyone in the room treats with single fraction?
Does the size of the tumor or residual tumor has impact on what you use as a twice daily or single fractionation?
You mean in terms of response or?
No, it's the size of the tumor originally. You give it concomitant, right?
Yes, yes. No, like we don't take this, like if it's, we decided if it's BID, we'll go ahead with the BID. We don't take this like the size of the tumor or response into account.
Actually, most of the patients, they respond with the first cycle of chemotherapy. That's why nowadays we tend to start the radiation treatment with the first cycle of chemotherapy. Doctor.
Thank you, Dr. Ahmed. My question is, when you treat with BID, are you escalating the dose like the THORA trial up to 60 gray for select patients, or you're still sticking to the 45 gray total dose?
Some cases we do, but the regular is the 45. But sometimes we consider escalating the dose.
We have a question. Go ahead.
Well, we have been performing this MD Anderson regimen 1.8 to the IGTV and 1.5 to the PTV in the last 10 years, and it's not really increasing the, I mean, in routine, and it's not really increasing the toxicity in comparison to other patients. And in these 3 weeks, the treatments are completed without any major side effects. So even with additional chemotherapy, there is no real increased side effects that you can think of. So if you're doing it in a 4-dimensional CT setting with IGRT and IMRT, it should be really very non-toxic and overall very favorable at the end.
Right, thank you.
Okay, as we have no other questions in the audience, let me introduce our next speaker. You already met 𝗔𝗬𝗧𝗥. So he's very well-established radiation oncologist from Turkey, India, and he's honored to be ASTRO ambassador and ASTRO fellow as well.
Thank you very much. Great to be on stage again. I'll be talking on the 10-year outcomes of the revised STARS trial, comparing SABRE and surgery for early-stage non-small cell lung cancer. In the background, as you know, it has been debated for years whether the early-stage disease can be treated with SBRT alone, and there are a couple of trials, but none has a long-term follow-up. So in this background, the initial discussion started with the Lancet Oncology pooled analysis of STARS and ROSAL, which defined basically a higher overall survival SABRE based on the postoperative complications in the surgery arm. And there are ongoing trials like VALOR, STABLE-MATES, and SWORD from Washington University, which were not reported yet. So we don't know the long-term comparison. So on this background, this study from MD Anderson is a very important trial to give us a long-term outcome and quality of life. So basically, this is a single-arm trial, which is enrolling patients based on the STARS trial, and they have treated the patients with SABRE in 3 fractions if these lesions are peripheral lesions, and in 4 fractions if these lesions are central lesions. And they have registered in a prospective single institution observational cohort of video-assisted thoracic surgery, lobectomy, and mediastinal lymph node dissection group. So this is not a real prospective trial and randomization, but they are comparing a single arm with their institutional surgery patients. So 80 patients enrolled from the SABRE trial were matched with the 80 patients from the surgical cohort. And these patients are all patients with small tumors, 3 centimeters or less, all histologically confirmed, and the performance status is 0 to 2. And basically in the SABRE arm, all patients had endobronchial ultrasound and biopsy for the mediastinal disease to ensure that they are clinically N0, but in surgery arm, it's not mandatory. And all these patients were operable patients. So they also investigated the long-term quality of life and financial toxicity in both groups. So they used the health questionnaire and cost questionnaire in order to understand the current status. When we look at the patient characteristics, they are matched cohorts, so there's no real difference between them based on the age, sex, performance status, and histology, and the tumor size. and the median follow-up was 8.3 years. So it's a really good interval to define the details in both arms. And the important detail in the patient characteristics is lying in the EBUS defined clinical N0 disease in SABRE arm, but in the surgery arm, initially, although they are clinically N0, only 25% at EBUS. So this revealed 6% pathologic N1 disease and 5% pathologic N2 disease in the surgical arm, which after the surgery required adjuvant chemotherapy in 8 of them and adjuvant chemoradiation in 3 of them. Overall, the grade 3 pulmonary and cardiovascular acute toxicity is almost none in SABRE arm, it's 1%, but in the surgery arm, which is basically a cutting-edge surgery, WATS and mediastinal lymph node dissection, 50%. So it's grade 3 pulmonary and cardiovascular acute toxicity is 50% in the surgery arm. So the overall survival is the same. 69% for SABRE, 66% for the surgery. And when we look at the lung cancer specific survival, it's also the same at 10 years, 92% for SABRE and 89% for the surgery. When we look at the recurrence-free survival, it's 57 for SABRE and 65% at 10 years for surgery. And when you look at the first 3 years, you can easily see that I cannot use a pointer here, but in the first 3 years, it looks like that the SABRE arm has more recurrences. So that's important to look into details of the first instance of recurrence. And it looks like that the local regional recurrence in the SABRE arm is a bit more in comparison to the surgery. 2 local and regional, and 5 regional only. So they had a good salvage afterwards. So even though there's a recurrence, among these 9 patients with local regional recurrence, 5 underwent salvage chemoradiation, 3 treated with salvage surgery, 1 treated with salvage SABRE, and among 2 patients with local regional recurrence in surgery arm, they are treated with salvage chemoradiation and 1 with palliative systemic therapy. So overall, the overall survival at the end was not different in both arms. When we look at the questionnaires, almost 1/3 of these patients responded and they replied the pro-health and cost questionnaire. And it looks like that the physical component score is the same, mental component score is the same at 10 years. Surgery seems to be a little bit expensive in comparison to SABRE, but it's not statistically significant. So take-home points in this trial is through 10 years of follow-up, there was no significant difference between SABRE and WATS for overall survival, cancer-specific survival, and recurrence-free survival. And although recurrence rates are numerically higher for patients treated with SABRE alone in comparison to surgery, they could be effectively salvaged. And although a higher toxicity results from surgical resection compared to SABRE for this early stage non-small cell lung cancer patients, the impacts of lung cancer treatment on long-term quality of life and financial stress seems not to differ significantly. So overall, SABRE remains an option in this group of patients for operable stage 1 non-small cell lung cancer, and multidisciplinary discussion is strongly recommended in this group of patients. And I'd like to thank the MD Anderson team to put forward a trial like this, which we can easily use in our multidisciplinary discussion basis. Thank you.
Thank you for a great talk. So do you have any questions in the floor?
Thank you, Dr. Salik, for the presentation. My question, you mentioned the peripheral and central, but how about ultracentral? Were they included in the or not?
I believe there's no ultracentral in this one because MD Anderson regimen is mainly 50 gray in 4 fractions in central lesions, but for ultracentral lesions, they prefer 10 fractions. So none of them were included in this trial. And they try to select these patients based on that they can match with the operative group. So for that reason, there's no ultracentral lesions as far as I know. But of course, we need to be waiting for the published manuscript to see that.
But this was a phase 2 trial, right? It was not 3.
No, it was a single-arm trial.
Okay.
It was basically 80 patients treated with SABR in MD Anderson. So they prospectively chose patients from surgery, surgical series, which are matching properly with this group. So they performed a propensity score matched analysis. It's not a randomized trial.
Thank you.
Thank you.
I have a question here. So nowadays, with integrating immunotherapy for early stage non-small cell lung cancer, do you think this will strengthen the role of SBRT in early stage non-small cell lung cancer?
Well, until now, as far as I know, there's no data to back up immunotherapy following stereotactic body radiation treatment for these kind of tumors. And one of the fact is most of those patients were patients who could not undergo surgery and inoperable cases. And I'm not aware of any completed trial, including these operable patients. But that can be a way, but that maybe perhaps we can use circulating DNA in this group of patients if we can define positive circulating DNA, let's say, in 1.5 months after the treatment of SABR. That might be a group to use immunotherapy. But probably if we use immunotherapy to all of them, we would probably be failing and it will be a negative trial.
Right, right. And I think, like quick comment regarding your question, there are 2 clinical trials are recruiting patients nowadays. The VALOR clinical trial and the StableMates. The VALOR, they recruited 100 patients so far, and their target is 600 patients, but I think they will never meet the target. And the same with the StableMates, and it is a head-to-head trial comparing SBRT to surgery. The second question regarding the surgery, nowadays there is a trend more towards like less invasive and less surgery. For example, they used to recommend lobectomy and they went down to sublobar resection and now segmentectomy. Where do you see like the radiation treatment compared to the these 3 different surgical approaches?
Well, it has been shown in the last lung cancer meeting, in IALC, that the segmental resection is very comparable to the lobectomy. So for this group of tumors less than 3 centimeters, they are probably one of the leading surgical approach in coming years. But overall, when they perform that, they are also doing mediastinal lymph node dissection. So that's the positive side of all those patients. And as you can see here, if we are not doing EBAs to all of these patients initially, even though they are clinical N0, we might have 11% of patients which have N1 positive or N2 positive disease at the end. So I wish the surgeons would probably be sending their operable patients for our clinics, but it's not the case. If it's an operable case and if they are doing minimal invasive surgery, less than lobectomy, those patients would probably be receiving surgery. So it's very difficult to compare both, but I agree that the surgery would probably be not lobectomy, but less segmental resection if it is not a central lesion.
Right. Thank you so much. Any other questions? Okay, thank you, Prof. We will move to our next speaker, Dr. Bassam Youssef. Dr. Bassam Youssef is an associate professor of clinical radiation oncology at the American University of Beirut Medical Center. He will be talking today, inshallah, about the sequential chemoimmunotherapy plus optimized thoracic radiation versus standard thoracic radiotherapy for elderly and or frail stage 3 non-small cell lung cancer patients. The floor is yours. Thank you.
Thank you. Good afternoon. I know it's almost 4 p.m. and we're a bit late on schedule, so I'll try to be fast in my presentation. So as a background, we know that for stage 3 non-small cell lung cancer, We have multiple options, but if we really focus on patients with unresectable disease, we know that nowadays the standard of care for patients with good performance status is definitive concurrent chemoradiotherapy, and for those who don't have any disease progression post-chemorad, consolidation with durvalumab for 1 year is the standard of care. Now, if we look at the patients who are not candidate for the standard concurrent chemorad, the second option would be sequential chemoradiotherapy. And then for those who cannot really tolerate any chemotherapy, definitive radiotherapy alone can be used with definitely less optimal outcomes. Now, if we look at the NCCN guidelines, version 7, 2025, it's practically the same thing. Definitive concurrent chemoradiation is category 1, followed by either durvalumab for 1 year, or followed by osimertinib for patients according to the Pacific and LAURA trial, patients with EGFR mutations. Now, we know that most patients, most randomized trial, they really enroll patients who are younger, fitter, with a median age of 57 to 64 years, with good performance status 0 to 1. And we also know that in the real world, most of the patients are elderly with a poorer performance status and who can sometimes not tolerate the standard concurrent chemorad. So there's an unmet need for these patients. So what are the options for these patients with poor performance status slash elderly? We know that an option can be durvalumab plus radiotherapy as per the Dolphin trial. We also know that sequential chemotherapy followed by radiation therapy plus durvalumab can be another option as per the Pacific 6 trial. And we have some ongoing trials also looking at other options for frail patients. Now, so the rationale for this radiotherapy dose reduction study came from the Pacific trial when they looked at the outcomes of patients according to the dose of radiotherapy that they received, less than 60, 60, 66, or even more than 66. And they thought that radiotherapy dose may not affect the survival benefit from durvalumab, which inspired the current study. So when we look at the experimental study, the authors looked at the option of using sequential chemoimmunotherapy to be followed by immunotherapy with concurrent radiotherapy as the arm A, versus those with decreased or those de-escalated radiotherapy 250 gray, which is arm B. So this is the study design. Most patients were vulnerable patients who had unresectable stage 3 lung cancer. They received 4 to 6 cycles of chemoimmunotherapy, and those who had complete response, partial response, or stable disease, they were randomized to either radiotherapy with concurrent immunotherapy to a dose of 60 and 30, which is the standard dose, or to the reduced dose, 50 gray and 25 fractions with concurrent immunotherapy, and this was followed by maintenance immunotherapy for 6 months. The primary endpoint was 1 year progression-free survival. The secondary endpoints included the 1 year overall survival and toxicities, grade 3 or higher acute toxicities. A brief look at the inclusion criteria. Most patients had a performance status of 2 or were elderly as defined as more than or equal to 70 years with a performance status of 0 to 1. And also it included patients who were older than 65 years with a CCI index more than or equal to 1. So eventually 66 patients were enrolled. Down the road, 56 patients were randomized. And per ITT analysis, there were 56 patients. Per protocol, 27 patients were randomized to radiotherapy, dose reduced, and 26 were randomized to standard dose radiotherapy. When we look at the baseline characteristics, it was a well-balanced trial. The median age was 68 years. 90% of the patients were male. Pathologies were 73% squamous cell carcinoma, with PD-L1 more than 50% in 23% of the patients. Most of the patients eventually received 4 cycles of neoadjuvant chemoimmunotherapy, and around 89% received an anti-PD-1. Most common comorbidities were hypertension. About a third of the patients had hypertension, 32% COPD, and cerebrovascular diseases, 1/5 of the patients. When we look at the efficacy as per protocol, 1-year PFS was 82% in the standard arm versus 73.4% in the reduced arm. Same, not statistically significant. The same was for 1-year overall survival, 92 versus 84% with a p-value of 0.26. When they looked at the efficacy as per ITT, the 1-year PFS was 84% versus 70%. Again, not statistically significantly different. Same for overall survival, 92% versus 85%. Now, when they looked at the pattern of recurrence, a total of 26 patients experienced disease progression. There were more loco-regional progressions in the reduced radiotherapy arm, 39% versus 21%. So numerically, it's a big difference. But again, the p-value was not statistically significant. The duration of immunotherapy maintenance was 6 months for 57% of the patients who they completed 6 months, and then 38% of the patients completed 1-year total maintenance immunotherapy. 28 patients discontinued immunotherapy due to toxicity, with the most common reason being pneumonitis or radiation pneumonitis, which was quite significant, 75% of the patients. What about treatment toxicities? The overall grade 3 incidence of toxicity was 57% in the reduced arm versus 82% in the standard arm. Again, not statistically significant, but numerically quite high. The limitation were that this is a single arm design study with no direct comparison between the standard dose and the reduced dose thoracic RT groups. It was a small sample size, and there were mixed immunotherapy and chemotherapy regimens in this trial. The take-home points: sequential chemoimmunotherapy with concurrent radiation and immunotherapy maintenance is effective in elderly/frail, locally advanced non-small cell lung cancer. Reduced thoracic radiotherapy did not significantly comprise survival and showed a trend toward fewer severe adverse events. This approach needs future validation and larger multi-center trials. And with this, I thank you for your attention.
Thank you. Any questions? So if you allow me, I have a quick question. So for elderly and frail patients, sometimes we treat them with mild hypofractionated radiation treatment, for example, 45/15 or 15/20 with concurrent chemotherapy, and they do very well with excellent local control. Do you think if this arm was, instead of using the standard fractionation, looking at the BED, if we do the hypofractionated approach along with concurrent chemotherapy and using immunotherapy, will affect the outcome of the trial?
So thank you for the question. So I would agree with you that when using radiotherapy alone, using hypofractionated regimens published makes sense, and those ranges were between 45 gray to 60 gray given in 3 gray per fraction. We are really cautious with the use of concurrent chemotherapy when we use hypofractionated radiotherapy, and we have not been doing it really in practice. So in this trial of theirs, it's an experimental thing for sure. They used immunotherapy concurrent with radiotherapy, which really does not make a lot of sense after the publication of the Pacific-2 trial. That was a randomized phase 3 trial, and it showed that adding immunotherapy concurrently to radiotherapy did not really improve outcomes as compared to sequentially after chemoradiation. So in my practice nowadays, yes, when I use radiotherapy alone for frail and elderly patients, I try to use hypofractionated radiation, as I said.
Not with chemo, though.
Sometimes we use single agent carboplatin, but we use it with standard fractionated radiotherapy, not with hypofractionated radiation. I leave the decision to the medical oncologist.
Right. Because in head and neck, we have, Dr. Saif agrees, we have a phase 3 trial looking at hypofractionated radiation treatment with cisplatin for frail or for like old patients, and they do very well. And we did that many times with like 45/15 or 50/20, and they also do very well. They tolerate the treatment. So I was just thinking if we
Well,
compare
we're,
this?
we're not
like,
doing that.
No,
in,
no, no.
in lung, we're not doing
Okay,
that.
sure.
Any other questions?
Professor Siddiq, do you have any input regarding hypofractionation with concurrent chemo or any experience here?
Well, we had only a couple of patients, which, and in those patients, we had to treat them in that 3 weeks because they're coming from abroad, and we didn't want to treat them with radiation alone. And basically, we have a long run hypofractionation experience, including 45 gray and 52.5 gray in 15 fractions. So most of these patients are not having a real difficult esophagitis. So it looks like that if you are really leaning on sparing the esophagus and trying to keep the not V20 but V16 gray in the limits, they can easily be managed with concurrent chemotherapy. But overall, because there is no data for concurrent hypofractionated plus chemotherapy, we lean on still with 30-day concurrent chemoradiation. But I believe that it can easily be managed, and most of these patients would probably be feeling better in 3 weeks. And there is basically a concurrent chemoradiation UK trial, which was 50 gray, so 55 gray in 20 fractions with concurrent chemo. And it looks like that it is a smooth and non-toxic trial, but you know, there is no real data that we can go ahead and do in routine.
Thank you. I think we are living in a very interesting era for radiation oncology. Just like a short comment, Mohammed Abu Zaid at Northwestern University is leading now the clinical trial where they are modifying and teaching artificial intelligence to calculate what would be the best dose fractionation for each biological type of the lung cancer. So I'm excited to wait till these results in future. So I think we don't have any more comments in the room, and we can proceed with the next session.
Thank you very
Thank
much.
you.
Okay, everyone, we will start with the next session. I believe we're behind on schedule, so there will not be a coffee break from what I was told. So this will be the B9 session, and so I'll hand it over to Dr. Thoraya to introduce our first speaker.
So we will welcome Dr. Sangeeta as the first speaker. Oh, okay. Hello, Dr. Sangeeta. So, sorry, I cannot see from there. Sorry, Dr. Sangeeta. So, Dr. Sangeeta is a radiation oncologist who specializes in stereotactic body radiotherapy. She did her fellowship in the Royal College of Radiologists in the UK, and she is currently working in 𝗔𝗦𝗧𝗥𝗢 Medical Center, right? Okay, welcome, Dr. Sangeeta. Please.
Thank you, Dr. Thoraya. So I'm glad to be shifting gears a little bit from oncological indications to non-oncological indications for radiotherapy, which is all the talk recently. So today I'll be speaking about the results of the DEPART trial, or at least part of the results of the DEPART trial. And these are the disclosures of the authors and the investigators. So the DEPART trial was done to evaluate the outcomes in patients treated with radiation for Dupuytren's disease. And this this presentation is about the 3-year secondary endpoint analysis. So to give a bit of background, we have all seen patients with Dupuytren's disease, which is a common fibroproliferative condition. It's more common in the Caucasian population, more so in the Northern European descent. And some cases progress significantly to functional impairment. And this is a picture that we've all somewhat at some point seen. And what is interesting about this and what it lends to for preventative radiotherapy is there's almost a prodrome type phase where there is nodularity, which then progresses to contractures and functional limitation. So there is actually a window of opportunity to treat this with an intent to reduce progression and disability. And that's what this trial is focusing on. So if we look at the trial design, they picked up patients with progressive early stage disease. And by that, it means that people who have had some progressive symptoms over the preceding year before randomization. Patients could have had a contracture of up to 10 degrees, but no more than that. And of course, patients over the age of 30 were eligible to be enrolled in this trial. And they were then randomized into the observation arm or into the treatment arm. There's also another aspect to this trial, which was in the adjuvant setting after the patients have had some intervention for the contractures, but that is not reported at present because that would, I think, be reported as a next analysis with the primary endpoints. So in arm 2, patients were recommended 30 Gray in 10 fractions, which was given in 2 phases of 15 Gray in 5 fractions over 1 week. And they were allowed between 4 to 12 week break in between the 2 phases of treatment. And this comes from differences in practice between UK and Northern Europe, where RCR gives usually a typical recommendation of a 4-week break, and DEGRO recommends a 12-week break. So they allowed for both within this trial. Primary endpoint was a time to definitive intervention or more than a 20-degree increase in contracture. But we're not talking about that today. We're talking about the secondary endpoint, which is the medium-term toxicity and patient-reported quality of life. So potential radiotherapy toxicities as anticipated, which was looked at, was arthralgia, dry skin, reduced sweating, radiation dermatitis, induration, edema, skin atrophy, what we would anticipate, nothing unusual from that. And they were scored using the CTCAE toxicity scores at baseline, at the end of radiation, about 30 days post-radiation, and 6 monthly for the first year, and then annually, taking it up to a 9-year follow-up. For patient-reported quality of life tools, they use 3 different tools, the Quick Dash, URAM, and visual analog scores. I'll just talk quickly about these 3 tools that they used. The Quick Dash is used for rheumatological situations, and it is more of upper limb type symptoms. So it's not very exclusive to just the hand alone, which would be the issue in Dupuytren's. But it is a 11-point score with 5 different levels of severity. So you can have a score potentially from 11 to 55. The URAM score, however, it looks like it's more specific for hand-related dysfunction. And that is a 9-point score with a scale of 0 to 5, giving you a possible score from 0 to 45. And the visual analog score does not need any introduction, actually. So the secondary endpoints of patient-reported quality of life measures was reported as baseline and then less frequently thereafter. So at 6 months, 12 months, and then just at 36 months. So this analysis is talking only of the analysis at 36 months. And if we follow the patients with regards to their short-term and medium-term toxicities, anticipated type of toxicities, radiation dermatitis, but we can see that, again, as anticipated, it is more prevalent in the post-radiotherapy time, and then it disappears quite quickly with nothing lasting beyond a year. Hypohidrosis was also similar, low-grade toxicities, no high-grade toxicities, and slight persistence, but just in about 4%, which is about one patient, lasting up to three years. Fatigue, again, low-grade toxicities, not lasting long enough. Edema, similar pattern. So it seems to be very well tolerated in terms of short and medium-term toxicities. Now, moving on to the 3-year patient-reported quality of life measures, with the quick dash score, as I explained before, the range is from 11 to 55, and at baseline, patients were well matched with the scores evenly matched. But if we look at 12 months after that, we see that the patients who did not receive radiation, their score actually deteriorated, meaning their symptoms were progressive, whereas in the radiotherapy arm, the symptoms were actually improving, albeit slightly from baseline. And those are the p-values for that. Similar pattern with the URAM scores as well. They start diverging around 12 months with deterioration in the standard arm and improvement or stabilization in the experimental arm. Similar pattern for the visual analog pain score as well. So what are the takeaways from this? I would say is we can see that low-dose radiotherapy for Dupuytren's disease is well tolerated, anticipated side effects, nothing unusual, and resolving within the anticipated time frame. And patient-reported quality of outcome looks like it's improved, although you can argue on one hand whether this is maybe the placebo effect, which, if patients receive radiotherapy, you may anticipate that their scoring is different, but we have to take it in comparison with the deterioration of the scores in the observation arm. So perhaps at least it is stabilizing. That's how we can interpret it in, I feel. So this is all short-term follow-up. Let's wait and see what the long-term results show, particularly with regards to late toxicities and how those are affected by radiotherapy. And in conclusion, the authors say that this is very refreshing to have a multi-center randomized control trial for a benign condition, which is very, very important before we establish it as routine practice.
Thank you, Dr. Sanjeet. Any question? I have a quick question. So can we offer it upfront or after surgery? Like salvage treatment if the surgery fails?
So this trial is looking at both. So they have picked up the patients before there is established contracture, so just less than 10 degrees of contracture. And in the randomization, just prior to randomization, there's one group which only had the contracture, and there's another group where they offered it to patients as so-called adjuvant treatment. So after they had had some tendon release or procedure for preventing further fibro proliferation. So almost like a keloid type situation. So both have been looked at, but this report of this results is only for the first part of it, which is just as a primary treatment rather than as an adjuvant. So I think it will be interesting when they do the next analysis and report the primary outcome measures. Perhaps that will answer the question whether there can be limited surgery or, and then can be done as an adjuvant treatment.
Thank you very much. We would like to move on to the next speaker. My colleague and friend, Dr. Ahmed Boushehri, who is a consultant radiation oncologist from the Kuwait Cancer Control Center, will be talking to us about a very interesting topic, stereotactic arrhythmia radiotherapy, 3 years outcome.
So hello again. So I'll be talking about this interesting and challenging, and not sure if it's done here in the region, is SBRT is using stereotactic arrhythmia radiotherapy STAR versus repeat catheter ablation for high-risk refractory ventricular tachycardia. This is a 3-year safety and efficacy outcome. This was presented by PGY3 Shannon Jiang from University of Washington. So The objectives of the trial is to compare the relative safety profile of stereotactic arrhythmia radiotherapy STAR and repeat catheter ablation in patients with high-risk refractory ventricular tachycardia, and evaluate the efficacy of STAR versus repeat catheter ablation in achieving ventricular arrhythmia control. So we know that the ventricular tachycardia is a life-threatening arrhythmia associated with significant morbidity and mortality, and the standard VT treatment with the first-line antiarrhythmic drugs, and then followed by placement of cardiac device, and then ablation, and then you try with ablation. But the management of refractory is a bit challenging because of the physical and psychological distress on the patient, as well as the impaired of the cardiac function impact. So just a background on the catheter ablation. This is an invasive procedure with a very high risk early post-catheter ablation death. So if you can notice that if you have a high pain risk score, you have a high early mortality rate. And if you can see that also with the high risk refractory VT, you have a worse VT control and survival, and especially in the high risk patients. So how to treat these patients? So then they came up with this idea is using a stereotactic radiation as a novel non-invasive treatment modality for these refractory VT. There are multiple retrospective studies were done, like from 2019 up to 2023, but this was but there was no data directly comparing STAR with the catheter ablation. So the method, it was a retrospective single institution cohort study with all patients with recurrent VT refractory to medical management who failed the prior catheter ablation or medically unfit, post-STAR or repeat catheter ablation from 2015 to 2018. And then they looked into the safety, the treatment-related serious adverse events, efficacy, and then they looked at both, which is the overall survival. So this is just the workflow of the STAR, how they moved on with the trial. They selected the patient, and they discussed these cases with the cardiologist, and then they did the cardiac mapping and the cardiac imaging and the EP mapping, and they determined the potential VT circuits. And then they moved on with the radiation process from imaging to simulation, segmentation, planning, and the treatment execution. They use here single 25 gray. So this is just the baseline characteristics, and you can see here that the age is, you have more elderly patient in the STAR arm, and also you have a higher risk patient in the STAR arm, 14 versus 11 patients in the catheter ablation. Also, you have a high pain score in the STAR arm, which increase the procedure mortality. So when they looked at the safety, I'll go through them. So I'll go through the catheter ablation in the next slide, but you can see here that at the treatment adverse event at 1 year is 38% in the catheter ablation versus 9% in the STAR, and the median time for any adverse event in the STAR arm is about 10 months. So nothing happened prior to 2.5 months. You have pericarditis, one patient at about 2 to 3 months, and then at 7 months you have one case with pericardial effusion. When they looked at the catheter ablation, the median time to any adverse event is 6 days. So you have atrioventricular block just at the time of the procedure, at the same day. Day 1, you have infection. Day 2, you have also respiratory failure and intubation, as well as 2 cases with infection. Day 8, you have more infection, and the day 18, you have multi-organ failure. When they followed this patient closely, 2 patients died from respiratory failure at 6 and 9 days after the adverse event incidence. 2 patients died from infection at 14 and 16 days, and 1 patient did not survive the procedure. In terms of STAR, there was no death attributed to the adverse event. In terms of efficacy, there's equivalent in both in the catheter ablation and STAR. And when they looked at both in terms of safety and efficacy, we can see they're almost like at 3 years, it's the same 45% in both arms. So in summary, in terms of the safety profile, the patient treated with catheter ablation experienced more treatment adverse event which tended to occur earlier and were closely followed by patient death, suggested a potentially safer early post-treatment course for STAR versus catheter ablation. Similar efficacy in both arms, they're equivalent in terms of the cardiac control. So the data support the use of STAR as potentially safer and equivalently effective treatment option for high-risk patient with refractory VT. And thank you.
Thank you so much for this interesting topic. I guess, again, a quick poll, a show of hands. Who here has experience using stereotactic radiotherapy for arrhythmias? Anyone? No? Not in human. Okay. No, in human. Interesting. So you can maybe share some of that experience. Anyone has any question? Okay, I have a question.
I want to share the experience, Basim.
Oh yes, please go ahead.
And just we can just talk about it quickly. That was probably 8 years ago when we started using SBRT on the AV node in an animal model. We published that in JAHA. We had 100%. So what we did as a proof of concept, we wanted to hit the AV node and try to stop completely the conduction through the AV node. So we implanted pacemaker on the animals, and eventually we had a 100% block. But I don't have any human experience, human treatment experience.
I think it would be a great idea if we can have a workshop in the Gulf or regional area here where we can learn how to do this, because I feel maybe all of us are scared to start this treatment. But okay, Ibrahim, so it's next task, inshallah. Prof. Hamid, maybe, yeah.
And I completely concur with that. It's not a impossible technique, but it is a difficult technique to start because the way they use the image. Did they describe the dose fractionation?
Single 25 gray.
Single 25. So it is quite of a strong dose in a very functioning and motion, continuous motion organ. So thank you so much for this talk. So I'd like to move to the last speaker for this session, Dr. 𝗲𝗲 𝗕𝗲, who's a consultant radiation oncologist in King Salman bin Abdulaziz Medical City in Medina al-Munawwara, who will be talking about one of the more anticipated talks, the single course low dose radiation for knee osteoarthritis.
Thank you, Dr. Saif. I think Dr. Al-Bishri makes the doses very high now. We will go down to low dose radiation therapy. Thank you, Prof. Hamid, Dr. Ibrahim, for inviting me. Today we will talk about, I will be presenting the short-term result of Lord Knee trial, a randomized sham control study evaluating the clinical effectiveness of single course of low dose radiation therapy with the patient knee osteoarthritis. This study came from South Korea. This one. Thank you. So, pain is a dominant phenomenon, whether it comes from simple condition or serious illness. Knee osteoarthritis representing a major and growing clinical problem, particularly in the aging population. There is a persisting gap between the conservative management such as physiotherapy and analgesic and surgical intervention. Many patients remain symptomatic, but are they unfit to for the surgery or unwilling to proceed it. Low-dose radiation therapy is an non-invasive and anti-inflammatory treatment. Option has been used for decades in some European countries such as Germany. However, high-quality randomized evidence remained limited, and optimal dose regime is still unclear. This study aimed to address this gap by evaluating the integration of low-dose radiation therapy into the standard care, testing an optimal single-course dose regime under controlled analgesic to use minimum bias in pain control outcome. So, this protocol included two experimental groups comparing against a sham control. 114 patients were assigned to in three groups. Group A received a total dose of 0.3 gray, 6 fraction in 3 weeks. Group B received 3 gray, and Group C received sham radiation. They included here 0.05 per fraction. This is the first group as an experimental arm based on the report from the German orthorad. Because in the German orthorad, they explain they had similar effect to the dose 0.5 gray. A patient eligible here was, sorry. A patient eligible here was 50 to 85 years old with primary knee osteoarthritis, Kilgren-Downes grade 2 or 3. They excluded all the patients with grade 4, no narcotic analgesic, only paracetamol was allowed, no re-radiation or second course. The primary endpoint was the Urasi response at the 4 months. For reference, the WOMAC score is widely used, 24-item instrument assigning pain, stiffness, and physical function in osteoarthritis. A patient was defined an Urasi responder if the one of the following criteria was met. Major improvement in WOMAC pain or function, 50% or more improvement, and absolute change of 20 point, or a moderate improvement, a 20% improvement, and absolute change of 10 points at least 2 of the 3 domains: WOMAC pain, WOMAC function, and patient global assessment. In the ITT population, 114 patients was enrolled, randomly assigned to the group A to C, approximately 75% women, and a mean age is 68.1 years old, and mean BMI of 25.1. And here they excluded also all the patients with BMI more than 35. Baseline characteristics was balanced with no significant difference among the 3 groups. So this is the important slide. At the 1 month, the response rate were similar across all groups, reflecting a strong placebo effect in the sham group. However, at the 4 month, the response rate were 58.3 in the group with the 0.3 gray, and 70.3 gray, and 70.3 in the group with 3 gray, and the placebo group 41.7. The 3 gray group demonstrate a significant high response rate compared to the sham group. The difference was 28.6 with a p-value of 0.014. which remained significant after stratify the adjustment. In contrast, 0.3 did not differ significantly from the sham group. WOMAC total score improvement was evaluated as a secondary endpoint defined as 16-point reduction from the baseline. At the 1 month, improvement rate was similar across all groups. However, at the 4 month, the 3 groups showed a highly significant improvement rate compared with the sham radiation, while no significant benefit was observed in the 0.3 group. For the other secondary endpoint, all groups showed modest improvement in VAS and in WOMAC subscale pain, stiffness, and function up to the 4 month without significant difference between groups. VAS score decreased approximately 15 to 20 points across all groups, with no significant difference were observed in the serum inflammatory marker CAP or ESR or in reduced medication use. All patients complete the assigned treatment and no treatment related toxicity was observed. About 4% discontinued the trial due to uncontrolled pain and were not included in the 4 months evaluation. This study has several limitations. The sample size was small and limited to AGN population. The index, only the index of knee was treated and evaluated, while contralateral knee pain may be influenced assessment in bilateral cases. Long-term follow-up based in evaluation is needed. Conclusion, a single course of 3 gray, 6 fraction low-dose radiation therapy led to a significant clinical benefit in patients with mild to moderate knee osteoarthritis, while 0.3 did not. With medication control and single course design, this study provides object evidence for efficacy of low-dose radiation therapy. Thank you very much.
Thank you very much. Another interesting topic. And then again, I'd like to ask and poll the audience who has experience treating this population. So again, not many.
We treat PVNS, which is the pigmented villonodular synovitis of the knee, up to like 30 or 36 gray. But I guess this is something to explore for the osteoarthritis.
Yeah.
Please,
yeah,
yes.
I have been using this protocol for the PVNS many years, for nearly 20 years or even more. When I was at Tawam, I used 6 gray, either 24 hours before surgery or 24 hours after surgery. And I prefer before surgery because you can see your, you have to put it well rather than post-surgery. And I have many, maybe 20 patients over the years. And they do very well. You don't need the second treatment. Recently, of course, they start using lutetium and so on, so you can add that later on if they recur. Usually we don't do it in the first time, we do it when it recurs. Not as adjuvant, but when it recurs second time, we do it.
Any questions for Dr. Thamer? Okay. Thank you so much, Dr. Thamer. I think this concludes our session for benign diseases. Thank you very much.
So thank you so much. We'll go to the last session, definitely not the least. I hope you guys are still awake for discussion of the metastatic and oligometastatic cancer. Dr. Faiz apologized, he had to travel. So it'll be great to introduce again Dr. Mohammed Isa, with Dr. Isa Muhammad. He is the consultant radiation oncologist at Sheikh Hussein Cancer Center, very active in research. He'll be moderating the last talk. Thank you.
So I would like to welcome you in the metastatic and oligometastatic disease session. We have 3 presentations. We will start with Dr. Tang without any further delay. So he will be speaking on the addition of metastatic directed therapy to standard of care, primary aggregate analysis, and immunologic correlatives of the phase 3 of the phase 2 randomized extended trial. Please, Dr. Tang, the floor is yours.
Okay, thank you, everybody. Saving the best for last. So, yeah, I know.
Yeah.
So yes, this study ran over a while ago. In fact, Dr. Ibrahim Abugida, he actually enrolled some patients on this study back when he was at MD Anderson. So, my pleasure to talk about metastatic therapy across a couple different histologies. And my resident presented this at Astro. Here's his disclosures. So the Extend is a basket trial, and what it looked at was the benefit of metastatic therapy on top of standard of care systemic therapy in several different histologies. We looked at pancreas, prostate, breast, kidney, and a catch-all other basket. So we are presenting here an aggregate analysis across all the different histologies. We're also going to look at a pre-specified aggregate analysis if we exclude the prostate patients, because they're a little bit different endpoints. And then we're also going to present for the first time the baskets, the kidney basket and the multi-histology baskets, not previously published. So for the methods, Extend enrolled patients with up to 5 sites of metastatic disease. And as a basket trial, it was powered to detect the difference in progression-free survival within each basket. It uses standard phase 2 calculations. So you had a 0.1 power with a one-sided log rank test, with 80% power to detect an alpha of 0.1. And we pre-specified not only to look at each basket individually, but also in aggregate. Furthermore, we had a number of exploratory endpoints we looked at, and we're presenting here the exploratory endpoints looking at the immune correlatives, especially the TCR sequencing data. So Extend was a multi-site study. We mostly enrolled in MD Anderson, but we had participation across a number of sites, across a number of states in the MD Anderson network, all listed here. This is the diagram here showing the enrollment. We assessed 500 patients for eligibility. We randomized 350 patients across different baskets. 175 had metastatic therapy plus standard of care versus 175 who had standard of care. The final per protocol analysis involved about 160 to 168, as a few patients declined radiation, declined participation after randomization. This is the patient demographics across the different histologies. We can see here we had approximately 40 breast, 40 pancreas, a little bit more prostate, so 190 prostates, 40 kidney, other. Most patients had 1 to 2 sites of metastatic disease and had 0 to 1 line of prior systemic therapy. They are also mostly metachronous oligometastatic patients. Here's the details for the metastatic therapy. So most patients received radiation therapy, and this was done usually with SBRT. Some sites, like the lymph nodes, we did more hypofractionated or conventional radiation therapy, but the general modality was SBRT across different sites and across different histologies. So when we combine all baskets, and I think this is the largest of this kind, we found that if we combine them all, the PFS was met with a hazard ratio of 0.54, showing that we improved progression-free survival. And if we pre-specified and analyzed all the baskets minus the 2 prostate baskets, we once again also saw that this also hit our PFS threshold, hazard ratio of 0.6 with a p-value that was also significant. So PFS was improved. Now, there was a lot of crossover. After the patients were on standard of care, they many times crossed over and received metastatic therapy. So there was a little diluting of signal. But what we did see here was there was no significant benefit in overall survival. The hazard ratio was 0.95 and 1.24 when you include and exclude the prostate baskets. But once again, a lot of different confounding here for the OS signal. We looked at the primary kidney basket, and we saw here with a hazard ratio of 1.03. So unfortunately, adding radiation therapy consolidation on top of effective systemic therapy did not benefit the kidney cancer patients. It was not a PFS benefit. If you look at the other histology baskets, which was a mix of colorectal, sarcoma, gynecologic malignancies, we did see a benefit. So PFS was improved when you add MDT across a number of these histologies. So when looking across different histologies, we see, similar to this morning, that breast and kidney did not meet the primary endpoint for PFS, while other baskets like pancreas and prostate met the benefit for PFS. So there's a heterogeneity in terms of what MDT can histologies benefit. If you aggregate across all different baskets, you see a benefit for PFS, and that holds if you remove the prostate baskets. So next, what we looked at was, well, one of the reasons we thought that radiation could be causing a benefit is it induces a favorable immune response. So we had the same time points of peripheral blood draw for all the baskets, baseline and a 3-month follow-up. And what we see is when we add metastatic to therapy, we see a lot of changes in the immune population. And one of the populations that we really wanted to focus on was the CD8, PD1 positive, TK67 population. This was a proliferative population that was not energetic. So it was, we believe, capable of acting. We saw here that the addition of metastatic therapy improved or increased this population significantly at follow-up, while standard of care did not. And we also saw that this population was associated with overall survival. So if you induce this population, which happened more often in radiation, you saw OS benefit. Another indication that we were very keen on was TCR expansion. So TCR expansion is the end product of the immune cascade. So when you have a TCR expansion, that means that clone expanded the population. Each of these different bars is a patient. So you saw on the right side, that's how many clones expanded in that patient's blood at 3 months, and the left side, how many clones contracted. So we see overall, when you have metastatic therapy, on top of standard of care, we see a lot more expansion in those TCR repertoires compared to standard of care alone. However, interestingly, we saw this expansion really only significantly in those baskets that benefited. So we saw in patients who had prostate or pancreas a significant TCR expansion after radiation therapy. And if you look at kidney or breast, which did not have a PFS benefit, there was no significant TCR expansion. Could be actionable possibly in the future. Once again, if you see here on this right side here, there was significant difference in TCR expansion in the prostate and pancreas baskets, but not so much in the kidney and breast baskets. So in conclusion, EXTEND met the primary endpoint of PFS in the aggregate and multiple basket-specific analysis. Histology-specific signals were elucidated. We saw benefit in prostate and pancreas. We did not see a benefit in breast and in kidney. We believe that this design offers really an efficient look across different histologies when you have a phenotype like allelic metastatic disease. And then we also saw that metastatic therapy may alter the immune system in a way that improves outcomes. And then your acknowledgements of the slide, and you put my face up there. So thank you.
Thank you, Dr. Tang. So we have time for one question.
Can I ask?
So, yeah, go ahead.
So do you think like we shouldn't push for SBRT for mets from the breast or the RCC?
Okay, so it's
we
a
shouldn't
really
fight the.
It's an interesting question. You know, when we enroll these patients, if you were like say a 40-year-old woman with one met, they were not getting randomized in this study. They were getting treated off study. And I always told my med-oncs and rad-oncs, like, if we treat these patients who are going to benefit the most, the results are going to show for themselves what's going to happen. And so there's a little bit, it's a little bit hard to say what happens because we did it, even when we rolled the study without studies, we didn't have equipoise in the very best patients. So you have to take that with a grain of salt, I think. So I hope that there's going to be more studies there's going to be subtypes of the benefit, and there's going to be more biomarkers. At ESTRO, we're going to present ctDNA. It's very interesting results for ctDNA.
Dr. Ibrahim.
Thank you, Dr. Tang. Great talk, and congratulations. I think this was a presidential session at ASTRO, so great to have it also here. I have a question. When you are using metastatic directed therapy, my first question is that do you routinely biopsy those sites? And the other thing is that how do you assess response? What's your modality of assessing response? And how quickly after local therapy?
So it depends on histology. A lot of times in prostate cancer, when we're dealing with sclerotic bone lesion, we don't torture the patient to biopsy because we know that the yield is low. Other sites like breast, we do like to biopsy to see if the histology remains consistent when feasible. And sometimes if you can do it, sometimes we can't. Your second question was, sorry.
The best modality.
Response to treatment, because it's different. And how do you assess the treatment response?
Resist mostly, because that's all we have right now. Now in prostate, we have PSA. That's a great assessment tool. If I get a patient at 0 PSA, everybody's happy, giving each other high fives. I think in the future, we're going to need better tools because radiation causes a lot of alterations that are not cancer in the pneumonitis, stuff like that. So I think things like ctDNA, blood biomarkers, they're going to play a big role in the future. And I think we're going to get there in the next 5 to 10 years.
Okay, thank you, Dr. Tang. We will move to the next speaker, Dr.𝗶𝗿 He is consultant radiation oncologist and director of clinical radiation oncology department at Al-Azhar University. He will be speaking on treatment with stereotactic ablative radiotherapy for up to 5 oligometastases in patients with cancer, long-term outcomes of non-randomized phase 2 SABR-5 clinical trial. Please, Dr. Wael, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Thanks a lot, Dr. Isa, for this nice introduction. Thanks a lot, dear Dr. Ibrahim, for this very kind invitation. It's a very good chance to meet all of you. I know it's the end of the day. Maybe I have just one presentation after me and we will finish. I will be very quick to the target. This presentation has been presented in the last ESTRO by Professor Dr. 🗶🗱 𝗕𝗲𝗀. He presented the phase 2 trial. It's a very simple trial. Recruited patients with oligometastatic disease. First of all, oligometastatic disease, we have some data coming to prove efficacy of treating oligometastatic disease with SABR treatment. And the problem is we don't have long-term outcome or long-term follow-up period to be sure that this treatment will affect the survival and either the overall survival or the progression-free survival. We have current needs. I think all the day we have trials discussing the role of SBRT in oligometastatic disease across the different diseases. And still we have the same question, which patient will get the maximum benefit from the SBRT in the metastatic setting, which disease, and how many lesions we should treat. And even the presentation of oligometastatic disease is different. We have patient who coming with synchronous oligometastatic disease, or patient who has induced oligometastatic disease after systemic therapy. Additionally, even we have the patient who treated for oligometastatic disease and kept under treatments and has oligometastatic progression once again. So we have heterogeneity of this disease. So heterogeneity in presentation, in disease type, and even in the other factors. What is SABR-5 trial? SABR-5 trial is phase 2 trial, multi-institutional, very simple trial, just included patients who are eligible for SABR treatment and has oligometastatic disease. The patient treated at this site, actually it's real-world data coming from this trial. Why real-world data? Because they included all the patients who are eligible for SABR treatment, regardless of primary site, regardless the histology, and just choose patient who has 1 to 5 fraction metastatic sites and good performance status ranging between 0 and 2 and more than 6 months expected survival. Otherwise, they treat all the patients treated over the 6 centers with SABR. So it's real world data. The primary endpoint of this trial was toxicity, and this trial has been designed after the SABR-COMET trial to answer the question, do we really have this high toxicity level that noticed in the SABR-COMET trial? Because SABR-COMET trial reported about 30% more than grade 2 toxicity and around 5% mortality coming from treatment. So it was like high toxicity. The secondary endpoint of this trial was to look at the long-term outcome regarding overall survival, progression-free survival, and local control. This trial conducted over 6 regional cancer centers in British Columbia, recruited between 2016 and 2020. And SABR was only offered on trial during this study period. That means no any patient treated with SABR for metastatic disease outside of the trial. So included all the patients. So it's real world data. And it was a population-based trial. Why this analysis is done now? It's looking for the long-term outcome data coming from the SABR-5 trial. The objective is to evaluate the overall survival, progression-free survival, and local control, and also look at the other factors that may affect the outcome among these patients. They use the Kaplan-Meier and the Cox regression analysis for statistics. This trial included 380 patients. Actually, this trial, when designed for the first time, designed to recruit only 200 patients. But after that, they decided at this center not to treat any patient outside of the trial. So they continued the trial until they got another trial to recruit patients. So reached by the total population to 380 patients. The median follow-up period was 4.5 years, and the median age was 69 years. The most common histological type was prostate, colorectal, and prostate cancer. And the most important part here is synchronous metastasis has been recruited in less than 1/4 of these patients, only 24% of the patient. And the most common treated site was the bone, followed by the lung. The majority had 1 to 2 metastatic sites, 90%. And actually, about 70% of the patient was having only 1 metastasis. This is the overall survival results, showing median overall survival around 65 months, and almost 60% of the patient is still alive at 5 years from initiating the trial. On the other hand, these factors affected significantly the outcome. The echo performance status, if the patient has 1 to 2, doing worse. The tumor diameter, as the tumor increase, the outcome decrease. And the colorectal and lung histologies was also associated with a worse overall survival. And surprisingly, the 1 and 2 lesions was doing worse than multiple lesions. And the author of this trial will come to this explaining why this happened. And oligoprogression was also associated with a worse outcome. The median PFS for this trial was 14.6 months, and at 5 years, only 20% kept without disease progression. Again, at multivariate analysis, the echo performance status 1 and 2, tumor diameter high, the non-upfront systemic therapy, oligoprogression were all associated with low PFS. The local control was very good. At 5 years, we had 85% local control. And the main findings of this trial, durable long-term survival and local control of oligometastatic patients treated with SABR. Median overall survival exceeds 5 years in this cohort, and oligoprogression was independent predictive factors. When we come to why patient with 1 to 2 lesions doing worse than the patient who has 3, actually it's radiation oncologist behavior. Like the most of the radiation oncologists after the result of the 𝗔𝗲-𝗕𝗲 trial prefer to treat patient who has low burden disease. And when they treat patient with high burden disease, it shows the patient with very good criteria. So they selected patient with indolent disease, good systemic control, good performance status, and maybe for this reason, the patient with 1 to 2 lesions did worse than patient who has multiple lesions. And actually, there is a coming or ongoing trial, the 𝗔𝗲-𝗕𝗲 trial, include patient who has even more than 5 lesions, between 5 and 10, and trying to confirm what the benefit expected from treating patient with polymetastatic disease. On the other hand, the oligoprogression disease is actually heterogeneous disease. It's not include only the patient who has oligoprogression during systemic therapy, include also patient who has repeat oligoprogression. That means they treated for oligoprogression and they develop once again oligoprogression. So this is likely late line, and this may explain why these patients are doing worse in the real life. On the other hand, we have many limitations. It's a phase 2 trial, just single arm, no control arm reported in this trial, so we cannot compare the 𝗔𝗲 versus no 𝗔𝗲 in this trial. And there is heterogeneity regarding the histology, included all the histological types. And additionally, we need further trials. And actually, I think in a few years, we'll have the result of the randomized phase 3 trials that may answer the question, do we have real benefit for these patients or not? Thank you so lot for your attention.
Thank you, Dr. Wael, for the fantastic presentation. So we have time for one question.
I ask a question.
Yeah, so in your practice, do you treat up to 5 metastases or just you treat just fewer metastases, 1 to 2?
Actually, I treat just fewer metastases because actually treating more than 5 carry risk of complications. This is one. Second, I think the choice of patient is the first, most important part when you are treating patient with oligometastatic disease. I mean, we have multiple players in this situation. The systemic control is one. It's a very important one. Do we have systemic control or not? The behavior of the disease. Do we have indolent disease or highly aggressive disease? So it's a heterogeneous presentation. So it's not just the number of metastases, but when I saw a large number of metastases, I feel I'm dealing likely with aggressive disease. So I wait until I got like oligometastatic disease with systemic therapy and guarantee systemic control, then I go with 𝗔𝗲 treatment.
Thank you, Dr. Wael. So now we will move to the next speaker. Dr. 𝗲𝗿𝗄 𝗕𝗲, an assistant professor at the Department of Radiation Oncology at the American University of Beirut, Lebanon. He will be speaking on predictors of skeletal-related events and the quality of life dimensions among patients with high-risk asymptomatic bone metastasis with or without early radiation therapy. Please, Dr. 𝗲𝗿𝗄, the floor is yours.
Thank you for inviting me to this event. I'm so happy being with you. And my presentation now is very simple. It's the last presentation. It's gonna be fast. So this is about a scenario you probably see every day in your clinic or in your practice, not in the clinic of radiation oncology, in the clinic of a medical oncologist, but in your practice. A patient coming with imaging showing several metastases, multiple metastases, but none of these metastases is symptomatic. And if you want to apply the standard of care, if these lesions don't pose an immediate threat, function threat or life threat, then you can observe or refer back to the medical oncologist for systemic therapy. And this abstract is about checking if treating these lesions with radiotherapy, with early radiotherapy, would add any benefit to the outcome. And the background of this study is another phase 2 randomized controlled trial, which randomized patients to either receive, with multiple bone metastasis, they randomized patients to either early radiotherapy to these lesions or nothing. And there was a clear, as expected, there was a clear decrease in the incidence of skeletal related events at 1 year. It was reduced from 30% to 1.6%. Surprisingly, this phase 2 randomized trial showed an overall survival benefit, and there was no change in the quality of life. And this was the reason for this secondary analysis in this study. So instead of looking at the lesion as a lesion and factors related to the lesion itself, this presentation is trying to identify patient-level factors associated with the risk of skeletal-related events. And because of the global quality of life showed no benefit, they are looking into the dimensions of this quality. So they are breaking down the quality of life components and looking at each one apart. The data collection was done, and they used the EQ5D5L model. Let me explain. EQ stands for European Quality of Life, 5D because it has 5 dimensions: mobility, self-care, usual activity, pain, discomfort, anxiety, and depression. And 5L stands for 5 levels because each of these dimensions has 5 levels. Level 1 means no problem. And these are the results. As you can see, the only factor associated with changes in the skeletal-related events was the use of radiation. So those who favoring the use of radiation in these patients. The other factors were not statistically significant. At the time of the skeletal-related event, none of the 5 dimensions showed a significant, a statistically significant difference or correlation with outcome, except for pain when it was measured to according to BPI, brief pain inventory. And this is the breakdown of the quality of life dimensions. Self-care showed favored the use of radiation early. Let me go to the next slide first. Mobility, usual activity, and pain discomfort. There was a very clear role for a very clear benefit from radiation. And surprisingly, there was anxiety. There was more anxiety in those who received radiation, probably because when you offer radiation to these patients, I don't know what goes into their mind. Maybe they think that my problem is serious. So if you say you don't need, you have 5 spots, but you don't need radiation, maybe they can be more reassured about their condition. So it affected the use of radiation early, affected negatively anxiety and depression in these patients. So from the phase 2 primary study, early radiation reduces skeletal-related events from 30 to 2%. And early radiation may preserve self-care, as you saw in the previous slides, and functional ability compared to observation. The benefit starts, let me show you the slides before the conclusion. As you can see, the benefit starts at 6 months from randomization. So which means that this option of starting radiation early should not be offered to patients whose survival is less than 6 months. And the confirmatory phase 3 randomized controlled trial, NRG CCO14 preempt is ongoing, and they have enrolled 48 patients out of 22 patients so far. We're waiting for the result to start using it as in our practice. Thank you very much.
Thank you, Dr. Tawfiq. Any questions to Dr. Tawfiq? Ibrahim?
Thank you, Dr. Eid, for this great talk. So sometimes, our medical oncologist colleagues, especially when newly diagnosed, let's say ER/PR positive breast cancer with multiple metastases, with metastases on weight-bearing bones, like femoral, that does not require surgical intervention. The cortex is fine. And they send patients are asymptomatic completely, right? No, not even pain, but they have bone disease, including weight-bearing bones. Is the current recommendation practice is to radiate those now upfront, given that consider these are high risk for fracture, and with this data support this, knowing that they have good prognosis usually with ER/PR positive cancer, they respond. They have lots of lines of systemic therapy.
Well, yes, if you have in my practice, if I have a patient coming with a weight-bearing bone, like the hips, even the shoulder, because the shoulder, patients can pull heavy things with their shoulder. So if you have a lesion invading deeply inside the cortex, then yes, I would do something before study. If there is a significant risk for fracture, I would refer first to orthopedics, and then I would consolidate with radiotherapy after surgery. So yes, I'm using it in my practice, especially for weight-bearing areas, for sites that are at risk to do serious complications, like, for example, base of skull near the optic nerves, for example, spinal cord, risk of spinal cord compression. I wouldn't just watch and just wait and watch for these lesions, because you're going to start systemic therapy and you don't know yet how the response would be. So just watching and waiting on these in these scenarios is not. It doesn't make me feel comfortable. Thank you.
Dr. Hikmat?
Thank you. Two things really. First, a question: were those patients optimally treated with the bone resorpting agent, i.e., bisphosphonate or denosumab?
Yes, they were. It was mentioned. Sorry.
The second thing, really, just to answer Ibrahim's question, I mean, all the data that we have in bone and skeletal-related events really was based on old data. Currently, we have the new SERDs and the new ADCs, where those patients were treated with the new SERDs and new ADCs would have a rapid response, so you don't have to wait any months and months to see a response, or be a durable one. But also, if difficult to believe that a patient with impending fracture in the vertebrae or in a bone without much of a symptoms. So in such a cases, when we have the weight-bearing bone lesion, even if it's asymptomatic, we tend to irradiate after we clear that with ortho. Sometimes we end up doing fixation even before the fracture. So the question is, it depends really where the bone lesion is, how bad the bending fracture question, and we tend to irradiate. But again, I mean, I guess this is probably an opportunity for all of us in the region to think about randomizing the patient. Currently, we have a new modalities of treatments, and whatever data exists is not the same that we see in daily practice nowadays.
Okay, let me show you the patients who were the eligibility criteria for this trial. First, it has to be confirmed to be malignant, more than 5 sites, and at least 1, but up to 3 asymptomatic high-risk bone metastasis, bulky disease more than 2 centimeter, disease involving the hip, shoulder, and SI joint, lung bones with up to 2/3 cortical thickness involved, disease in junctional spine like C7, T1, T12, L1, L5, S1, and ECOG KPS more than 50, ECOG 0 to 2, and of course adults. So these are the scenarios where those patients were treated. And I think they covered all the scenarios where the patient is at risk to develop later on, to require later on intervention, whether it is radiation, from radiation oncology or from surgery. So this is it.
Okay, thank you, Dr. Tawfiq. So now I will invite Dr. Ibrahim to deliver his closing remarks.
So thank you so much for all the survivors so far. So this concludes our Best of ASTRO Gulf 2026. This was a collaborative effort done. Before we can just, I want to show you the slides. I promised Dr. Ugur to show you the slides. He's encouraging all the audience residents to get their residents and their staff to participate in this meeting in Turkey. So we can move on. So again, we'd like to thank our really great sponsors who really helped us through this. First, Servier, please, if you can join us. Atlas Medical, please join us. I would like to get Safe join me on the stage because SARO's on it, so you need to be with me on this. And this is of course Atlas with Elekta being part of that. So thank you, Elekta, as well. Brain Lab, please, thank you so much for support. Emitac Health Solutions. Thank you so much. All right, so lastly, thank you so much, everyone, for making all the effort to travel from abroad, to be from different parts of the world, from the US, Canada, Jordan, Lebanon, Saudi, obviously, all Gulf regions. We hope that this conference, Georgia, of course, guys, please join me to thank the team from Georgia for being with us also. Really, thank you so much. And we hope to see you, inshallah, for the following years and lots of events. Shukran. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you.